current methods of DSA measurement are based on solid phase immunoassays. Our approach to DSAs and alternative donor selection is, we measure the pre-transplant DSA. The DSAs are present at an MFI of anything greater than 1,000. I know there's some controversy about these cutoffs, but really anything above 1,000, even with mitigation strategies, you may get graft failure. So we try to avoid the donor to whom there are DSAs. Sometimes that's not an option. If a mismatched donor with DSA is the only option, then you either use mitigation strategies, or that's a situation where you could consider umbilical cord blood transplants, particularly with the newer methods like NICOD or omidubicel, which have better immune reconstitution. So keeping these in mind, when we compare different donor sources in the context of PTCy, because we know PTCy seems to be the best GVHD prophylaxis with all of these donor sources. Back in 2015, Steven Surya and others used CIBMTR data to compare haploidentical transplants using PTCy TAC-MMF and HLA matched transplants with calcineurin inhibitor and methotrexate, and found similar overall survival, and in fact, lower rates of GVHD in the haplos. However, in 2021, when we knew that it's really the PTCy and not the donor source, which is, giving us these good results, we redid the study comparing haploidentical donors using PTCy and fully matched unrelated donors also using PTCy. And as you can see from these curves, there was actually lower overall survival in the haplotransplants in the reduced intensity setting. This was due to higher non-relapse mortality. And in the myeloablative setting, similar overall survival, but more graft versus host disease. There will be updates to these studies in the upcoming year, both at the EBMT meeting and various manuscripts which are in process. But currently, retrospective data does support that if you use PTCy with both donor sources, using a MUD is better than using a haplo if you have access to both. Results from this study from Alberto Musetti replicated the results in ALL and MDS in the lymphoma setting, similar results that haplos than matched donors. Once this lab have been studying the immune reconstitution with haplo PTCy and MUD PTCy. Compared to TAC methotrexate, there's delayed NKB and dendritic cell recovery for a month. The CD4 T-cons and CD8 T cell recovery is delayed for 3 months, while CD4 T-reg recovery is only delayed for 1 month. NKT cells are delayed for at least 1 year. But this delay is similar in both haplo-PTCy and fully matched PTCy. However, if you look a little deeper at the TCR repertoire, the TCR-V beta repertoire, that recovers much more slowly with haplo-PTCy than with matched PTCy. And that may explain the slightly higher infection and morbidity rates that we see with haplotransplants with PTCy. We then looked at comparing fully matched donors with single antigen mismatched donors, both using PTCy. This was a large 10,000 patient study that we recently published in JCO, my colleague Brian Schaefer from Memorial Sloan Kettering. Overall survival and PRIFIS was similar with 7 of 8s and 8 of 8s when PTCy was used. These results were unchanged with or without ATG, which is important because in Europe and I think in many parts of Asia, ATG is used preferentially compared to PTCy, but it did not seem to make a difference in these results. CIBMTR outcome data comparing 7 of 8s to haplos are very similar. So in the absence of a prospective trial, if you do not have a fully matched donor, there's nothing much to choose between a haplo and a 7 of 8. I would just try to choose the youngest donor. This has also been done from the 15 MMUD study compared to a CIBMTR haplo cohort, which showed similar survival numbers. The EBMT also performed this analysis where they actually felt mismatched unrelated donors did a little better than haplos. There was, a lot of heterogeneity in this population, ATG use. So I still think if you have a mismatched unrelated donors and a haplo, you could use either, whoever's faster and cheaper. And then last week, once again in Hawaii, the results of BMT CTN 1702 were reported, which I think is a very important study to put all of this data in context. So this was a study where the NMDP used a donor search prognosis, which is a number which helps you decide whether you're likely to have a matched donor or you're not. So if you were likely to have a matched donor and you proceeded with a matched donor transplant, that was group A. And if you were unlikely, then you proceeded with the alternative donor transplant, or 70% of which were haplos. And as you can see from these curves, there was no significant difference in the incidence of transplant or time to transplant, whether you use the alternative donors or the fully matched donors. And in secondary analysis, even though most of the patients in the matched donor group attack methotrexate, there was not significant difference in survival numbers. So based on all of this, I would say in 2025, a matched sibling donor is still your first choice. Using a donor search prognosis, if you have greater than a 90% chance of finding a HLA matched donor, you should proceed with that donor with PTCy-based prophylaxis. If there's less than 10% chance of finding a HLA matched donor, you should not waste any time and move on without delay to either a haploidentical or a mismatched unrelated donor, once again using PTCy-based prophylaxis. How do you choose between a MMUD and a haplo? There is unlikely to be a randomized study in the near future. So if there are DSAs, avoid that donor. I would prefer a 7 of 8 or a haplo over anything more mismatched than a 7 of 8, even though we do have encouraging results from the ACCESS study. Always choose the youngest donor option within donor groups. It's a plus if they're ABO match, but not a deal breaker. And Litermovir prophylaxis, which once again was really happy to hear that it will be available soon for you to use in India. Cord blood transplants not being used as much, both because of the cost and the slightly poorer outcomes, but there as a backup option. So I'll end with that to thank my colleagues where I work and the NMDP and CIBMTR and patients and families, and thank you for inviting me again. Happy to take questions.
Any questions? Thank you, madam. My son is also in Boston. He has just completed his MS. Thank you. Thank you very much.
The audio's cutting out a little, but.
There are no questions right now. My son is in Boston. He has just completed MS in Boston. Thank you.
Oh, that's great. That's great.
Thank you. So we have next speaker,
Thank you.
Professor Shaji Kumar. Can we have Professor Shaji Kumar on screen? So to introduce our next speaker, Professor Shaji Kumar. Okay. So she'll be joining.
Looks like we're going to have a bit of a change. The next speaker is not yet ready, but we can try to solve the mystery. We'll have our next speaker as Dr. Pajmaja Lokiredi, a distinguished hematologist in Hyderabad. with 16 years of experience in diagnosing and treating blood disorders. She completed her MBBS and MD in internal medicine and advanced qualifications with the MRCP, FRC pathology in hematology and a certificate of completion of training. Her comprehensive education and expertise make her a highly sought after specialist in hematology. Ladies and gentlemen, join me to welcome Dr. Padmaja to take us through this mystery. Welcome, Doctor.
Thank you so much, sir. Thank you for a great introduction. Sorry for the delay. I'm a last-minute filler for this session. Excuse me if it's not up to the mark. I'll try and fulfill the time of ours. So I'm going to discuss on pyrexia of unknown origin. This talk is meant for a lot to the general physicians, and it's a very common topic, and we want to look at a hematological perspective into this common problem. And So I'm going to cover what is PUO, what are the common classifications, common causes, what's the pathophysiology of fevers, what are the common diagnostic tests, and what is the up-to-date new diagnostic test which is included in a part of a PUO screening, and what are the current diagnostic pitfalls which fall into a hematological category. And we'll look at two of the case scenarios with a PUO starting off with, ending in a different manner with illustration towards the end of the journey for a year after the treatment. So classical pyrexia of unknown origin is considered as a temperature more than 38.3 with a duration more than 3 weeks and evaluation of at least 3 outpatient visits or 3 days in hospital. There are multiple etiologies, the commonest being infections, the second being malignancies and collagen vascular disease and other miscellaneous causes. Again, when we're talking about a pyrexia of unknown origin, whether we're talking about 4 different categories of these pyrexia of unknown origin, a classical PUO is someone who comes from the community. There could be a nosocomial where you're hospitalized and then you're having a PUO where your context of investigations are completely different, or if you're an immunocompromised, a neutropenic patient, your prospects are completely different compared to the HIV associated. So what we can see is we're more focusing on the classical side, the infection being the commonest, the second commonest being still a malignancy, followed by collagen vascular disease. And as you can see, the other spectrum of where we have to look through the nosocomial infections, it again varies from where you're practicing for the nosocomial infections. You could be having an MDR infection if you're in India. If you're in UK, most of the nosocomial is a Clostridium difficile where you're on antibiotics and you're having fevers and diarrhea. So again, a pulmonary embolism is a very common anaphlebitis. And somebody with a neutropenic sepsis, we're always talking about a fungal infections, or be it a viral or an MDR sepsis, the most common in our scenarios. And a HIV aspect is completely a PCP versus a CMV and mycobacteria. So this is a pyrexia of unknown origin. If you look at this category numbers, 40% of them are infections. About 15% of patients are with autoimmune disease. A good 25% of PUOs who come from the community are malignancies. And I think it's important for general physicians to start thinking PUO has got 25% of their patients who are presenting with pyrexia of unknown origin do have a malignancy background. And how do patients have a fever? So the hypothalamus in the brain is a thermostatic setting point where you've got an immune response, be it an autoimmune, inflammatory, or malignancy, due to the pyrogenic cytokine release due to macrophages, or a tissue endothelial damage due to the inflammation. You could have a IL-1, IL-2, and a TNF-alpha, which resets the thermostatic path at the hypothalamus and releases the prostaglandin E2, thereby causes a severe vasoconstriction in the periphery and the resetting of this temperature levels in the hypothalamus. And this happens followed by Riga to increase the temperatures to set it up at that level, followed by a drenching sweats to set the temperatures down in order to protect the brain. So this is the standard pathway of how the fever occurs, whatever the reason. you have a cytokine storm for either the exogenic or endogenous pyrogens, which are causing this, be it a bacterial infections or inflammatory, or even in a deep vein thrombosis, you've got a tissue damage, endothelial damage, causing these pyrogens endogenously. So there are lots of fever patterns we talk about in our MD time, but so much so, I don't think it's that much relevant. It's about the context where we're coming from, where we start investigating them further. If we look at a classical PUO in a patients coming from the community, among the infectious diseases, 32% of patients do have a tuberculosis, followed by typhoid, malaria, and bacterial endocarditis, and a brucellosis, not very uncommon. So the TB is still being the top notch among the infections. It is proven in multiple studies the common cause of PUO in the community when they come due to infections is a tuberculosis. And most strikingly, recent evidence shows that the incidence of pulmonary tuberculosis is much less in a PUO patients, more so with a extrapulmonary, either it is a nodal or gastrointestinal or a bony tuberculosis, are much common in these patients. So perhaps that pulmonary TB is much early diagnosed compared to where they're categorizing into a PUO for the nodal tuberculosis. Again, this paper published in 2020, a recent one from North India, again, etiology of pyrexia of origin. Majority of these are tuberculosis, and about a considerable number are lymphomas, followed by adult Still's disease in this study. So looking back, as we see that in this article, they also talk about most of them are a non-tubercular, non-pulmonary tuberculosis, and lots of infectious causes of PUO, wherever there is an abscess, we all know. And most of these abscesses, a lot of times you have symptoms pointing towards that site where you would investigate. Osteomyelitis and prostatitis in our older patients is also another thing, not just in the community, even in our hematological patients. Sometimes you don't know where the recurrent UTIs are coming from. That could be a source from the prostate. One has to look at a semen analysis to look for prostatitis, and also in patients with a myeloma post bone fractures or a surgical sites, ongoing fevers which are masked due to steroids, and sometimes patients can continue to have osteomyelitis at some sites. So other common causes being infectious, tuberculosis, fungal infections, and all these, I don't think I have to go into details of it. Most of you are well aware of these. Coming to malignancies, lymphoma being on the top of the list, the leukemia, myeloma, and at times a myelofibrosis can present, and solid tumors like renal carcinomas, hepatocellular carcinomas can present with. Lymphoma is still being the commonest. I think it's important to think when we have a nodal tuberculosis, a lot of times we don't see an AFB, more of so granulomas. It is important to have that thought process that we're not missing out a tuberculosis. And if those patients are not responding to tuberculosis therapy, within the first 2 months, one has to revisit that rather than continuing the 6 to 9 months therapy without much response. So collagen vascular disease, these are the commonest one. And these are the diagnostic workup for PUO, what we do. The standard comprehensive history taking, physical systemic examination, the standard blood counts, and rest of the biochemistry, urine cultures, blood cultures 3 times, autoimmune screen. Most of these things are done in our routine practice after the initial, initial pyrexia workup, including the auto antibodies for ANA screen, ANA profile, and rheumatoid factors. Once we cross this, what is the next step if we're still not able to have the diagnostic workup for PUO is the PET CT scan, which is a new addition to PUO diagnosis, which is commonly practiced these days when we don't have. And the PET certainly gives you a lot of clues about the nodal etiology, where all the nodes and how do we get a diagnosis. This is how a lot of extrapulmonary nodal tuberculosis are diagnosed these days. So there are several studies showing even a cost analysis. The patients who spend a lot of time without having a diagnosis will actually benefit from, and the PET is not that expensive with the time they spend without having a diagnosis. The additional tests which favor malignancy are also these of the tumor marker type of things, LDH, uric acid, and a high D-dimer. Certainly one has to think about a malignancy or some sort of a blood clots which is thriving this process. And patients in most of the malignancies, patient is having fevers but not looking toxic, otherwise comfortable. And there's also a study talking about using an naproxen. Majority of the patients settle down their fevers. That is quite diagnostic for malignant fevers. And again, a high index of suspicion is very important for these patients. The diagnostic challenge after noting lymphadenopathy is, once you do a PET CT, you found a lymph nodes, which node to biopsy is a $1 million question. Do you want to do a neck node biopsy, which is simple and easy? And a lot of times people want to do FNACs, which is not useful at all. Or we do a neck node biopsy, and PET CT guides you about where is the highest SUV intake. That's the place where you want to do a biopsy to have a highest yield. Sometimes that particular site may not be easy to access, but one has to make those decisions where to biopsy. Whenever you have got a neck node biopsies or a groin node biopsies, they can come reactive. So we tend to prefer axillary node biopsy if you've got one. So generally you don't get any reactive nodes at that site. I think having that index of suspicion to rule out lymphoma is very important. Use a surgical versus interventional radiology service is also important. And one more thing to note, whenever we suspect a lymphoma with a typical pattern, we do not need to do a whole excision of the lymph node when it is a 6 centimeter, 7 centimeter mass, and leave alone a big scar with a wide excisions, like how we do on a solid tumors. It is not warranted in lymphoma as they are extremely chemosensitive. You need a tissue for a biopsy for a diagnostic purpose, not for a therapeutic purpose, as a surgery is not the streamline of treatment in lymphomas. And early referral to oncology, medonc or hemonc to discuss what is the best site to biopsy, and involving a multidisciplinary team will certainly improve the outcomes of the patient. I want to illustrate 2 case scenarios which are real life. This is a 56-year-old lady who presented with fever of 4 weeks duration with a weight loss. The initial investigations, as usual, she had a blood cultures, urine cultures, all the autoimmune screen which showed a 1+ positive. She had a brucella, all the tropical infectious screen, all negative. She has had an abdominal pain at that time, seen a gastro, and followed by a CECT abdomen which showed a lymph nodes. She was suspected to have a malignancy, and the lymph node biopsy showed a reactive in view of, so initial lymph node went on to have a PET CT, which showed a diffuse lymphadenopathy. The initial neck node biopsy was taken, which was reported reactive. That biopsy was sent to a higher centers, to 2 different centers to confirm the diagnosis. All the 3 centers have reported as a reactive node, and she was referred to rheumatology in view of ANA positivity, started on steroids. Initially the fever settled and it recurred back and she was losing weight. That's the stage where they've come for a second opinion. Sometimes revisiting the whole case is very important. When you start looking back, the PET CT shows also liver lesions, which is very unusual for an autoimmune disease. So we started biopsying the liver lesions, which turned out to be a high-grade DLBCL, with a high proliferation index and a double-hit lymphoma. So this lady had a PUO, weight loss, stage 4 nodal disease, and later on the liver biopsy showed a GCB type of a double-hit lymphoma. She had a high-dose chemotherapy. Later, after 3 cycles, there is resolution of liver lesions. Further, she developed a brain mets, and she went on to have a secondary CNS lymphoma. This is her initial PET and the response. So it's important to see, if an oncologist sees this, everybody thinks there's got to be a malignancy. Even if that neck node biopsy has come as a reactive, I would not believe that you would go ahead and do a biopsy in another site, rather than sending the same sample for multiple sites. So that is the importance I want to highlight in this, to have overall view of these cases. Whenever you see unusual patterns, it's important as a physician to recognize what fits in, what doesn't fit in. If it doesn't fit in, you have to reinvestigate. Do not hesitate to put another biopsy, subject the patient to have another biopsy rather than continuing the same treatment. That's the learning point in this, that if we had done a repeat biopsy at the liver, we would have had the biopsy earlier. So this lady went on to have a further chemotherapy, which is high-end chemotherapy, and she had a CAR T-cell therapy later on, and she is now about 10 months. She had a 3 months scan, which is negative, 6 months PET CT negative. So she is a very high-grade, progressive, high-grade lymphoma with the brain lesions. She was rescued with a PET CT, but what I mean to say, I want to illustrate in this case, this is a PUO with the lymph nodes, Initial biopsy showed reactive with some false positive ANAs, but don't get carried away. It's important to look at the images rather than just reading the report and sense that could that fit in with this reactive nature, or do you have to re-challenge her for more tests before you start on just the treatment? So that's a hematological perspective. Lymphoma is one thing which is important to diagnose. And another thing is whenever you have a cytopenias, the high index of suspicion to rule out acute leukemias, especially the time is essence in APML where you have got a 48 hours initial window period, people can have a DIC and sustain major bleeds and go on a ventilator. Once you have a patient in ICU with leukemia, your mortality is almost 50%. So early diagnosis is the key for these kind of patients. The next scenario, what we normally see is a HLH on the cards in sick patients in ICU. The diagnostic criteria is very wide, but it's important to differentiate primary versus secondary. In secondary HLH, we have to treat the secondary cause rather than a chemotherapy in standalone. So it is important in an ICU patient whenever we see some high ferritin and fevers not to jump around and talking about HLH and start looking at what are the secondary causes. Could we treat those secondary causes and this would settle down? Fever, cytopenia, and splenomegaly, raised ferritin, it is very common. If you find 10 ICU patients, you would have a spleen, borderline cytopenia, they're not that severe, and they may have a mild spleen. And if you do a ferritin in all ICU patients, half of them will have an elevated ferritin due to acute phase reactant. So it's important that you have to have additional things and make sure these symptoms are not related to anything else known. So if I give a context of alcoholic liver disease who comes in with a fever, he has got a cytopenia, he has got a fever, he has got a splenomegaly, he will have a high ferritin. So that does not put somebody at a HLH. If suppose that patient develops a dengue, he would have some macrophages. So it's important to put everything in the context, what is there before and what is new.
Sorry to interrupt, ma'am. Just because of lagging of time, we request you to finish it off fast.
So soluble CD25 by flow and macrophage activity in the organs and marrow, poor NK function is important. This is the diagnostic criteria for HLH. I have 2 more slides, not a lot. So these are the diagnostic clinical features, the fever, splenomegaly, hepatomegaly, lymphadenopathy, and the DIC screen, low fibrinogen, high triglycerides, and HLH antibody screen, genetic screen is very important in a primary HLH diagnosis. So that's a pathophysiology. Again, this is the release of inflammatory markers which is causing the fever. This is just the last case scenario projecting a post-COVID. A patient comes with a fever, cytopenia, high ferritin, who is transferred to us with a diagnosis of HLH. And these are his findings, very high D-dimers. This typically at the outset looks like a HLH, and patient was very sick. What is striking is patient had an ultrasound with a normal liver. On examination, patient had a hepatomegaly, which raised the concern, why would somebody develop a huge hepatomegaly within few days and developing a heart failure? We went on to go ahead to triple phase CT scan, which showed no obstructive pathology for his liver failure, but massive hepatomegaly, which come on within over a less than a week period, which realized that could this be a veno-occlusive disease of liver? We did an urgent bone marrow, which showed less than 10% of macrophages. We could not qualify this as a HLH. We did a transjugular liver biopsy to find out. This turned out to be a veno-occlusive disease of liver, which is a complication post-COVID, and patient had initial therapies, supportive therapies, and liver failure, pleural effusions, ascites, low albumin. He's on a best supportive care and a liver transplant list. Patient was started on a defibrotide. These are his liver functions, and the clue for the diagnosis is the liver biopsy, urgent liver biopsy. Within 48 hours, we could turn around to have the diagnosis, and the drug called defibrotide, which is a drug of choice in a veno-occlusive disease, which costs about 2 lakhs. Patient remarkably improved over about a week to 2 weeks period. He has to continue it for 3 weeks. He's come out of all the episodes, and he's doing well. So it's just important. This is another illustration to say this looked like a HLH at the outset, but it's important for a physician to look back on an overall view of the patient rather than just taking the face value. In conclusion, a systematic diagnostic approach, evidence-based practice, keeping on follow-up for any evolution of new findings, and timely involvement of specialists, have a logical thinking to fit in all the symptoms, how they evolve, and a teamwork is always wins. And not, is it a clone or true colors? Everything looks is not the same. Thank you. This is my cat, by the way.
Thank you so much, madam, for navigating all of us through the diagnosis of PUO and its hematological perspective.
Thank you.
Thank you so much.
Thank you.
I think because of lack of time, we won't have any questions session for this lecture. And we will go ahead with next lecture. So we have, next speaker we have Professor Shaji Kumar. He is a professor at Mayo Clinic, Rochester, New York. He will be speaking on emerging role of bispecific antibodies in myeloma management.
Good morning. It's my pleasure
Good morning.
Talk
Welcome.
about the emerging role of bispecific antibodies in the management of multiple myeloma today.
Good morning, sir.
As you know, the treatment...
So very good morning and welcome to Deccan Hematolink 2.0, Hyderabad. I just want to introduce you to our delegates. Professor Shaji Kumar is a consultant. He's a professor and researcher at Mayo Clinic, Rochester, New York, specializing in hematology and oncology. He received his medical degree from All India Institute of Medical Sciences and completed his training in internal medicine, oncology and hematology at Mayo Clinic and Dana-Farber Howard Cancer Institute. He has a special interest and focus in research on multiple myeloma, amyloidosis, and plasma cell disorders. He has more than 500 publications to his credit, and he is also serving on many editorial boards for major journals. So this hall and screen is all yours, sir. We can proceed with your lecture.
of myeloma has evolved rapidly over the past 2 decades with a significant improvement in survival outcomes that have gone along with it. In fact, the survival of patients with myeloma has more than tripled over the past 2 decades. Now, when you think about the treatment approach to myeloma, of course, the initial diagnosis and risk stratification is critical, but the treatment of the the myeloma initially after diagnosis is one of the most important aspect. And we have made great progress here with the routine incorporation of autologous stem cell transplant, use of 4-drug combinations, and continuous maintenance with 1 or 2 drugs depending on the underlying risk. Unfortunately, the patients with myeloma will eventually relapse and they will need additional therapy. The initial relapses are sensitive to a variety of different drugs that we have currently available, including proteasome inhibitors, immunomodulatory drugs, and monoclonal antibodies. And hence, combinations of these drugs in triplets are often able to control the disease for prolonged periods of time. However, the majority of the patients who go through these various stages eventually become refractory to all these drug classes, and then we will need treatments that are quite different in terms of mechanism of action in order to have meaningful disease control. In fact, studies have shown that patients with high-risk disease are more likely to become refractory to these 3 classes of drugs at an earlier time point. And once they become refractory to the IMiDs, the proteasome inhibitors, and the monoclonal antibodies, their overall survival is often less than a year, and the progression-free survival with most therapies are in the range of 3 to 4 months. This is where I think the new therapies are making a big impact. In particular, CAR T cells, bispecific antibodies, and antibody drug conjugates have all demonstrated significant activity in the setting of relapsed refractory multiple myeloma. For today, we will focus on the role of bispecific T cell engagers. Now, the bispecific T cell engagers, it's a very simple approach, elegant, where you have a monoclonal antibody that is specificity against two different antigens. One will be against the CD3 on the T cells and the other towards a tumor-associated antigen. This then allows the T cells to come next to the immune cell or the tumor cell, and this then leads to an immune synapse formation and malignant tumor cell death. So this principle has been employed very successfully in the context of multiple myeloma. The very first bispecific antibody that was approved for treatment of multiple myeloma was teclistamab. Now, teclistamab is a bispecific antibody that targets B cell maturation antigen in addition to CD3, and the initial trials in patients who are triple class refractory demonstrated that nearly 60% of these patients actually responded to teclistamab used as a single agent, with a median progression-free survival of almost a year. Now, this is quite different compared to using existing therapies where the response rates would have been more in the 20 to 30% range, and the median PFS would have been 3 to 4 months. Now, the results from the Majestic-1 trial that led to its approval was replicated in real-world experience as well. In the recent ASH meeting, there was a study that looked at 385 patients with relapsed refractory myeloma who received standard of care teclistamab. Nearly half of those patients had no prior BCMA-directed therapy, and the others had, and a variety of different BCMA-targeted therapies, including antibody drug conjugate, CAR Ts, as well as bispecifics were used. What is important to note is that nearly a quarter of these patients had multiple genetic abnormalities. Nearly a quarter of the patients had extramedullary disease, which can be a real challenge in patients with relapse disease. The median number of lines of therapy in these patients were 7 in those patients who had previous BCMA-directed therapy, and 5 in those who had not, again, as one would expect. Now, when you look at the safety outcomes, you can see that the theme of toxicity that we see with bispecific antibodies, again, cytokine release syndrome is a common toxicity seen in almost 2/3 of these patients. But unlike CAR T cells, the majority of the patients tend to have grade 1 or 2 CRS, with grade 3 CRS seen in less than 2% of patients. You can see ICANS, again, in about 10% of these, 10 to 15% of these patients, but grade 3 ICANS is fairly low. The other important signal that we see across the board with the bispecific antibodies, particularly in the clinical trials, have been grade 3 or higher infections in nearly 1/3 of the patients. In the real world setting, again, you see about 15 to 25% of patients getting grade 3 infections, but seems to be maybe a little bit less than what we saw in the clinical trials, and that may be partly related to the duration of therapy. Hematological toxicities can be seen, particularly neutropenia grade 3 that can persist by day 30 or more. And again, this is much less frequent than what we would see in the setting of CAR T cell therapy. Now, in terms of the overall response, you can see that the patients who did not have a prior BCMA-directed therapy had about 60% response rate, very similar to what was seen in the Majestic-1 trial. In contrast, when you look at the patients who had a prior BCMA-targeted therapy, clearly the response rates do fall some, but still has a meaningful 50% overall response rate compared to what we would have expected to be much lower in that patient population. When you look at the median PFS, if you had no prior BCMA directed therapy, then the median PFS was 8 months, quite similar to the 11 months seen in the Majestic-1 trial, but that is almost half when you think about the patients who had a prior BCMA directed therapy. And again, when you look at various factors, what really stands out in terms of poor functional status and patients with extramedullary disease, whether it be soft tissue or plasma cell leukemia. So there have been other experiences too that have looked at the impact of teclistamab therapy in people who have previously received BCMA therapy. And you can see very similar picture in this one as well. If you had prior ide-cel, you can see that almost a third of the patients respond. Patients who had prior ADC, it did not seem to have an impact. And the overall response rate in those people who had no previous BCMA targeted therapy was about the 60% that we have seen before. Now, this is, again, you can see the type of BCMA-directed therapy can also make a difference. Here is the more recent data from the large cohort study. If you look at the ADC, you can see the response rate, or the CAR-T, the response rate is about 48 to 51%. So about 10% less than what we had seen in the naive patients. In contrast, when you look at people who have previously received a BCMA-targeted bispecific antibody, the response rate was significantly lower. Again, these are based on very small numbers of patients, and we still continue to learn more about the concept of sequential therapy in these patients. Here's another set of data from the Majestic-1 trial cohort C, again showing that patients with the prior ADC and CAR T-cell therapy seems to maintain the response to a large extent, but maybe not so for the prior bispecifics. Now, the other monoclonal or the bispecific antibody that is approved for treatment of multiple myeloma is elranatamab. This is again a BCMA CD3 bispecific. You can see the overall response rate is quite similar to what we saw with teclistamab at about 60%. And when you look at the median PFS, overall median PFS was roughly about 15 months, whereas in patients who had a complete response or better, the median PFS was not reached. Now, just as with the teclistamab, we have data for elranatamab used after prior BCMA targeted therapy, and we see similar phenomenon of some drop, about 10% or so, in the overall response rate in patients who have previously seen a BCMA targeted therapy. And you can see that prior ADC and the prior CAR-T, both of them seems to have similar response rate, about 10%. Lower than what we would have anticipated in a BCMA naive patient population. Now, finally, the third bispecific antibody that has been approved for treatment of myeloma is talquetamab. This targets GPRC5D, which is distinct from the BCMA that was targeted by teclistamab and elranatamab. Here you can see various subcutaneous formulations and different doses. The overall response rate with talquetamab is roughly about 60 to 70%, quite similar to what we have seen with the other bispecific antibodies. Now, there are some unique toxicities associated with talquetamab, particularly because of the presence of the GPRC5D on the cutaneous tissue, epidermal tissue. And you can see that there is alteration in taste, difficulty in swallowing, dry mouth, all of which can lead to decreased oral intake and also some weight loss in these patients. You can also get skin rash, you can get nail-related abnormalities, and these can all be managed with appropriate supportive care measures. Now, there is, as with the teclistamab and elranatamab, there's data with talquetamab as well, showing how these patients respond to therapy if they have previously seen T-cell redirected therapy. And you can see that in patients, the overall response rate is about 70 to 72% and drops by about 10% with the prior T-cell redirection therapy exposure, similar to what we saw with the other bispecific antibodies as well. Here you can see the duration of response in patients with prior T-cell redirection therapy appears to be lower than what we would have seen with the Q2-week administration in this particular trial. There was another set of data that was presented at the ASH 2 years ago, looking at the use of talquetamab after prior T-cell redirection therapy. In this particular study, you can see that talquetamab in patients who had prior BCMA-targeted CAR-T and the prior BCMA-targeted bispecific antibodies were all quite similar, though the rate was lower in the BCMA bispecific. And again, the same phenomenon that we're seeing across the board is that in patients who had prior BCMA-targeted therapies, there seems to be a small decrease in the response rate when you're talking about patients who had a BCMA-targeted CAR-T or ADC, whereas patients who had prior bispecific antibody, the drop in the response rate seems to be more profound. So how do we build upon the efficacy of the bispecific antibodies? One approach has been to use combinations. So a variety of different combinations have been studied. One of the earlier ones have been to combine teclistamab with daratumumab and lenalidomide. And you can see from this cohort from the Majestic 2 trial, these patients, the response rate was almost 93.5% compared to the roughly 60% or so that was seen with the single agent teclistamab. Similarly, teclistamab has been combined with daratumumab and pomalidomide. This is combined data from Majestic 2 and TRIM2 trials, very similar study design, except the patient population was slightly different. We can see that the less heavily pretreated patients in Majestic 2 had almost a 94% response rate with this combination, whereas the more than 3 lines of therapy in the TRIM2 had some drop in response rate and it was about 70%. So, but again, quite nice responses in patients who are refractory to a variety of other drugs. Now, finally, the TRIM2 study also had talquetamab plus daratumumab. You can see that the combination gives rise to a response rate of about 80 to 84%. So again, we see that the increase in the response rate from about 60% for single agent bispecific antibody to about between 80 to 85% in those with bispecific antibody with one drug, and about 90 to 95% in those patients when you combine bispecific antibody with the anti-CD38 and an immunomodulatory drug. So the Monumental 2 also have other cohorts where they're looking at just talquetamab with lenalidomide as well as talquetamab with pomalidomide, just IMiD combinations, and then also the combination of anti-CD38 and len in patients with newly diagnosed multiple myeloma. If you specifically look at the talquetamab and pomalidomide combination, you can see high response rates. Almost 94% of the patients actually responded to the talquetamab and pom combination despite having been exposed to a variety of different therapies before. So all this data is being taken to the frontline setting. There's actually a newly diagnosed patient trial called the Majestic 7 that is planning to enroll 1,500 patients who are not considered eligible for stem cell transplant, randomizing them to either TEC or TAL with daratumumab len or just daratumumab len dex as was used in the Maya trial. So this trial will definitively answer whether the incorporation of bispecific antibodies early after diagnosis is beneficial. Now, another very interesting combination that was studied was the combination of teclistamab and talquetamab. And this trial showed that you can get almost a 96% response rate, almost as much as you see with the CAR T cells when you combine teclistamab and talquetamab. And this data was recently published in the New England Journal of Medicine. One of the biggest challenges with bispecific antibodies have been the risk of infections. And we can see that there is an increased risk of bacterial, fungal, and viral infections. And there's a cumulative increase in the risk of infections over time, particularly the bacterial infections and viral infections. So how can we mitigate the incidence of infections? One approach is to use dose modification. So gradually winding down the dose frequency and intensity can help with this. The second is to use IVIG replacement. In fact, there was a large study that was retrospective study that was presented at ASH last year that looked at primary IVIG prophylaxis before the onset of any infection in patients getting bispecific antibodies. And you can see that the patients with primary IVIG prophylaxis had a better infection-free survival, but an even more striking difference when you look at the grade 3 plus infection-free survival. Not only did this IVIG prophylaxis improve the or decrease the risk of infection, it also seems to have improved the progression-free survival, again likely through the ability to sustain therapy for longer periods of time without interruptions from infections. And it appears that the overall survival is better too. Again, this is retrospective data. There are prospective trials looking at the role of IVIG prophylaxis and how best to optimize its role in the treatment of patients getting bispecific antibody therapy. There are still very many questions that are left to be answered. We don't know where should be used. Should be used at relapse or at the time of initial diagnosis? Should we be using them alone or in combinations? Clinical trials that are ongoing will answer this question. Should we use CAR T before bispecific or bispecific before CAR T? Our initial approach or current approach is to use CAR T earlier if it is feasible because of the drop in the response rate that we see with CAR T in patients who have previously seen bispecific antibodies. Now, if you were to use two T-cell engaging therapies, should we have different targets? So if somebody got teclistamab, the next time, should we be focusing on a GPRC5D or FCRH5 targeted bispecific antibody? How much of a gap between two T-cell redirected therapies is ideal? And what about the combinations? Do we use all those drugs in combination? Do we use combinations in sequence? These are all important questions that need to be answered. And finally, I think the toxicity is an important part of the bispecific antibody therapy. And what we have seen is that if we can actually decrease the frequency of administration once patients get to a deep response, we can decrease the risk of infections in these patients as well. Obviously, these are newer therapies. We don't have long-term experience, but as we learn more and more, it is likely that bispecific antibodies will be used very early in the treatment of patients with multiple myeloma, and a variety of different T-cell redirection therapies will be available beyond that point. I'll stop there, and thank you so much for your attention.
So this was the recorded video, and for any questions, we will have Sir on Zoom meeting in a minute. So we can have questions if we have.
Sir is not available. We'll conclude the session 1. I request all the chairpersons and speakers to collect their mementos at the front desk.
Thank you.
Now let's break for a short tea and refresh ourselves. We'll resume at 11 a.m. sharp, so please be back in time. Tea is on the exit side. Okay.
30 నవంబర్ 2022లో నాకు వామిటింగ్స్ అయినాయి. వామిటింగ్స్ అవడంతో వెళ్ళి టెస్టులు చేసుకుంటే
Namaste, ladies and gentlemen. Welcome aboard Deccan Hematolink 2.0. This is your captain, Dr. Ganesh Jaishetwar, along with my co-pilot, Dr. Pragna. Thrilled to have you on this exhilarating journey through the skies of practical... Namaste, ladies and gentlemen. Welcome aboard Deccan Hematolink 2.0. This is your captain, Dr. Ganesh Jaishetwar, along with my co-pilot, Dr. Pragna. Thrilled to have you on this exhilarating journey through the skies of practical hematology, groundbreaking innovations, and cutting-edge research. We are cruising at an altitude of great expertise, accompanied by 200-plus national and 10-plus international faculty experts, ensuring an insightful and inspiring flight. Destination: the latest in hematology, hemato-oncology, and stem cell transplants. Case-based discussions, essential updates, and breakthrough therapies. Participate in quizzes and grab 10-plus smart rings and many more prizes. Connect with top minds in the field and expand your professional horizons. In-flight services, pharma and innovation hub, and exhibition zones. There is Wi-Fi on board. Stay connected and share your experiences live. Your safety is our priority. In case of an emergency, please use the oxygen masks and dial 105910 for immediate assistance. Rest assured, we hope it won't come to that. We are set for an exhilarating 36-hour journey at an amazing height of the 5th floor, where you'll explore the latest innovations, trends, and breakthroughs in hematology. Feeling hungry? Step outside the premises during breaks to enjoy some refreshing tea and Karachi biscuits, as well as the Deccan special dum biryani. Later this evening, join us for a gala dinner, where you can unwind, network, and celebrate the spirit of hematology with your peers and mentors. As we cruise through this journey, take a moment to appreciate the Deccan region, a hub of pharma innovation, IT revolution, and rich cultural heritage. When you're not immersed in hematology, explore the city's iconic landmarks like Charminar, Golconda Fort, Buddha statue, and Falaknuma Palace. Don't forget to visit the bustling markets for pearls and bangles, a hallmark of this vibrant region. A quick reminder, exit will be only on the right side, so please plan your movements accordingly. I kindly request all participants to follow the instructions of our crew and move only during scheduled breaks. Your safety and comfort are our top priorities. Once again, on behalf of Deccan Hematolink 2.0, I thank you for joining us on this journey of knowledge and discovery. Sit back, engage, and let's revolutionize hematology together. Namaste, ladies and gentlemen. Welcome aboard Deccan Hematolink 2.0. This is your...
Small announcement. Please scan the QR code for session 1 quiz questions. Let's move on to the session 2. I would like to call the chairpersons for session 2. Dr. Ravi Kumar sir, Glengel's Hospitals, Hyderabad. Let's move on to the session 2. I would like to call the chairpersons for session 2. Dr. Ravi Kumar sir, Glengel's Hospitals, Hyderabad. Let's move on to the session 2. I would like to call the chairpersons for session 2. Dr. Ravi Kumar sir, Glengel's Hospitals, Hyderabad. Let's move on to the session 2. I would like to call the chairpersons for session 2. Dr. Ravi Kumar sir, Glengel's Hospitals, Hyderabad. Let's move on to the session 2. I would like to call the chairpersons for session 2. Dr. Ravi Kumar sir, Glengel's Hospitals, Hyderabad. Dr. Monalisa Sahu ma'am, Senior Consultant, Yashoda Hospitals, Hyderabad. Dr. M. Venkatramana sir, Senior Physician, Nizamabad. Hand over to you, sir.
Thank you. Good morning. Thank you for inviting me 8 times. It is a privilege on behalf of the rest of the chairpersons to be a chair for none other than Dr. M.B. Agarwal. Every hematologist in the country knows him as a stalwart. People who go to him for a second opinion would go for a final opinion with him. Dr. M.B. Agarwal is a distinguished expert with decades of experience. We have read his treatises, we have read his book. He has been a mentor to most of the hematologists who are practicing in the country and abroad. His dedication to patient care have set benchmarks in the field, and he's been instrumental in advancing treatments for anemia in the field of hemato-oncology and bone marrow disorders. I'm extremely pleased to chair your session, Dr. M.B. Agarwal, sir. Over to you.
Thank you so much, Chairperson. So the subject is iron deficiency anemia revisited in 2025. I'm extremely grateful to Dr. Ganesh. I'm blessed to have a friend like him, because of whom I have the pleasure of visiting this wonderful city every year. So anemia, also known as Pandu Rog, because the father of Pandavas was pale. Maxwell Winthrop, 1901 to 1986, John Hopkins Institute, had the pleasure of seeing him those days. Without any cell counter, described anemia to be of 3 types: micro, normo, and macro, just based on what you see under the microscope. And then came the cell counters, which made the job very easy for all of us. Iron, and the iron deficiency anemia is the commonest anemia of mankind. The consequences of iron deficiency, including iron deficiency anemia, are galore. You can crack corners of your lips. You lose hair. You may become ataxic. You may feel fatigued and tired. You may feel sleepy. You may have a headache. You may feel depressed to the extent that you may feel like committing suicide. So these guys may go to a dermatologist, may go to an oral physician, may go to a psychiatrist, but they need to actually come to a hematologist. There's one specific symptom for iron deficiency, and that is pica. Pica doesn't occur in any other condition except iron deficiency anemia. And what is pica? Pica is name of a bird. And this bird has persistent and compulsive craving to eat non-food items. So ask your patient of anemia whether there is history of pica, and unwillingly or willingly, if he or she says yes, then you made your diagnosis. Pica includes eating everything, including the delicious dirt, clay, paint chips, plaster, chalk, cigarette ashes, soap, toothpaste, burnt match heads, cigarette butts, ice, glue, hair, buttons, paper, and sand. If the husband comes home and finds the home to be neat and clean, the lady in the house has got iron deficiency anemia. There's one specific sign of iron deficiency which also does not occur in any other condition, and that's koilonychia. And after 6 months of oral therapy or 2 months of parenteral therapy, the nail become wonderful and so beautiful. A rare complication of iron deficiency and can be presenting feature sometime to a GI physician or surgeon is Plummer-Vinson syndrome, leading to dysphagia due to this web formation in the esophagus. There are two specific tests for iron deficiency which also do not occur in any other condition. One of them is ferritin. We used to be taught that ferritin below 10 or 20 stands for iron deficiency anemia, but today it has been changed to ferritin below 50. So you're justified in probably giving iron to all those having ferritin below 50. Sometimes there's difficulty in differentiating iron deficiency anemia from anemia of systemic disease or anemia of inflammation. And a test which comes to your rescue, which is not so widely available, but available, is soluble transferrin receptor assay, the STRF. Now this is a simple cartoon to tell you that if your ferritin is on the lower side, if your CRP is normal, if your transferrin saturation is low, it suggests iron deficiency. If your ferritin is not so low, if your CRP is high, if your transferrin saturation is again not so low, probably it does not suggest iron deficiency. Shifting gears, can you die from anemia, and especially can you die from iron deficiency anemia? This is Bill and Melinda Gates Foundation, and they gave these figures which are genuine. Almost about 200,000 people every year die of just iron deficiency anemia. And let me show you one case, which is a real case. 26-year-old pregnant woman, 35th week of her pregnancy, was brought to the emergency gasping. She was ghastly pale. She was in cardiac failure, tachycardia, tachypnea, edema, hypotension. Her blood was collected, sent for cross-matching, but before the blood arrived, she was no more. Investigation showed hemoglobin was less than 2 grams, the MCV was very low, and the ferritin was extremely low, suggesting that this was just iron deficiency anemia. Again, shifting gears, there can be a confusion in differentiating iron deficiency from beta thalassemia, and there are a number of things, including your cell counter, hemoglobin A2 level, etc., help you. There's a concept that if you've got thalassemia minor, you should not give iron therapy. But there are enough publication to tell you and enough clinical experience to tell you that thalassemia minor does not protect you against iron deficiency whatsoever, and you have full liberty in giving iron to thalassemia minor if his or her hemoglobin drops below what it used to be. All pregnant women with thalassemia minor need prophylactic iron throughout their pregnancy to maintain their hemoglobin. Result of this study from Tufan Dolai and others from India itself. Shifting gears again, tracking the progress in preventing iron deficiency. Such is the volume of cases of iron deficiency, as you see over here. If the world population is over 7 billion, then more than 1 billion of them are iron deficient. That is 16% of the whole world population. And if you come to the children, pregnant women, and even non-pregnant women, virtually 40% of them have iron deficiency. Can we reduce this prevalence? Of course, this is more for the epidemiologist and the government and the health workers rather than you and me in the clinical practice. But diversified diet, food fortification, food supplements, and genetic or agronomic biofortification. For example, the rice gold is one example of how you can prevent deficiency at a mass level. Now we come to what you and me are supposed to do, and that is treat iron deficiency anemia. The various tools for treating iron deficiency: dietary advice, oral iron therapy, intramuscular iron, intravenous iron, and blood transfusion. We'll first take up the dietary advice and the blood transfusion. Now, dietary advice, it's extremely difficult to treat iron deficiency by correcting the diet. Dietary advice is essentially to prevent the relapse of iron deficiency anemia once you treat it. There is no diet that can improve your hemoglobin because you will require an elephantine diet to give you that amount of iron by mouth. So yes, dietary advice can be of various types. In the old good days, if you cook your food in the iron vessel and use rusted knives, you get enough iron per day. Iron-rich foods, there are plenty actually, even in a vegetarian diet. You have green leafy vegetables, you have fruits, and more fruits, you have dates, you have dry fruits, you have pulses, you have various kind of iron-fortified food items, etc., etc. Non-vegetarian sources of iron are even richer, and we will see soon why that is even better than the vegetarian sources as far as the bioavailability of iron is concerned. There are factors that affect the iron absorption. For example, vitamin C is a buddy of iron. When you have vitamin C content in the diet, which is good, then with the same amount of iron, there is a better absorption and less deficiency. And there are other factors too. So there are enhancers for absorption of iron, there are inhibitors of iron absorption. The other extreme is the blood transfusion. Probably one should never give blood transfusion to an anemia which can be corrected by any other method, and iron deficiency is one of them, except if iron deficiency is creating morbidity and mortality, which is unacceptable. Like somebody is in cardiac failure, somebody's got angina, or the lady which I just showed you who succumbed, where transfusion can be life-saving. So blood transfusion, yes, and probably no for majority. Let's come to the exact treatment of iron deficiency, and first let's talk about the oral iron. Oral iron works. It is cheap. It is effective. It can be given every other day. You don't have to give it every day. When we were students to start, they'll give it twice a day and give it before food so there is best absorption. That is all obsolete. You can give it once a day, after food, and alternate days. And these are publications in Hematologica, Italian journal, showing you that when you give it alternate day, there's less hepcidin production and therefore there is better absorption. Overall, the advantages and disadvantages of oral iron therapy are now well known. On the green side, you have widespread accessibility, low cost, easy to implement, effective in good intestinal absorption, and a good safety profile. On the right side in the red, you have the problems, the compliance issue, the side effects, the decreased absorption because of the tea, coffee, etc., high fiber diet, antacids, PPI, and so on. Well, oral iron therapy is not very easy to take, especially when you have to take it for 4 to 6 months, because your stomach can be upset, there can be nausea, diarrhea, constipation, and so on. Is there a differential absorption of iron that I was talking about from the vegetarian source as against the animal source? And there is. And the reason of that is hepcidin. Hep is from the liver, cidin is something that kills. This 25 amino acid structure, hairpin-like in its appearance, is produced from liver and originally was thought to prevent sepsis, prevent bacteremia, because this molecule kills organisms. But it kills the organisms because it deprives them of iron. And that's how a breakthrough occurred about 15 years ago in understanding the iron metabolism. Excess of hepcidin leads to iron deficiency, and no hepcidin leads to hemochromatosis. What hepcidin does, it blocks the absorption of iron from the gut, and it blocks the release of iron from the reticular endothelial system. So there is a lot of iron in the RES, no iron reaches the bone marrow, no RBC production can take place. So this becomes very detrimental if your hepcidin levels are high. Shifting gears once more, we come to the parenteral iron therapy. Intramuscular iron therapy is obsolete. We don't use it anymore. No need to discuss. So we come to the IV infusions containing iron. All these preparations are ferric iron, and there are various generations of these parenteral iron preparations. Right from the left extreme, there is naked molecule of ferric hydroxide, which when was given about 100 years ago, people succumbed in 5 minutes. And it was soon realized that you cannot give ferric hydroxide just like that without a cover of sugar around it. Rest all the preparation that you see on the right side are having a coating of the sugar like this. So you've got an iron hydroxide shell. Above that, there is carbohydrate coating. So first generation products include high and low molecular weight dextran. The second generation include ferric gluconate and iron sucrose, of which iron sucrose has survived till today. And the third generation, which are the most popular, is the FCM and IIM, that is iron isomaltoside. And today I'm going to convince you that in your practice you must use only one of these products, and that is IIM, iron isomaltoside. Probably very few of you must be giving that to your 100% of patients. Why it is superior to FCM and why both of these are superior to iron sucrose will be the rest of my talk. So intravenous iron is a framework of changing the management of iron deficiency, is the result of this Lancet Hematology publication 5 years ago. At the bottom is the conclusion, which tells you that the advantages of a single dose of IIM given in 20 minutes is so powerful, and it is so free from the adverse effects which can create morbidity or mortality, that it should be probably the standard of care for all iron deficiency anemia patients. Iron isomaltoside is taken up by the reticuloendothelial system in no time whatsoever. And then it is released from that RES slowly. It goes to the iron binding proteins, which is transferrin and ferritin. 80% of it is taken to the marrow and 20% is stored in the reticuloendothelial system. There is no risk of anaphylaxis because there is hardly any release of what is called NTBI or non-transferrin bound iron. And therefore, no test dose is needed because nobody is going to succumb to this injection. So iron toxicity, especially what we are worried about when we used to give those intramuscular injections or IV dextran drips, is the presence of NTBI. And if you look at this, iron isomaltoside on the left side over here, iron gluconate and iron sucrose over there, there's a marked difference in the amount of NTBI which is produced by different products. So you have to be conscious of this fact and choose your product very carefully. Overall advantages of the parenteral iron therapy are crystal clear. It's effective in 100% of patients. The response is rapid. Within 6 weeks, you achieve the normal hemoglobin. It's free from the adverse effects which can be life-threatening. No test dose needed. Please do not give a test dose whatsoever. There's no question of GI intolerance. There's ease of administration, single sitting, 20 minutes, whole doses inside the body. And therefore, it is recommended even for your dispensary practice. It doesn't have to be that the patient has to be hospitalized. Of course, you have to be ready to take care of some allergic reactions. Therefore, it is cost effective. A patient coming to you just for about an hour, 20 minutes of that is the drip, and the patient goes home. His time, the accompanying person's time, the job from which he has to take a leave or she has to take a leave, etc., etc., etc. And if you've got a side effects, then the work that you lose because of the side effects, etc., are all taken care of. Giving this kind of one dose of iron therapy will significantly reduce the blood transfusions and also significantly reduce the use of erythropoietin, especially for renal anemia and anemia of systemic disease. The clear-cut indications for parenteral iron therapy include those who cannot tolerate oral iron. 1/3 of the people cannot tolerate oral iron. Inadequate response to the oral iron due to A to Z, 100 causes. When you need a very rapid response to iron therapy, like a woman coming to you in the 3rd trimester or imminent for the delivery in next few days, postpartum anemia, because that's a situation where the woman will be breastfeeding, etc. Menorrhagia, where the blood loss could be so much that you cannot replenish with the oral iron, or any other bleeding like piles, etc. Inflammatory bowel disease, where oral iron can lead to more inflammation and precipitate an attack of Crohn's disease or ulcerative colitis. Patients who are into cardiac failure, patients who have cardiorenal syndrome, we'll come back to this very soon, patients who have chronic kidney disease together with erythropoietin therapy, anemia of cancer and anemia of chemotherapy, and we'll come back to this little later, and anemia of systemic disease together with erythropoietin, and we'll come back to this later. That's very simple to understand, including in children. When there is an inflammatory bowel disease, oral iron is going to exacerbate it. So you need all of these, including the pediatric population, IV iron therapy. With respect to the heart, what is not well known is this. Iron deficiency impairs the contractibility of the human cardiomyocyte, and this is through decreasing the myocardial function. So this has been well published, well researched. So improve the cardiac function unrelated to the hemoglobin level by replenishing the iron therapy. Patients who have renal anemia, when you give them erythropoietin, it cannot work without parenteral iron. So the combination works the best. During pregnancy, there are two lives which are important, the mother and the baby. And you have to take care of both, because iron deficiency in the mother leads to preterm birth, low birth weight, small for gestational age, decreased auditory recognition memory, and worst of all, the cognitive and behavioral abnormality in the person to be born. The brain development in the first few years of life are dependent on your supply of iron that has taken place through the placenta in the 3rd trimester. The maternal iron deficiency can lead to even the risk of schizophrenia in the child to be born. All this is published data in the Journal of Neonatology and Obstetrics. Safety during pregnancy. So, well, I like to give parenteral iron isomaltoside during pregnancy, but is it safe? And if it is safe, in which trimester? So we have enough data for 2nd and the 3rd trimester. We have no data for 1st trimester, so it should not be used in the 1st trimester. In 2nd trimester, you have the option because you've got time in your hand, so oral versus injectable. In the 3rd trimester, probably you are running out of time as well, so parenteral iron therapy. Coming to the babies, and babies are not mini adults, there has been enough publication to show you the safety and efficacy of parenteral iron therapy, both the compounds FCM and IM in children with inflammatory bowel disease, and that can be utilized by pediatrician even for other causes of iron deficiency anemia. And this is a wonderful chart published in Blood, giving you 3 types of situations. One where the oral iron is enough, one where parenteral iron is a must, one where you must use your clinical judgment. So children and others who have got simple nutritional iron deficiency, it's not of very severe degree, probably oral iron is okay. Those of you who have got inflammatory diseases, GI tract condition, cardiac failure, kidney diseases, parenteral iron is the only way to go. And then you've got conditions where there is bleeding or symptomatically low ferritin, use your judgment. If oral iron fails, you have to go to the parenteral iron and so on. What about elderly people? Opposite extreme, who are 70s and 80s and maybe even 90s. It's a very complex situation. Their anemia, very interestingly, iron deficiency anemia is more common in the males than in the females, as against the rest of the population that we have talked about. And the anemia at this is extremely complex. I'm not going to discuss this, but most of the elderly people in 70s and 80s have impaired EGFR. They have some kind of the inflammatory disease with reticuloendothelial system overactivity. They may not have healthy liver. Their hepcidin metabolism is deranged. Their erythropoietin production is low. All these people, at least one thing that you can take away is by giving intravenous iron, take away the absorption factor. And then you can link it up with erythropoietin and control of other problems. Is anemia common in diabetics? Diabetic is a national disease. I'll come back to this issue a little later, but one published data is that there's a link between statins and iron deficiency, and most diabetic patients are on statins. So when you are randomly advising statins, keep a watch on the ferritin as well. Iron versus iron, and I was telling you about why IIM is superior to FCM. I'll again come back to this little later on, but this is a Danish study showing you how IIM is cost effective because of various reasons against FCM. I'll come back to this. How long does it take to give the parenteral iron therapy? So it's not like a bullock, it's like a jet. You finish it in 20 minutes. One go, everything is over, and the patient is ecstatic because no more you have to see your hematologist, pediatrician, or physician. How do you calculate the dose? Very simple. The old formula of 0.3 WD, where weight is in pounds, deficiency is in percentage, and this takes care of the storage as well. So not very difficult to remember. However, even simplest is that if your patient is not very overweight and the seriousness of anemia is not much, then about a gram. If your patient is terribly overweight and the anemia is very severe, then 2.5 grams. So overall the range is for an adult is about 1 gram to 2.5 grams, but never give more than 1 gram in a week. So if you need 2.5 grams, patient has to come thrice to you. How do you administer it? You got to dilute it. Don't over dilute it, because when you over dilute it, then iron becomes unstable. You can't keep it. So 500 mg, maximum 250 ml, 1 gram, maximum 500. A lot of people ask me, should I have to give you in 20 minutes? Can I use 40 minutes? Of course, you can use whole day. No issue at all. If your bed is free, you are free, your nurse is free, the patient is free, the relative is free, you can give it as slowly as you want. This 20 minutes is the fastest with which you can complete the iron therapy. Tolerance is excellent. Adverse events are rare. And by now, hematologists of my age have given it to 2,000 patients plus, so you have seen everything that can happen. I'll go over this. 24 hours before the IV iron therapy, the patient may be anxious and may have brain fog. So look down, look at the top for each one of these. Then at the time of administration, there can be extravasation if your nurse is not very good in getting the veins, and this staining will be for the rest of the life of the person. So be careful, and there can be anxiety in the mind of the nurse. So be careful about that, because that will lead to more extravasation. In less than 5 minutes, there can be what is called fish-bane reaction. Fish-bane has nothing to do with fish. Fish-bane was the name of a physician in New York who described this reaction, which is actually just flushing at the top over there, which is an innocuous reaction. Just stop it, wait for 5-10 minutes, the flushing goes away, restart the same infusion slowly, same preparation, same drip without any wastage, and give it little slowly. Then comes little more serious matter, which happens in 5 to 30 minutes, and that is hypersensitivity reaction. Though it's written at the top anaphylaxis, over 10 million units of preparations of these two iron products, anaphylactic deaths have not occurred. So anaphylaxis is extremely rare. Yes, hypersensitivity reactions can occur. They are manageable. They may require even to the extent of fluids or epinephrine, but that's okay. 24 to 72 hours, patient may call you back that she or he has got myalgia, arthralgia, body pain, low-grade fever, flu-like symptoms as put on the top, easily manageable with paracetamol. And last thing, which is, I think, news for some of you, is hypophosphatemia, which occurs with IV iron preparation. Extravasation shown to you over here. Infusion reaction, 3 types, fish-bane reaction due to NTBI, Karpa reaction because of complement, and anaphylaxis IgE mediated. So these are 3 in the gravity of situation from above downwards. How do you manage that? When Ganesh calls me for another 45 minutes talk, I'll elaborate this, but this is of course very, very important for you, because last thing you want is the patient becoming uncomfortable because of IV iron therapy. So this is available on Google, have it in front of you, read it properly, master it, show to your nurse, show to your juniors. You should know how to prevent and how to treat any reaction that may take place, because when you're going to give it to hundreds of patients, these are bound to occur. Let me come to this hypophosphatemia, which is an important tool. FCM and to a very small extent IIM lead to phosphaturia, and that leads to hypophosphatemia. And the symptoms of hypophosphatemia is fatigue. And you may take it as a symptom of iron deficiency anemia. But if this continues for a long time, and if you have to give somebody parenteral iron multiple times, it can lead to even hypophosphatemic rickets and osteomalacia. Incidence of this with FCM is 51%, right at the bottom. The incidence of this with IIM is 5%. So it makes no sense why should we continue to persist with FCM, though of course we are all used to FCM because that has been around for 15 years and IIM is a recent addition. If you are giving FCM, please give extra phosphorus or phosphate to the lady or to the patient, and The kidney guys can tell you what preparations are available in your city, and this can be given by oral route all the time. Can you give parenteral iron therapy to somebody who is infected? Answer is no. Answer is yes. Answer is no if your patient is in the red zone. He's got bacteremia, he's got septicemia, he's got serious localized infection like abscesses, etc. The answer is you can give it if you are on the left side. There's no serious infection. Infections are in the form of, say, hepatitis or HIV, etc., cold, cough, etc. So minor infection, green. Serious infection, red. Yellow, you are the boss. You decide what you want to do. Shifting gears once again, etiology of iron deficiency. Fever, you need to know the cause. Iron deficiency, you need to know the cause. If you don't treat the cause, the patient will be back to you. So increased demand, like physiology, pregnancy, children, blood loss, inflammatory bowel disease, peptic ulcer, GI malignancy, excess blood donation. And then on the right side, causes like poor intake, wrong diet, poor absorption, all of them come in the picture. Fit test. After the age of 40, if for no rhyme and reason, especially from the affluent class, especially the males, if they become iron deficient, it's your duty to rule out a bleeding polyp or a bleeding precancerous condition in the colon or even cancer of the colon. And fit test is one of the very, very authentic tests which can be done on the stool. Patient himself or herself can do this, and this test is now available, so make use of it. The standard test for the fecal occult blood testing can have false positive due to so many dietary and the drug factors. So you've got to stop non-vegetarian food, you've got to stop aspirin-like preparation, you've got to stop oral iron therapy, wait for 3, 4, 5 days, and then do the stool examination. But FIT is something wonderful. Chronic H. pylori infection can lead to atrophic gastritis, which almost stops your oral iron absorption. So you become chronically recurrent iron deficient. Ankylostomiasis in the barefoot walker in the farms. Taking tea or taking coffee immediately after lunch and dinner inhibits the iron absorption to a great extent. Somebody who is vegetarian in diet and is used to taking tea, coffee in place of his dessert can lead to iron deficiency. Perverted appetite, like this girl had trichobazor. What you see on the right side is chewing on her own hair. And remember, iron deficiency leads to pica, and pica leads to hair eating, and hair eating leads to trichobazor, and that again affects the absorption. Celiac disease, widely prevalent, very less recognized. Simple test, TTG, IgA. That test is 70 to 90% sensitive, specific. It's just an ELISA-based test. Should be ordered for all patients of recurrent chronic iron deficiency. And gluten-free diet is the solution. Extreme dieting leads to iron deficiency as well. So somebody wants to become slim from 80 kg to 40 kg overnight, then this happens. Bariatric surgery is the new cause of iron deficiency. Your stomach is out, your stomach is bypassed, you'll end up with iron deficiency. So iron supplement for life is required for patients undergoing bariatric surgery. Malnutrition. It's equal to dieting. So rich people, obese people, dieting, poor people, undernourished people, iron deficiency. Wrong food can lead to obesity with severe iron deficiency. Milk is a very poor source of iron, and all other products which are very rich in fat and carbohydrate may not have much of elemental iron. Even the poor people, sometimes the babies are obese, but they are iron deficient. I told you about diabetes. Probably metformin is one of the commonest drug to treat diabetes. Just do ferritin of all your patients who have been on chronic metformin therapy. The ferritin is 1020. So there is data to suggest to you that metformin leads to iron malabsorption. We use Eltrambopac chronically for patients of aplastic anemia, and it's an iron chelator. So when you give it by mouth, iron goes away. You can, in a aplastic anemia, develop iron deficiency. So be conscious of that. Shifting gear for last 5 minutes. Iron deficiency without anemia. Is it important? Does it need treatment? And I will explain you why it needs treatment. It's a relatively new concept. Imagine your man has got 15 grams of hemoglobin, or the woman has got 13 grams of hemoglobin, and you tell her that take iron and take IV iron. She's not going to be convinced. But the fact is that her ability to work for 8 hours was phenomenal, and today her work capacity is just 4 hours. She's tired, she's fatigued, she's exhausted. By the end of the day, her hemoglobin is, yes, 12, 13. His hemoglobin is 15, but his ferritin is 10. This is functional iron deficiency. And this iron deficiency, iron is required for muscles to work. Iron is required for heart to work. We've seen that one dose of IV iron, 500 in an adult, is good enough to take care of this fatigue, and the fatigue goes away. And this is all published literature. Chronic fatigue, iron deficiency, subclinical, before the hemoglobin drops, can produce extreme fatigue. Restless leg syndrome. I do not know how many of you have noticed it in your life. In the night, there are involuntary movements of your leg disturbing your sleep. Because of no sleep, your whole day goes absolutely astonishingly. This is because of lack of iron in the area at the brain called substantia nigra. This has been shown by MRI study, and there's a very good correlation of lack of iron in the substantia nigra leading to restless leg syndrome. Once again, one dose of 500 mg of IIM and your restless leg syndrome disappears. Chronic disease, let's see a case. So you've got a woman with hemoglobin of 7-8, MCV, MCH are low. You're thinking of iron deficiency, but the woman has got an inflammatory condition, rheumatoid arthritis. A woman has got a systemic disease, like say tuberculosis. Woman has got, she's on cancer treatment, chemotherapy, etc. Now, all these people have excess of hepcidin in their body, as a result of which iron from the oral route cannot be absorbed. So iron from the diet cannot be absorbed. Iron by oral fursolate cannot be absorbed. They need IV iron to put the iron in the proper place. Together with erythropoietin, because their production of erythropoietin is also low. So the answer for the treatment of anemia of systemic disease due to tuberculosis, rheumatoid arthritis, cancer, or cancer chemotherapy is to give EPO with IIM. Some of you might have started using this oral drug. It is called roxadustat. This is hypoxia-inducible factor inhibitor. The nephrologist in between became very, very fond of it because it was supposed to be an oral erythropoietin-like drug. It will do the same job as erythropoietin injection will do. This drug is not US FDA approved because the subsequent data showed that this drug is not effective. So please, if you are using roxadustat in place of erythropoietin, please stop using it. So I conclude my talk by saying that iron deficiency can be corrected by various methods, from dietary to blood transfusion, and in between oral and parenteral iron therapy. However, the most prescribed, the best, and the most scientific is to give one dose of IV iron, and preferably iron isomaltoside, so that hypophosphatemia does not occur, about a gram for majority of Indians. This is the best way, the shining way out of the various options you have. The eye does not see what the mind does not know, and my job was to put this in your mind, how to treat iron deficiency anemia. Knowledge is a barrier to error. So if you have this knowledge, you will not make mistakes. Thank you so much for giving this opportunity to me. Not working.
I thank Dr. M.B. Agarwal for the wonderful talk, and it was enlightening to listen from such a stalwart. I would like to address any questions from the audience.
Yeah, so pediatric data is essentially in children with inflammatory bowel disease, both FCM and isomaltoside, and earlier iron sucrose. Parenteral iron therapy in kids is extremely safe as in adults. And that is now being used by pediatricians as treating nutritional iron deficiency as well, including hematologists use it now.
Sir, Saurabh here. So for this hypophosphatemia, so how to monitor and how long to treat?
So if you want to give FCM, you should worry about it. If you want to give IIM, you don't have to worry about it. Preferably, you should do the baseline phosphate level. Then if you are giving FCM, then you should give a diet rich in phosphate, which majority of dairy products are, or you should give the oral phosphate supplements. Patient has very vague symptoms, so waiting for some symptomatic hypophosphatemia to occur will be a bit difficult, because symptoms of anemia are equal to symptoms of hypophosphatemia. So I have stopped using FCM. If you're using FCM, do the phosphate level, repeat it sometime, or give oral supplements.
Thank you, sir.
The incidence is 55%. So every alternate patient deserves some kind of support.
Sir, it was an excellent talk. mind-blowing, and the whole hall was houseful and calm. So thank you, sir, coming all the way. Thank you, Ganesh, sir, for inviting the sir all the time. Thank you very much. And one question is that in pregnancy, where the 2 lives are to be saved, why don't we give this advice to all the gynecologists and all the treating physicians from the 2nd trimester to start wherever possible, who are affordable for iron injection, so that we can prevent all the malformations and all the things.
So FOGSI is the national gynec obstetric body. They're extremely conscious of this fact. In fact, they have worked with the health ministry, both at the state levels and the national level. They are very, very positive about it. Lots of symposia, seminars, meetings take place from FOGSI on iron deficiency. I don't know whether MCure people are here. They are very aggressive, and they have been helping OBGY people to use the parenteral iron preparation left and right. So I think the pharma, the OBGY society, the FOGSI, and the government, they are working pretty aggressively on this. The problem is the population, the large amount of population, and the rural-based population where these things have not reached. So yeah, the problem is there, solutions are there, and the attempts are going on.
What is the cost of the new molecule, that IIM, which you have said?
What is the?
Cost.
Cost of FCM and IIM is identical. A gram cost between 2,500 to 3,000 rupees.
IIM is available?
IIM is available, at least one preparation from Zydus by name Feruno.
Sir, I have a question.
Where are you? Yeah.
Sir, is it mandatory that we should do a ferritin estimation in all thial minors? One. Second is, how often do you follow it up, even if they don't have significant anemia?
Yeah, so if somebody with thalassemia minor, say male, has been keeping a hemoglobin of 12 and a woman is keeping a hemoglobin of 10, if their level goes down, the first cause is iron deficiency. You want to prove it, you should do ferritin. You don't want to prove it, or there's some problem in doing ferritin, you should give a therapeutic trial. I do a lot of therapeutic trial for my patients who come from municipal hospitals. 2 weeks later, just check the hemoglobin. If it is rising even by 0.5 gram, then you're on the correct track. And then you complete the whole course.
Are the values, the normal ranges, different for thial minors?
Not really, because ferritin below 1020 used to be iron deficiency. Today, ferritin below 50 is iron deficiency. Levels are not different.
Thank you.
Ferritin can be false high if there is inflammation, infection. But low ferritin, only iron deficiency.
Thank you.
So if there are no questions, we'd like to have a big applause
I
and
have
standing
a question.
ovation.
Sorry, I have a question here. I have one last question.
Yeah, please.
Thank you very much for an amazing talk. I'm from the diagnostic space. So I have a question. Currently, do you have true companion diagnostics for determining ferritin deficiencies in the hospitals in different parts of India?
Yes and no. Ferritin is very widely available in cities. Ferritin is widely available in private hospitals. I think ferritin is also available in all the municipal government hospitals where there is hematology department. Ferritin may not be available at smaller places, but there you may have to go to the standalone labs. Private labs, I think ferritin is available left and right. It's a test which has been available for 30 years. It's not a new test. And it's not very expensive.
Thank you so much.
Thank you.
Sir, standing ovation to the great speaker coming all the way. Big applause.
It is my pleasure to introduce to you all to the man behind the show, Dr. Ganesh Jaishetwar. He is the chief pioneer in the clinical hematology and bone marrow transplant working at Yashoda Hitec City. He has been extensively trained in MD, DM and prestigious fellowship in leukemia and BMT from the University of Columbia, Canada. He has played a key role in pioneering various types of transplants, about 500 transplants to his credit, and presented at various esteemed platforms, the national and international ones. And with such an inspiring personality within us, among us, we are glad. I welcome Dr. Ganesh Jaishetwar.
Thank you, madam, for the kind introduction, and good morning, everyone. At the outset, I would like to thank all the eminent faculties as well as the distinguished clinicians from our region. You can see the hall is almost full, and this much enthusiasm and curiosity about hematology. I'm really grateful for all of you sparing time on a busy weekday and coming all the way to this auditorium to discuss, share, and learn about hematology. So I'd like to request all the my eminent panelists, Dr. Venkatraman Kola sir, who is the Director, ICU Services, Yashoda Group of Hospitals, Dr. Somnath Gupta sir, Senior Physician at Yashoda Hospital, Hitec City, Dr. Meet Kumar, Senior Consultant Hematologist from Delhi, my friend and colleague, Dr. Padmaja Lokhi Reddy, Senior Consultant Hematologist, Head Department of Hematology, Bone Marrow Transplant, Apollo Hospitals, Jubilee Hills, Dr. Karthik Vedula, Consultant Infectious Diseases at Yashoda Hospital, Hitec City, Dr. Lakshmi Maithili Mulam Madam Senior Consultant Hematologist from Visakhapatnam, Dr. Bala Saheb Wanwe, friend and colleague, Consultant Hematologist from AIG Hospitals, and Dr. Ravi Kumar sir, Senior Consultant Critical Care, Yashoda Hospital, Hitec City. So I welcome all the eminent panelists here, and Professor M.B. Agrawal sir, none other than Professor M.B. Agrawal sir can, the man behind hematology education, the movement he has started 4 decades back. We are all students of Dr. M.B. Agrawal sir, and I'm sure most of the hematologists in this August podium auditorium are all direct, indirect students of M.B. Agrawal sir. So hematology is a niche subspecialty of medicine and one of the most newest child of medicine, particularly in India. And when we think of hematology issues in ICU, the topic is so extensive. The various hematological issues are so rampant common. Discussing all the issues is practically impossible for a panel discussion of 30 minutes. So we are just few common gist case scenarios. I will request eminent panelists to share and discuss. When we think of hematological issues in ICU, it can be 2 ways. Hematological patients in critical care, mostly the blood cancer patients with various immunocompromised status like neutropenic sepsis, various blood disorders and blood cancer patients with various organ dysfunctions like respiratory failure, shock, the blood cancers with high count, tumor lysis syndrome, hyperviscosity. And whereas the critical care patients with hematology issues, most commonly the cytopenias, anemia, thrombocytopenia, DIC, coagulopathies, and amongst thrombocytopenias, the benign one as well as the most serious and dreadful ones like thrombotic microangiopathies. So we will share some of the, and when we think of hematological issues in general, of all the medicine subspecialties, managing hematological issues is, as Dr. M. Agrawal sir and most of our teachers like Professor Mamanchandi used to elucidate that managing hematological issues are quite simple. It is, they follow algorithmic approach, just like when you master the art of, solving mathematical puzzles, solving hematological issues, once you master that art is really rewarding and gratifying. So algorithmic approach, and then these are the hematological emergencies we discuss. We will discuss mostly cytopenias as well as the common hematology issues in ICU. So of the all hematological issues, I'm going to share cytopenias, anemia. Again, there are a lot of talks in line during this conference, so we'll skip that. We'll discuss thrombocytopenia and serious thrombocytopenias like thrombotic microangiopathies, pancytopenia, serious pancytopenia like HLH. And the one hematological issue we will discuss, the commonest is neutropenia with fever. So this is my first case. This is a 36-year young gentleman. He's admitted in ICU, and the hematologists are called with a platelet count of 10,000, and he already has sepsis with MODS with renal failure. So, these kind of critically sick patients in ICU with various cytopenias, most notably thrombocytopenias, is a common day-to-day occurrence. So I will start with Dr. Meet. So how do you differentiate the thrombocytopenias in ICU setting, and how you particularly the challenge of differentiating the serious thrombocytopenias from the benign ones? So, how you approach such cases?
First of all, thank you so much, Dr. Ganesh, for organizing this wonderful conference and making me a part of it. So I would say that in ICU, thrombocytopenia is the most common cause of consult, and the most common cause within the ICU for thrombocytopenia, in my perspective, is sepsis itself. Sepsis followed by drug-induced, followed by maybe viral sort of myelosuppressions that are causing it, and maybe in particular whenever there is a mention about renal failure in addition to thrombocytopenia, I always like to think about a TMA, thrombotic microangiopathies. So these are the most common causes that should be considered while dealing with the sort of thrombocytopenia in a sort of ICU setting. Of course, ITP, that can be a presentation in ICU also if the patient is otherwise clinically relevantly stable. So that can also be a consideration. But yes, in this background, in general approach for me, at least for thrombocytopenia, is a simple test, IPF. I get it most of the times, immature platelet fraction. That's a retic sort of a comparator of platelet production by the bone marrow. That is a test that practically I'm doing for all patients who are sort of undergoing thrombocytopenia, and that gives us the bone marrow production sort of capacity. So that leads to the further algorithm, like based on that.
Thank you, Dr. Meet. So, IPF is a parameter probably most clinicians won't have access to. Any simple lab tool which can help us.
Peripheral smear is the basic test. That's the first test, of course, that has to be done.
And second is sometimes LDH, patient with any, particularly any neurological abnormality or renal impairment with very high LDH. This is the, one of the serious thrombocytopenias you should be aware of, particularly thrombotic microangiopathies, and should be thoroughly investigated, because delay in diagnosis just by few hours also can add to a huge mortality. So again, as thrombocytopenia, as Dr. Meet mentioned, most common hematology consult in ICU, particularly surgical as well as medical patients, and usually these overall thrombocytopenia as a whole is associated with high ICU mortality as well as morbidity. And as across the literature, the mortality can be 4 to 6 times higher if the low platelet is sustained more than 4 days, and it's a marker of serious medical underlying illness independent of bleeding events. It's not just the bleeding, it's just the presence of thrombocytopenia. So persistent sustained thrombocytopenia is a serious marker. And then it's always easy, as I mentioned, the algorithmic approach. If you divide the thrombocytopenia into 3 categories, the thrombocytopenia due to decreased production from the marrow, it can be either immune like ITPs and autoimmune disorders as well as TTP, and it can be non-immune like DIC. Decreased production from the marrow, mostly marrow disorders like hematological etiologies, hematological malignancies, as well as aplastic anemia, and also drugs. And second is ineffective production like butyl folate deficiency, very common in ICU, and the commonest are the infections. It can be due to destruction, peripheral destruction, as well as sequestration, most notably of splenomegaly of various causes, like commonest is chronic liver disease, infections, autoimmune, and again malignancies. So again, the serious ones, as I mentioned, very high LDH with abnormality other than thrombocytopenia on the peripheral smear. Abnormalities in the red cell lineages or abnormalities in the white cell lineages is a concern that points towards the possible hematological etiologies, and the DIC with coagulopathy or bleeding manifestations disproportionate to the degree of thrombocytopenia, and as I mentioned, thrombotic microangiopathies like TTP, HUS. And most of the times the ICU thrombocytopenia is multifactorial. The most important differentiation is whether it is associated with bleeding or not. The commonest associated, the thrombocytopenias associated with bleeding are ITP drugs, whereas those with associated with thrombosis are serious thrombocytopenias like MAHA, like TTP, HUS, or heparin-induced thrombocytopenia. And this is simple. I'll like to take the attention of all the eminent clinicians from this august audience. This slide here, TTP patient is usually sick, DIC patient is sick, and the peripheral smear showing abnormalities like schistocytes goes more in favor of TTP. whereas coagulopathy, PTA, PTT high goes in favor of DIC. And this distinction is very important because your timely intervention like plasma exchange, treatment of underlying cause for DIC can save a lot of lives. Dr. Padmaja, so with regard to thrombocytopenia, the severity, will you like to tell this august audience, how are you going to approach based on your severity, and which are the most bothersome, concernable thrombocytopenias in your clinical evaluation where you will be more proactive to investigate and act quickly?
Severity, we go by two ways. One is just by number, one is by clinical phenotype and the age. Less than 10,000, irrespective of the age, it is critical, one has to look at it. Even if you know it is looking like ITP, one has to give a platelets, do a 1 hour platelet increment, establish that you're not having an increment, so confirm it's an immune. If it's an older patient, or ideally to look for wet purpura like oral, any mucosal bleeds, those are the patients at a higher risk of intracranial bleeds in the next 24 hours. So you have to be alert and get them platelet transfused to a higher levels. So it's one is the age, the cutoff less than 10, less than 20 you have to transfuse. And between 20 to 40, it depends on the patient, how his bleeding phenotype. If it's a septic patient and you've got a cutoff, you're on antiplatelet agents, you want to keep it up to 50. So whenever in a sick patient we give platelets, we should always look for how is the increment happening or not. In a lot of septic patients, you do get an increment in the first 1 hour. So that rules out an immune cause. It is a non-immune cause. But by the next day morning when you do it, it may have gone down. So it is just saying that there is a consumptive process going on. It may not be a DIC, but it's because of the sepsis. And if you've got a big spleen, the platelets will go up, but it'll last for only 8 hours and it dip down, like alcoholic liver disease, all these. So one is the age and severity of the symptoms and also the numbers. And the associated, whether you have a DIC, you want to put the platelets up to 50,000, irrespective of it, and knowing about wet purpura, risk of IC bleeds. And
thank you so much, madam. So I just for the, just to summarize Dr. Padmaja madam's, comments to all the eminent physicians here. Severe thrombocytopenia, isolated thrombocytopenia without very high LDH, you can try something called as platelet transfusion challenge. Again, thrombocytopenia with other abnormalities or high LDH, you should be little careful because adding platelet transfusions in thrombotic microangiopathies HIT can be detrimental, it can worsen the clinical scenario. But isolated thrombocytopenia, severe without any other abnormality in any other blood lineages and no other feature suggestive of possible thrombotic microangiopathies, you can give them a platelet transfusion, check the platelet count 1 hour, 24 hours after the platelet transfusion. If platelet count increment is good, more than 20-30,000, that rules out immune thrombocytopenia. If the platelet count increment is not appropriate, the platelet count still remains low. This goes more in favor of immune thrombocytopenias like ITP, and here you can add various ITP directed therapies. So Dr. Somnath sir, so what are the indications of platelet transfusion in our day-to-day clinical practice?
Okay, usually platelet transfusion depends on the count in a scenario where there are different existing scenarios, like normally because of ITP or sepsis, or it may be a dengue. If the platelets are very less, like less than 10,000, we usually recommend prophylactic transfusion. But when it is like around a plan for surgery, like minor surgeries, we can keep the platelets up to more than 50,000. And in a general surgeries, we can keep around 75,000. In some kind of surgeries like ophthalmological surgeries, neurological surgeries, where the platelet requires around 1 lakh. But when the patient is on oral anticoagulants, we need to keep the platelets around 50,000. Similarly, in few scenarios where patient platelet has a dysfunction and some kind of coagulopathies where the platelet transfusion is to be done when the platelets are around less than 20,000. So it depends on the multiple scenarios where we require platelet transfusions.
Yes, thank you, sir. So to summarize Dr. Somnath sir's comments, absolute indication of platelet transfusion is when platelet is less than 10,000, 20,000 in presence of bleeding, fever, infection, 50,000 for procedures and surgeries, and 75,000 to 1 lakh for critical organ surgery where slightest of bleeding is not acceptable, like neurosurgery or ophthalmic surgery. I see a lot of patients, infectious thrombocytopenias, a lot of us proactively, apprehensively keep on transfusing platelets when it is absolutely not required, like dengue fever with 30, 40, 50,000. If patient is not bleeding, patient is clinically stable, we can keep a watchful waiting. So again, Dr. Venkatramana sir, so does platelet transfusion in ICU, particularly in sepsis, improve survivals?
In fact, the data remains worldwide the same, that platelet transfusion without an appropriate indication, which already been mentioned in any spectrum of cases, has shown to be harmful than beneficial. That's the data, including the dengue. Even the 10,000 cutoff has its own questions across the globe. If you look at your WHO paper, your papers from so-called the World Authority on the Guidelines from your hematology, the 10,000 guidelines as a prophylactic transfusion for all the spectrum across was always questioned. But probably as a generalized statement, we take that as a count. Coming back to the sepsis as a infective etiology, more so with a bacterial other than dengue, we see sepsis causing thrombocytopenia in different modalities. One is DIC as a common phenomenon. Sometimes we also see sepsis causing some amount of marrow suppression, inflammation causing thrombocytopenia. If I don't have those indications which Dr. Somnath and Dr. Ganesh just enumerated, I don't have an invasive procedure to go ahead, I don't have probably a reason to give them prophylactically. If I give platelets, probably I harm my patient more than I give them any benefit. So I will avoid any form of platelet transfusion if I don't have those general indication which is applicable to any other patient in even sepsis. In fact, I say it can harm my patient.
Thank you, sir. So as we mentioned earlier, ICU thrombocytopenia mortality variably, but then definitely mortality is higher than non-thrombocytopenic patients. Again, on the chart you can see, and again particularly late thrombocytopenia developing after day 10, day 14 is associated with associated with higher propensity to high mortality, like day 14 thrombocytopenia 66% versus on admission 36%. So again, these are the causes of ICU thrombocytopenia. Commonest as mentioned, sepsis, DIC, medications, liver disease, sometimes factitious like dilutional, and multifactorial most of the times. And that is what Dr. Venkatramana sir mentioned, the mortality, the transfusions, the impact of platelet transfusions. There is a variable school of thought, but there is no definite improvement in survival outcomes of these ICU patients presenting with thrombocytopenia. So changing gears further, I am presenting second case. This is 38-year lady with past medical history significant only for history of migraine headaches, more so during her menses, presented to our ER with worsening headache over acute onset 24 to 36 hours. She is absolutely fit and healthy before this. She has taken ibuprofen, sumatriptan and meclizine for this unbearable headache. She is mildly febrile 37.4, and while she is in the ER, while our ER consultant is attending her, she has a trouble while speaking, and she has an episode of seizure. So this is her clinical picture. Hemoglobin, the lab investigation, HB is 9.4, WBC normal, platelets 26,000, creat 1.6, retic 8.8%, INR 1.44, and CT head for her unbearable headache was done. It was reported normal. So you can see creat is 1.6 with headache. I will ask Dr. Vijay Verma sir. So these kind of patients with renal impairment and various hematological abnormalities are common in ICU. So how do you approach such patient?
So this tells us that there is multi-system involvement, sir. So the brain getting involved, and here the renal involvement could be because of NSAIDs, or we need to rule out if there is any parenchymal involvement of the kidney. There is anemia with thrombocytopenia, and the marrow is reactive. And the
This
LDH
is her
slightly
subsequent clinical picture, which came 4 hours later. LDH is high, more than 6 times normal. Haptoglobin is low, and peripheral smear you can see lot of broken RBCs with severe thrombocytopenia.
Yes. So anemia, thrombocytopenia with renal impairment. There is hemolytic anemia.
Yes, sir. So, so this is consistent with TTP. Particularly, I wanted to ask you, most of our patients in ICU, the differentiation between TTP versus atypical HUS, because treatment completely differs. And again, both of these are medical emergencies. In TTP, plasma exchange as early as possible, whereas in atypical HUS, all the complement inhibitors which are not available in India. So how do you approach these cases and how do you take a decision, sir?
So at the bedside, the neurologic involvement is much more significant in TTP, whereas with the other spectrum, that is HUS, renal involvement is much more. The significance of AKI and the severity of AKI seems to be more in HUS. And one telltale sign, an early sign that HUS is happening is the presence of hypertension. Very often, HUS is associated with hypertension. More than 90% of patients with HUS will be associated with hypertension, and there is oliguria that can present.
Yes.
So that is one differentiating feature at the bedside. Otherwise, it's always an overlap.
Yes.
And it's
How do you
difficult.
manage HUS? Do you use plasma exchange in HUS also?
So again, it depends on what type of HUS. Now, the problem in Indian context is if you have to work up for HUS, the anti-factor H antibodies, wherein an autoimmune component or an infective process triggering the anti-factor H antibodies presenting as HUS. That is the only scenario wherein you offer plasma exchange and they can improve. For all the other complement and your complement regulatory protein deficiencies like complement factor H, I, and B, which are predominantly genetic mediated, and there is a deficiency, plasmapheresis has no role. In fact, there are some studies wherein just supplementation of FFPs on a regular basis solves the issue.
Thank you, sir. So basically, I wanted to take the attention of the entire, august audience here. Mortality in thrombotic microangiopathy can be as high as 80% in undiagnosed, untreated patients in time, and it can drop to 10 to 20% who've been started on early treatment for this thrombotic microangiopathy. And the very simple tool like LDH, very high LDH, any subtle neurological abnormalities, any renal impairment, peripheral smear showing any doubt of schistocytes, these are the patients we should start early plasma exchange because it can save lives. Even at suspicion, there is no harm starting these patients. And I see a lot of patients succumbing to TTPs right on way to their shift to the tertiary care center. So we all know TTP, the pathology, ADAMTS13 deficiency. Nowadays it is available to us also. The reporting turnaround time is 24-48 hours, cost just 4,000. So classical pentad, microangiopathic hemolytic anemia, thrombocytopenia, any organ dysfunction like neurological renal associated with fever. So TTP is not so uncommon as mentioned. The current diagnostic criteria in our clinical setting, hemolytic anemia, thrombocytopenia, and no alternative explanation for this presentation with either neuro or renal impairment. So peripheral smear, you have to be in touch with the pathologist for schistocytes that can, so devil is in the details, that's very important. In any suspected case, you have to talk to your pathologist, and nowadays the diagnosis is super simple, everybody carries the smartphones. This plasmic score can give you the clinical probability of TTP and can help your TTP management with timely plasma exchange. So mortality 90% untreated patients, and the time is a very crucial factor. You can see based on the timing and early diagnosis, mortality can be totally different. So thrombocytopenia can not be always simple. You have to be careful, vigilant about this serious bothersome thrombocytopenias where early intervention is mandatory. Again, TTP management, avoid platelet transfusions unless the patient has ongoing severe life-threatening bleed or you are anticipating any procedure. Plasma exchange, if plasma exchange is taking time, simple plasma transfusion before the plasma exchange is started is sometimes can be life-saving. So this is again an algorithm. I'm sorry for these busy slides, but thrombotic microangiopathies, other thrombotic microangiopathies, as Dr. Vijay Verma sir, our senior nephrology and renal transplant physician from Yashoda Group, Yashoda Hospital, Hitec City, has elaborated HUS, TTP distinction is important, but other clinical scenarios which mimic thrombotic microangiopathy like DIC, HELP syndrome should also be thought in appropriate clinical circumstances. So again, differential diagnosis, the most important hemolytic anemia, thrombocytopenia, and appropriate clinical presentation. There are some other causes like DIC where sometimes the picture, this is a spot case, a polytrauma patient, and you can see the picture reveals the diagnosis itself, large abrasions on the chest wall, coagulopathy with profuse oozing. The oozing is so profuse that the underlying bed sheet is completely soaked, subnormal temperature. You can just with simple, one glance, you can make the diagnosis. This is DIC, and the cause of thrombocytopenia here is DIC. So, Dr. Somnath sir mentioned the indications of platelet transfusions. It is equally important to understand and remember when to avoid platelet transfusions, because these thrombotic microangiopathies, APLA, heat, DIC, even in severe ITP, unless and until patient has ongoing active severe oozing or bleeding. Again, DIC for us, just another case I will highlight here. 32-year Primi, she is referred to us because of arrest of her descent in LSCS. Placenta was found to be adherent intraoperatively. It was removed manually. She developed atonic uterus resistant to these uterotonics, leading to surgeries. So the blood loss is profuse. She is in shock. They did subtotal hysterectomy. Still the blood loss is continuing. Dr. Maithili madam, how will you manage such case?
So post delivery, she's having bleeding. We think of DIC, which is a quite common complication that occurs post delivery, and we have to diagnose DIC by the use of the coagulation parameters, and it is very important to transfuse plasma and fibrinogen also is important. So transfusing cryoprecipitate also helps in the management of this case. We also have fibrinogen concentrates because hypofibrinogenemia is a major cause of PPH in a postpartum case. So hence fibrinogen is also important.
Yes, thank you so much. Nowadays, these newer drugs, universal bleeding stopping drugs or bypassing agents like factor VII, it is approved in India for severe uncontrolled PPH, as well as it is being used by most of our clinicians, our colleagues for uncontrolled, surgical bleedings or bleedings in patients with bleeding disorders where they have inhibitors. So this kind of newer factor concentrates can be life-saving under these life-threatening circumstances. So with simple factor VII, 2 doses, normally 1 dose is effective in more than 95% patients. The second dose is required in less than 5% patients. So DIC, remember, death is coming. And Dr. Ravi Shankar sir, so for us hematologists, it is death is coming. That's not the the long form, but it is so critical, and your action is so, prompt action is so much required that it's literally death is coming. Ravi Shankar sir, in all your DIC patients in ICU, is thrombocytopenia alone is a sensitive parameter, to gauge the underlying DIC severity, and it can it help you in your management plan, sir?
Yes, sir. Most of the cases what we see with DIC is there is massive blood loss where there is a depletion of the platelets along with the coagulation factors. That is where the rapidity of correction is very important. The more rapid the fall, the more aggressive you should be, and as early as you have to try to arrest the bleeding and correct the coagulation factors. That is when it makes a difference to the patient.
Yeah, thank you, sir. And again, most of us, all of us carry smartphones and all these fantastic, useful algorithms. In fraction of second, your diagnosis, all the scoring systems. I'm sure all of us are very much aware and using these kind of algorithms, which can really help this clinical practice very easy, effective. Again, management depending upon the type of bleeding or thrombotic, you decide. Again, the medication-induced thrombocytopenia, for the sake of time, I will skip that. And most important for ITP patients, again, I would like to take attention of all the eminent delegates here. The time to response, most of the physicians, clinicians start steroids and they expect within 1 or 2 days the platelet should shoot. platelet can take sometimes 2 to 4 weeks time. So if in emergent bleeding symptoms or bleeding scenarios like IC bleed, uncontrolled intra-abdominal, intrathoracic bleed, these rapid acting agents like IVIG, anti-D can be life-saving. So again, all these thrombocytopenias, we didn't thought of doing bone marrow. So Dr. Padmaja, will you like to highlight in which thrombocytopenia subset you will suggest upfront bone marrow studies for diagnostic evaluation?
So if you've seen a CBC report, you've got isolated thrombocytopenia, peripheral smear normal, you wouldn't jump up. You would straight off start your, is it a macrocytic? Is it a pancytopenia? Is it single cytopenia? Isn't patient sick, bleeding? What are the lymph nodes? Your physical examination. If you've got suspicion straight away, there is a lymphocytosis or a blast in the CBC as we are doing a 5 counters, then straight away you would ask for because you were suspecting. Suppose you've got an anemia patient, high ESR, your total protein is high, globulin is high, on your LFT reports, you're almost suspecting an elderly with a myeloma, so you would straight away go for a bone marrow. Unless you see a blast or you've ruled out a common causes, severe pancytopenia, sick patient, you're not allowed to wait for that long, yes, you would do. If patient has got a high D dimers, looking sick with a spleen, lymph nodes, yes, there is no point in waiting, you could straight away go for it while you're investigating. Everything has to go in a cyclical, multi-linear manner rather than just waiting for the test, depending upon how sick the patient is,
Thank
how
you so
severe.
much, Dr. Padmaja. So to summarize, whenever there is any other abnormality other than thrombocytopenia on the peripheral blast, leukoerythrocytic picture, or severe thrombocytopenia in extremes of ages, these are the absolute indications of bone marrow studies in patients with thrombocytopenias. Again, this is my last case. I will quickly wrap up, and we know we are just short of time, another 2 to 3 minutes. So this is a 29-year female, hypotension, hypoxia, fever, pancytopenia, emergency admission, then subsequently shift to ICU. The CT abdomen showed microabscesses in the spleen, and there is marked splenomegaly. And on labs, there is pancytopenia on hemogram with PT APTT high, consistent with DIC, and she also had low fibrinogen. The blood cultures grow these 2 bugs, and despite continued antibiotics, the blood cultures are negative. So Dr. Karthik, now she is a case of persistent fever. Cultures have already grown 2 bugs. She has progressive pancytopenia. She is clinically deteriorating. Because of her active coagulopathy, she is transfused daily with cryoprecipitates and also platelets for ongoing hematuria. But her blood counts continues to be deteriorating, dropping, and she is becoming more and more clinical deterioration with more worsening dyspnea, tachycardia, and this is the time we are being called. So for pancytopenia. So how will you approach such a case who is already culture positive, progressively pancytopenic, coagulopathy is not improving, based on the sensitivity pattern, the antibiotics are appropriately added, but she continues to clinically deteriorate with worsening cytopenias.
So basically, this is a case of pancytopenia with fever, febrile neutropenia. They're treating. So if patient is being appropriately treated, aggressively treated with antibiotics, and there's persistent cytopenias and organ dysfunction and unexplained fever, then we have to think of HLH. So basically, in critically ill patients in ICUs, HLH should always be in the back of the mind when there's unexplained fevers, persistent cytopenias, and organ dysfunction, because the mortality rate is very high with this condition if not treated early, and because the management will differ in HLH. We have to give like immunosuppressant steroids and other.
So in such case, this patient is really sick. Does she have really HLH? That is the question. But will you continue escalating antibiotics because she also has underlying sepsis?
So as you said, already staff and staff were there, but the culture pattern was there. We were giving adequate, appropriate antibiotics. We have to think of other antifungal causes. We have to rule out other infective causes, And if still, despite that, we are left with unexplained fever, then we have to consider the possibility of HLH.
Yes. So HLH is not so uncommon nowadays because of very good awareness as well as early high index of suspicion. It is a severe life-threatening inflammatory syndrome because of overactivation of macrophages and all these immune cells, results in progressive cytopenia and multi-organ failure. It can be infection associated, but not just infection, underlying autoimmune disorders, viral infections commonly, underlying undiagnosed hematological malignancies, post-transplant, and some patients are genetically predisposed. So this is pathophysiology, uncontrolled inflammation, not able to control the hyperinflammation, but not able to control the underlying precipitant, leading to overactivation of these macrophages, cytotoxic T cells. And so clinical presentation is refractory fever, dropping counts, and hyperinflammatory markers, most notably ferritin. So Dr. Meet, so what ferritin you will be vigilant about the possible HLH? What ferritin level? Just any high ferritin, 200, 500, or a specific level?
Okay, so I would say a couple of things here. So some of interesting things. I think, was a marrow done for this patient?
No.
So I think marrow is one thing in the light of pancytopenia,
Yes.
and this thing, a marrow is very important
Perfect.
so that we are not missing leukemias.
Yes.
That is one. Second thing is what is interesting is this patient has hepatosplenomegaly along with abscesses in liver and spleen. So that is something very interesting, that HLH presenting with abscesses, maybe abscess is a feature of systemic sepsis and not HLH per se. So that is the second thing. And third thing, what you are asking is about the ferritin thing. So ferritin, I think the guidelines say 500, but unless and until it is more than 10,000, we usually do not start thinking that it can be HLH. It might be something else if it is less than 10,000.
For the, just to conclusion of what Dr. Meet said, ferritin more than 3,000 in a patient with persistent fever, progressive pancytopenia, has a 90% sensitivity and more than 85% specificity for HLH diagnosis, because HLH is a very critical diagnosis. Your over-diagnosis can kill the patient, and also the under-diagnosis can kill the patient. So it's a double-edged sword, and you can see these are ICL prognostic models based on your early diagnosis, early intervention, because the treatment for HLH is intensifying immunosuppression with steroids, etoposide. Nowadays, this tocilizumab, ruxolitinib. COVID has been a great teacher. So this patient, because of this ferritin was more than 8,000, which HLH started steroids, etoposide, IVIG. Patient has ferritin more than 10,000, but despite this initial immunosuppressants, fever was persistent, started on a newer targeted drug, JAK2 inhibitor, ruxolitinib. Within 10 days, she recovered and was ready for discharge. So all ICU patients who are persistently febrile should get ferritin. In Western literature, all sick febrile patients, they do ferritin on admission. Ferritin more than 10,000, more than 3,000 should always be a high index of suspicion. And again, novel, modern, smartphone-based algorithms, H-score is very helpful in early diagnosis. Early recognition is a key, and key flag, immunosuppressed inflammatory diseases, refractory fever, progressively dropping counts, and inflammatory marker like high ferritin. So top causes, viral infections like CMV, EBV, disseminated tuberculosis, lymphoma, autoimmunity, and sometimes genetic HLH can present up to 30, 40, 50 years of age. Again, immunosuppression, starting immunosuppressive therapy for sick, febrile, cytopenic patients is a real challenge, but your prompt clinical evaluation can really help and save these patients. And as I mentioned, the HLH and all these inflammatory cascades, hyperinflammatory syndromes, cytokine release syndromes, COVID has been a great teacher, and nowadays this IL-6 ferritin is available across most hospitals. So useful tips: persistent fever spikes, periodic ferritin should be done, and for most clinicians, physicians, they believe that bone marrow is diagnostic of HLH, which is a misnomer. Bone marrow showing hemophagocytosis, only 20-30% patients of HLH at diagnosis. Of course, it will evolve. If you continue to do bone marrows, it will be seen in majority cases. So bone marrow hemophagocytosis is not mandatory for HLH diagnosis. So with that, I will conclude my talk, and I'm extremely grateful and thankful to all my friends, colleagues, panelists for bringing out such useful tips in day-to-day practice in
hematology issues in ICU. Like the famous saying Dr. M.B. Agarwal sir mentioned, eyes are useless when the mind is blind. Thorough clinical evaluation and simple lab-based algorithmic approach can help you evaluating and diagnosing vast majority of hematology issues in ICU. The future of medicine and hematology is very bright, and there are a lot of cures and cure rates and extremely rewarding results across this entire hematological spectrum. So it is time to change our approach to offer the best possible chance of cure, survival, relief across all these neglected blood disorders. To summarize, hematological diagnosis can be challenging, early diagnosis can be life-saving, delayed diagnosis can be fatal. Oftentimes, treatment may be needed to initiate it prior to confirmation of diagnosis like thrombotic microangiopathies and HLH. And most of the times, hematologist can be your savior amidst these turbulent times. Thank you so much, all the eminent panelists and all the eminent clinicians across this august podium for your patient listening. Thank you so much.
I would like to thank the chairpersons. My humble request, all the chairpersons and speakers to collect the mementos next to the photo booth. Next is the inauguration ceremony. I would like to hand over to Dr. Sai Kumar.
Please keep it within.
Request everyone to please be seated. Good afternoon. It's truly an honor to stand before such an esteemed gathering of distinguished faculty, oncology and hematology experts, and senior management members who have taken their valuable time to be here at Deccan Hematolink 2.0. This conclave serves as a vital platform where we come together to explore the latest advancements in hematological and hemato-oncological services, driving forward innovations that transform patient care. For over 3 decades, Yashoda Hospital has been the forefront of healthcare, evolving from a modest 30 to 50 bedded nursing home to a trusted name in the industry, now boasting over 4,000 beds across the multiple locations. One of our most groundbreaking advancements is the state-of-the-art MR-Linac system, a revolutionary technology that combines real-time imaging with highly precise radiation therapy. This ensures unparalleled accuracy and improved clinical outcomes for cancer patients. With over 500 successful MR-Linac cases treated so far, the results have been truly remarkable. Yashoda Hospitals has emerged as a leader in medical tourism, welcoming patients from across the globe. We take an immense pride in being the first private healthcare institution to successfully perform 500 plus bone marrow transplants so far, with a vision to further expand access to cutting-edge hematology care. We have established dedicated state-of-the-art BMT unit equipped with ultra-modern facilities. At Yashoda Hospitals, we are continuously adapting the latest advancements in hemato-oncology services. One such cutting-edge treatment is CAR-T therapy, an innovative immunotherapy modality that offers unparalleled accuracy and improved clinical outcomes for cancer patients. With over 500 successful BMT cases treated so far, the results have been truly remarkable and encouraging. Bone marrow transplant is a highly specialized and resource-intensive treatment, often associated with significant costs. However, at Yashoda Hospitals, our vision has always been to make a world-class healthcare facility both accessible and affordable for all category of patients. We offer some of the most reasonable BMT packages, ensuring that cost never becomes a barrier to receive life-saving treatments. Our BMT caters to both adults as well as pediatric patients, ensuring comprehensive care for all individuals receiving treatment. Additionally, we believe that quality healthcare should be accessible to all patients, which is why our BMT unit at Hitec City follows standardized tariffs, ensuring uniform and fair pricing across all Yashoda hospital units. Giving you a closer look at our commitment, expertise and vision, we invite you to watch a short video showcasing Yashoda Hospital's journey, the transformative impact of MR-Linac technology, and the exceptional care provided at our bone marrow and stem cell transplant unit. I would also like to express my deepest gratitude to the media and the press representatives for their presence and coverage of the event.
Welcome to Yashoda Hospitals, a trusted name in healthcare for over 30 years. We are committed to your health and well-being, providing world-class care with compassion and expertise. Introducing a revolutionary advancement in cancer treatment, MR-Linac, our newest addition in the fight against cancer. Being a pioneer and leader in cancer treatment, Yashoda Hospitals now brings you the world's best and India's first MR-Linac. A revolutionary breakthrough, MR-Linac is the world's first fusion of a linear accelerator and a high-resolution MRI, changing the grounds of medical imaging and radiation therapy like never before. Discover a groundbreaking approach to seeing and treating the ever-moving and ever-changing. Through intelligent and pioneering technology, we bring you a solution that offers crystal-clear vision like never before. Next generation of Linac technology that offers an uninterrupted 360-degree rotating gantry and integrated workflows to unlock the potential for precise treatment in any direction. Live target imaging and 7 dimensions of information enabling real-time visual tracking and seamless treatment adaptation. The use of AI technology further enhances accuracy and effectiveness, resulting in reduced side effects and improved quality of life for patients. This groundbreaking technology is now available at Yashoda Hospitals, Hitec City. Experience the future of healthcare today. At Yashoda Hospitals, our highly skilled doctors, nurses, and support staff deliver exceptional care. Trust us with your health because at Yashoda Hospitals, your well-being is our priority.
Thank you for watching the video. Let us now quickly take a look at our bone marrow and stem cell transplant unit video as well. Thank you for watching our bone marrow and stem cell transplant unit video as well. Now, the future of hemato-oncology services in India will be driven by advanced cellular therapies, precision medicine, and expanded access to bone marrow transplants with AI-powered diagnostics and integrated cancer care improving early detection and possible outcomes. Increasing affordability and government initiatives will further enhance accessibility and innovation in treatment. Let us quickly watch a video highlighting the future of hemato-oncology services in India.
Blood. It flows within us all. But do we truly understand its power? Let's dive into the lifeline of life itself.
Every drop of blood carries the power to heal, protect, and sustain. In the battle against blood cancers, science is our greatest weapon. We at Yashoda Hospitals, Department of Hematology, always push the boundaries of hematology to go beyond what we ever imagined.
Now it's my honor to invite Dr. M.B. Agarwal, a renowned expert in hematology and professor and head of the department, Bombay Hospital, Mumbai, and Dr. Usha Agarwal, as well as I would also like to invite Dr. G.S. Rao sir, our managing director, and Dr. Ganesh Jaishetwar sir to kindly join us on stage. As per our tradition, we begin the special occasion with the lighting of the lamp, symbolizing knowledge and positivity. I now invite our esteemed dignitaries to step forward for the ceremonial moment.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
I now request Dr. G.S. Rao sir, our Managing Director, and Dr. Ganesh Jaishetwar sir, and Mr. Karthik Haivelan to kindly felicitate Dr. M.B. Agarwal, honoring his remarkable contributions to the field of hematology and his invaluable presence with us today. I now request Dr. Usha Agarwal, Madam. I now request Dr. G.S. Rao sir to please speak few words addressing the gathering.
Good afternoon. Dr. Embry Agrawalji, Professor. Dr. Usha Agrawal, Professors. The Dians in Hemato-Oncology, and all the esteemed faculty, distinguished guests, members of the media, respected colleagues. It's an honor to inaugurate Deccan Hematolink 2, a platform dedicated to advancing hematology, oncology, bone marrow transplant. Today we stand at the forefront of new era in blood cancer treatment, one driven by innovation, precision medicine, transformative therapies. This event coincides with the World Cancer Month, serves as a vital platform for leading experts from India and abroad to discuss the cutting-edge technologies and treatment modalities for blood cancers and blood disorders. At Yashoda Hospital, we have always been committed to bringing cutting-edge evidence-based care for our patients. From pioneering Haploidentical transplants to performing advanced T-cell depletion transplants, our focus has been on offering hope where options were once limited. Over the past decade, our dedicated team has successfully performed more than 500 bone marrow transplants, providing renewed hope for patients battling life-threatening blood cancers and disorders. These milestones have positioned Yashoda Hospital as a pioneer of hematology, setting new benchmark for bone marrow transplant. Blood cancer treatment is evolving rapidly. We are at the forefront of adopting latest advancements including CAR T-cell therapy, gene therapy and immunotherapy. With these new treatment modalities, once incurable blood cancers are now potentially curable. The challenge now is accessibility, affordability, that is definitely a problem, and scalability. Why I am saying the scalability is, if you have the volume, the cost will come down, and that is where we are making the difference. Our mission in hematology is very clear: to make advanced treatment accessible and available to our people in general. We have dedicated BMT units with state-of-art infrastructure experienced multidisciplinary team delivering world-class care. Why I am saying this is infrastructure is very well compared to any other organizations is, we maintain sterile controlled environment. Our advanced air handling system prevent cross-contamination, isolating inflow from other theatres. Because they have zero immunity, these our BMT places are maintained much better than even the operation theatres. Additionally, patient benefit from specially designed provisions like we give only RO water to the BMT rooms where there are sterile water almost, and I think any utility for hygiene sensitive needs or any other, even if they want to take any bathing also, we use a very clean and neat RO system that is helping us a lot, preventing the infections. These innovations collectively contribute to our consistent, outstanding clinical results. Of course, it's not only infrastructure, it's also a question of the number of teams and also the nursing care and definitely backup by the intensivists. The second target of our hematology team is to train the next generation clinicians. I am happy Dr. Ganesh and his team is doing a wonderful job of educating the rest of the people, and anybody who wants to develop any BMT units in their hospitals, I request them to come and meet Dr. Ganesh and also see the units, and you can also talk to our engineering section so that you can definitely develop a system which is infection free. I definitely appreciate the organizers of this meet. did a wonderful thing. Yesterday night I came, they were just preparing still, so I was not very sure how it will come, but it has come very nicely. And also Dr. Ganesh doing this wonderful event. As we embark on the conference, let us engage deep discussions, explore ways to make these revolutionary treatments a mainstay in clinical practice. The future of hematology is here. The Yashoda Hospital is ready to deliver advanced treatment at scale. I conclude this, like to congratulate definitely for the good academic sessions designed by Dr. Ganesh and his team. Once again, I thank the print and electronic media for expanding the reach of this program. I also thank pharma companies taking part in this program. Thank you very much.
I now request Dr. M.B. Agarwal sir to please speak few words to address the gathering.
Dr. G. Surendra Rao, the Managing Director, Dr. Ganesh Jaishetwar, the whole soul personality behind all this full event that has been taking place, all other organizing committee members, the support people, and my fellow faculty members, as well as huge number of audience, the delegates over here. It's just amazing how first year and now the second year, you work so hard, you do this teaching activity and you attract so many people and their interest is maintained even for the second year in the subject. Kudos to you for your hard work and dedication. So Ganesh has achieved something which everybody is not able to achieve. It's a huge honor to be called the chief guest again for 2 consecutive years. Thank you so much for your love and affection. I remember when Ganesh used to come to my clinic. I'm sorry that I didn't meet you many times, but he spent a lot of time with my wife. And that time, many of you may not know, he was a graduate from pathology. And those days I used to always wonder how a pathologist would convert into a clinician and treat patients, including right up to bone marrow transplant and CAR-T therapy. You defied my thoughts, and you're done, and you excelled in treating the patients right up to, what was the figure put, 500 bone marrow transplant in this city, and very often we'll be hearing 500 CAR-Ts in this city. Courtesy Ganesh. So sky's the limit. You trust yourself, you know your abilities, you can go wherever you want. There's nothing that can stop you if you are ambitious and you have your self-confidence, and Ganesh is an example of that. The chairman, sir, is also an example. Ganesh was just telling me, the 3 brothers have created this institute, another 3 institute in the city, and the 5th one coming up, and the 2 coming up in Bangalore, and the pharma. So your vision is something which is fantastic. You're all together adding up in what is called developed India and the dream of our Prime Minister. Just yesterday I heard on the TV they want to bring the Commonwealth game by 2030 and the Olympics to India by 2036 or 2037. That is the vision of the Prime Minister, and your vision is not far behind. So what you're doing to Hyderabad and our Prime Minister is doing to the country, it's just fantastic days. I just wish that I was 20 years old and I had 60 years ahead of me to see India would have been the leading country ahead of all these guys who are just fighting with each other. Russia and Israel and all, they would have been all left behind. Lastly, just one sentence. I think when you are speaking on the mic, you should give one message. When you give your child to a teacher, you want the teacher to shape his future. You trust him and leave it to him. When you're building a house, you call an architect and you leave it to him, and he should give you a good house with all the facilities that you want. When you have got legal problem, you go to a advocate, you go to a law guy, and you expect him to pull you out of whatever hassle you are facing. But when you give your near and dear to a doctor, you are giving his life to him. You are trusting him that he is going to save his life and give your near and dear back to you. So I think that is such a responsibility on you and me and our shoulders. Death is not preventable. Ultimately, all of us have to die. But if there is one patient about whom you feel that he died because of your negligence or because of your lack of knowledge, or wherever you feel that you were slightly responsible for that death which was preventable, then that guilt will be with you for the rest of your life. So I think the CME like this, what it does is, it sharpens your knowledge. It increases your acumen to prevent preventable deaths. And I think from that angle, a medico has the hugest responsibility on his shoulder that somebody has trusted him with his life, not with his money, not with his house, not with his kid. So thank you so much once again to give this responsibility to me. Thank you.
Thank you so much, sir, for your valuable insights. With this, I would like to extend my heartfelt gratitude to Dr. G.S. Rao, sir, and Dr. M.B. Agarwal, sir, for sharing their valuable insights and wisdom with us today. Their expertise and dedication to advancing healthcare and hematology serves as an inspiration to all of us. As young professionals, we aspire to learn from their experiences, imbibe their principles, and incorporate their guidance into our day-to-day practices. Their unwavering commitment to patient care, research, and innovation reminds us of the responsibility we all carry as the next generation healthcare providers. Once again, thank you so much for your valuable time, sir, and invaluable contributions to this field. And I now request Dr. Ganesh, sir, to please speak few words and give vote of thanks.
Good afternoon, everyone. Dr. G.S. Rao, sir, the man with a vision, what you call it as, who has created this fantastic health care infrastructure for our region. My mentor, my teacher, Dr. M.B. Agrawal, sir, Usha Agrawal, madam, and all the eminent faculties from across the country, and all the distinguished clinicians from our region. I really share my humble, sincere gratitude for coming all the way and joining this conference. Hematology is an ever-evolving field. As Dr. M.B. Agrawal said, I had my own struggle. 2000s, I joined DNB medicine. I could not complete 3 years and then exam, because after 2.5 years, I had to run away because the results were poor. And then I tried to switch my field again, trying to do MD pathology. And then I realized the wonderful amalgamation of clinical sciences and lab sciences is in the hematology, and I got the opportunity to join hematology. Wonderful specialty, and with such a evolving landscape, very gratifying and rewarding results. So the numbers what Dr. Sai Kiran sir and all Dr. G.S. Rao sir mentioned, 500 plus transplants and thousands of blood cancer treatments. So this is a testament to collaborative teamwork with all the eminent clinicians of our region. Management by a hematologist is just a miniature part of the journey of that particular patient, timely diagnosis, timely referral, and after successful accomplishment of the treatment, periodic follow-up and meticulous monitoring is always relies on the shoulders of the eminent physicians, pediatricians of the region. And I'm really grateful to have such a wonderful team of eminent clinicians, physicians, pediatricians, intensivists, and all other specialties from our region. So these numbers, what highlighted by my colleagues, my management team, is it's a collective reflection of our teamwork over last 12 years at Yashoda Group of Hospitals. I'm really grateful for this wonderful opportunity, not just showcasing hematology and the future of hematology with all my eminent colleagues across the country on this, on the occasion of Deccan Hematolink 2, but also looking forward to a wonderful journey together, adopting to the innovations and developments in the field and bringing cure and smiles across thousands and lakhs and crores of people from our region. Thank you so much, one and all.
Thank you so much, Dr. Ganesh sir. With this, we now conclude the inauguration program. A heartfelt thanks to all our esteemed dignitaries for their valuable time, insights, and presence today. Your contributions have truly set the tone for this event, and we deeply appreciate your support. Now, I invite Dr. Lavanya to take over and guide us into the much-awaited academic sessions ahead. Over to you, Dr. Lavanya.
All media people are requested to join the next room. Our team will take you there, please. There I have the press briefing there. Dr. Ganesh Jaishetwar sir will brief you about the program in Telugu.
Namaste, ladies and gentlemen. Welcome aboard Deccan Hematolink 2.0. This is your captain, Dr. Ganesh Jaishetwar, along with my co-pilot, Dr. Stitha Pragna. Thrilled to have you on this exhilarating journey through the skies of practical hematology, groundbreaking innovations, and cutting-edge research. We are cruising at an altitude of great expertise, accompanied by 200+ national and 10+ international faculty experts, ensuring an insightful and inspiring flight. Destination: the latest in hematology, hemato-oncology, and stem cell transplants. Case-based discussions, essential updates, and breakthrough therapies. Participate in quizzes and grab 10+ smart rings and many more prizes. Connect with top minds in the field and expand your professional horizons. In-flight services, pharma and innovation hub, and exhibition zones. There is Wi-Fi on board. Stay connected and share your experiences live. Your safety is our priority. In case of an emergency, please use the oxygen masks and dial 105910 for immediate assistance. Rest assured, we hope it won't come to that. We are set for an exhilarating 36-hour journey at an amazing height of the 5th floor, where you'll explore the latest innovations, trends, and breakthroughs in hematology. Feeling hungry? Step outside the premises during breaks to enjoy some refreshing tea and Karachi biscuits, as well as the Deccani Special Dum Biryani. Later this evening, join us for a gala dinner where you can unwind, network, and celebrate the spirit of hematology with your peers and mentors. As we cruise through this journey, take a moment to appreciate the Deccan region, a hub of pharma innovation, IT revolution, and rich cultural heritage. When you're not immersed in hematology, explore the city's iconic landmarks like Charminar, Golconda Fort, Buddha statue, and Falaknuma Palace. Don't forget to visit the bustling markets for pearls and bangles, a hallmark of this vibrant region. A quick reminder, exit will be only on the right side, so please plan your movements accordingly. I kindly request all participants to follow the instructions of our crew and move only during scheduled breaks. Your safety and comfort are our top priorities. Once again, on behalf of Deccan Hematolink 2.0, I thank you for joining us on this journey of knowledge and discovery. Sit back, engage, and let's revolutionize hematology together.
Moving on to the next session, I would like to call the chairpersons, Dr. Gopi Srikanth sir, Consultant Gastroenterologist, Yashoda Hospitals, Hitec City, Dr. Ravi Kaladhar Reddy sir from Kurnool. There is a short delay in the schedule. Sir is in a press meet. So we'll break for the lunch and we'll catch up at 2 o'clock. Please move to your right side and proceed towards the exit door for the lunch.
Namaste, ladies and gentlemen. Welcome aboard Deccan Hematolink 2.0. This is your captain, Dr. Ganesh Jaishetwar, along with my co-pilot, Dr. Stitha Pragna. Thrilled to have you on this exhilarating journey through the skies of practical hematology, groundbreaking innovations, and cutting-edge research. We are cruising at an altitude of great expertise, accompanied by 200+ national and 10+ international faculty experts, ensuring an insightful and inspiring flight. Destination: the latest in hematology, hemato-oncology, and stem cell transplants. Case-based discussions, essential updates, and breakthrough therapies. Participate in quizzes and grab 10+ smart rings and many more prizes. Connect with top minds in the field and expand your professional horizons. In-flight services, pharma and innovation hub, and exhibition zones. There is Wi-Fi on board. Stay connected and share your experiences live. Your safety is our priority. In case of an emergency, please use the oxygen masks and dial 105910 for immediate assistance. Rest assured, we hope it won't come to that. We are set for an exhilarating 36-hour journey at an amazing height of the 5th floor, where you'll explore the latest innovations, trends, and breakthroughs in hematology. Feeling hungry? Step outside the premises during breaks to enjoy some refreshing tea and Karachi biscuits, as well as the Deccani special dum biryani. Later this evening, join us for a gala dinner, where you can unwind, network, and celebrate the spirit of hematology with your peers and mentors. As we cruise through this journey, take a moment to appreciate the Deccan region, a hub of pharma innovation, IT revolution, and rich cultural heritage. When you're not immersed in hematology, explore the city's iconic landmarks like Charminar, Golconda Fort, Buddha statue, and Falaknuma Palace. Don't forget to visit the bustling markets for pearls and bangles, a hallmark of this vibrant region. A quick reminder, exit will be only on the right side, so please plan your movements accordingly. I kindly request all participants to follow the instructions of our crew and move only during scheduled breaks. Your safety and comfort are our top priorities. Once again, on behalf of Deccan Hematolink 2.0, I thank you for joining us on this journey of knowledge and discovery. Sit back, engage, and let's revolutionize hematology together.
We'll move on to the next session. I would like to call the chairpersons for this session. Dr. Ravi Kaladar Reddy sir from Karnool, Dr. Gopi Srikant sir from Yashoda Hospitals, Hitec City. I would like to invite Dr. Venkatramana Kola sir, Critical Care Department Head, Yashoda Hospitals, Hitec City, to chair this session.
Thank you. Thank you, Lavanya. I think welcome to this post-lunch session. Most of our delegates are very eagerly waiting to listen to the next session of MB Agrawal sir. So he doesn't need any introduction. I think he has been a seasoned speaker and being on the dais for the last 2 hours or so. We welcome him on board. Over to you, Dr. MB Agrawal sir.
Start? Thank you. So, respected chairpersons and friends, spleen, splenomegaly, and splenectomy, changing concepts. Again, I am blessed to have Ganesh as my dear friend, because of whom I am in the city of Hyderabad yesterday, today, and tomorrow. So, spleen is like a story, and we're talking first about the spleen. So, what you see in the red color on the right side is the organ that we are talking about. Pancreatic tail is very close to the spleen, and very often when surgeon has to do pancreatectomy for say malignancy, etc., they just sacrifice the spleen, and I will tell you why probably not to do so. If you look at this particular picture, you are looking at the splenic hilum. You see the artery which takes the blood to the spleen, the vein which drains it back. When you remove the spleen, there is almost no blood flow in the splenic vein. Half the time it gets thrombosed, and that thrombosis extends to the portal vein, and that's okay, but then it extends to the mesenteric vein, and your intestine can become gangrenous. Spleen, developmentally, is from the fusion of multiple small splenenculi. And that's what you teach your students, that when you're palpating the spleen, there is a notch. And as you can see over here, this spleen has got multiple notches. Besides that, you can see the indentation on the surface of the spleen. Spleen is at the mercy of all the surrounding organs. The stomach presses on it, the kidneys presses on it, the colon presses on it, and so on. So it gets pressed by everything. That's the cut surface of the spleen, a cartoon showing you that there is a red pulp, which is all over. There is a white pulp in between, and there is a capsule. And that's the real cut surface of an enlarged spleen. And that's a little bit of high power view. What you see over here is bluish area, which is the white pulp, and the reddish area, which is the red pulp. Splenomegaly is a jigsaw puzzle. If I am in hematology, it's because of the spleen, and I'll tell you why. When I was doing my medicine as a registrar, one day in emergency, we landed up with 7 patients with large spleen. They were sent to hematology next day morning for workup. Within this week, those 7 patients had 7 different diagnoses. And that's what attracted me to splenomegaly and then hematology. When the spleen is enlarged, it may be mildly enlarged, it may be moderately enlarged, or it may be massively enlarged, or it may be so voluminous that it may occupy the whole of abdomen. No doubt, to become XL, it has to be L sometime. To become L, it has to be M sometime. And to be M, it has to be S sometime. So all those conditions which are characterized by a large spleen may also have a small spleen. These are the dimensions of a normal spleen. At the top, you have a child aged 0 to 3, and then 4 to 10, 11 to 18, and adults. By the time you are adult, the spleen size is about 13 centimeters. Of course, it's not palpable, but the sonography will tell you. When the spleen is in a problem, you may have heaviness in the left upper abdomen, you may have pain in the left upper abdomen, etc. We teach our students that to palpate the spleen, you have to put the patient into the lateral position, the right lateral position. You start palpating from the right iliac fossa, go to the left hypochondrium, put your finger inside or below the rib cage, and then you'll get the tip of the spleen. Today, you can just do a sonography and find out how the spleen is. The causes of splenomegaly and the splenectomy probably go hand in hand, so we'll discuss them together. Now my talk will be based on certain cases. First, we'll begin with the red cells. Spleen is the graveyard for the red cells. 90% of the red cells are destroyed finally in the spleen, and these are cells which are senescents. Imagine when the spleen is removed, what happens to the red cells? Do you become polycythemic? You don't. And the reason for that is there is enough reticuloendothelial system elsewhere which takes care of the red cells. However, the white cells and the platelet do go up. in a patient who has been splenectomized, and sometimes the platelets can be double than the upper limit of normal for the rest of the life, and we will discuss the harm due to that. Same thing happens to the white cells. And when these cells, which are not so good and which have to be killed by the spleen or destroyed by the spleen, they remain in the circular, it doesn't do anything good to you, it does some harm, and we'll see that. So let's begin with our first case. That's Priya, 17-year-old. She had an episode of jaundice. Her SGPT was normal. Jaundice, you go to a hepatologist or a gastroenterologist. When he looked at the SGPT, he said, this is not common community-acquired viral hepatitis. A sonography was done and the gallstones were picked up. So patient reached a surgeon. The surgeon saw her, said there is no biliary obstruction. There are gallstones, but because there is no obstruction, this jaundice is not a surgical jaundice. Then somebody looked at the type of bilirubin, it was indirect. And the moment it is indirect, it is in the domain of a hematologist. And the LDH was high. Of course, LDH is a non-specific test, but for a hematologist, hemolysis is an important cause of raised LDH. So you got a jaundice which is of hemolytic type, and the LDH, indirect bilirubin, and the spleen suggest all that. The hemoglobin was low. It was only 9.2 for a girl. She should have a hemoglobin of 12 to 14. So hematologist found first time that this patient had spleen, and the reason for that was that unlike all others, he examined the patient. And that is what a hematologist does. He takes a history, he examines, he doesn't rush with looking at the investigations. The blood film of this patient was diagnostic. Many of you might have guessed the diagnosis. This is what the blood film was. And now the diagnosis to a hematologist is absolutely overt. You have large number of cells which are small. These cells do not have central pallor, and they are dense. So this is what the red cell is of this girl. It's like a red season ball of the cricket. Normally red cells are dumbbell shaped. So in the center there is pallor, and overall the cell size is more. While here it's a sphere. So this is hereditary spherocytosis. Hereditary spherocytosis is a rare cause of hemolytic anemia. Hereditary spherocytosis is a rare cause of congenital hemolytic anemia. Hereditary spherocytosis, the diagnosis is made on clinical picture and peripheral smear. You miss the spherocytes in the peripheral smear, you miss the diagnosis. So if your pathologist is not astute, or as a hematologist you do not look at your own smears, then patients just rotate and keep searching for the etiology of so-called hemolysis without coming to the accurate diagnosis, which is one PESA test. Just stain the slide and have a look at the slide. At the same time, I must caution you, spherocytes is not equal to hereditary spherocytosis. The cells can become spherical in autoimmune hemolytic anemia. The cells can be spherical and they can be lying there for RBC enzymopathies. The cells can be spherical and they may be there for congenital dyserythropoietic anemias. Cells can be spherical in a patient who has got burns. So clinical picture is of extreme importance. The family history can be of importance because this is an autosomal dominant disease in 80% of patients. So you will have parents, one of them having spherocytes in their blood film. They might not have overtly present, but the membrane abnormality of the spherocytosis is of 80 plus types. So the phenotypic abnormality could be of 80 types. You can have an 80-year-old man who's got a hemoglobin of 15 and he may have spherocytosis. And you can have a neonatal hyperbilirubinemia going into kernicterus and developing a bad brain damage because of hereditary spherocytosis. So you can imagine from one end to the other end what can be the phenotypic variability of the degree of hemolysis. In the remaining 20% of cases which are not autosomal dominant, it may be recessive or it may be a mutation. So splenectomy is curative. This is one condition which you can challenge the diagnosis if after splenectomy the patient has not benefited. That means the diagnosis was wrong because there is hardly any failure rate. And this is one indication which has not disappeared from splenectomy. So surgeons are happy and they become friendly with hematologists that at least some indications still persist. When you're doing splenectomy for spherocytosis, you must always look at the gallstone, and if they are there, then probably you should do a cholecystectomy at the same sitting. The spherocytes don't disappear after splenectomy. They remain for lifelong. The genetic nature does not disappear. The offsprings, the children, will have 50% chance of developing hereditary spherocytosis. But the person himself, the hemoglobin becomes good. The bilirubin becomes almost normal or near normal, and so on. In that case, if you diagnose hereditary spherocytosis, should you remove the spleen? The answer is no. Because if you do not have anemia, if you do not have a problem, then why should you touch? So there comes your shrewd judgment that which patient of hereditary spherocytosis has symptomatology, would develop symptomatology, and therefore the spleen should be sacrificed. The other condition which is rare is elliptocytosis, where splenectomy is also useful, but many of those patients are mild. There are some RBC membrane disorders where splenectomy is contraindicated. It can kill the person. We'll come back to that little later on. But the conditions are stomatocytosis and xerocytosis. They are very rare. We come to our case number 2. So we now have Advika. She's a little girl of 2 years old. She had a sudden episode of relentless crying in the mid of night. Parents found that her tummy is distended and she had respiratory distress. They took her to the child specialist next door, who found that besides this she looked pale and the tummy was distended because of a very large spleen. Parents gave a history that 3 earlier children have died within 48 hours of exactly the same clinical presentation, and they were very worried. They had no live child except this little girl. Hemoglobin of this girl on that day was 2 grams, and the peripheral smear of this girl was diagnostic. And that is what the peripheral smear was. Those of you who are pathologists or hematologists, it's very clear. There are classical sickle cells. So what was this? This was a sequestration crisis of a sickle cell disease, which happens in patients who have got a severe phenotype of sickle cell disease. And this is one indication in a patient of sickle cell disease to save the life and do an emergency splenectomy. Very rarely you are able to save the spleen in a person who's got this type of sequestration crisis. Otherwise, splenectomy is contraindicated in a patient of sickle cell disease, and the reason for that is that as such the spleen undergoes autosplenectomy because of recurrent infarcts and infarcts and infarcts, and you don't want to compromise the quality of life of a sickler by causing one more addition to the risk of infection. So this little child, the parents were blessed, timely diagnosis, timely splenectomy, and they have a sickler but a child with them, and one day somebody will transplant this girl and cure her. And there are many transplanters sitting here. We move on to the third case. This is the story of Akshaya. She is adult, she is 33-year-old, but she has been a weak child from birth. Parents say she has been weak, she has been unhealthy. Her growth was not good. She was small in height. She was grossly underweight. She had an unusual face and she had a big belly. She hardly had much physical strength. She never played any sports, but she was brilliant in academics, standing first and getting gold medals all through. Often she will fall sick with short episodes of fever, during which she will become more pale and even need blood transfusion. And there were 7 such occasions where she needed blood transfusion. Recently, in last 2 years, she started needing regular blood transfusions, 26 in these 2 years. Examination showed a moderate spleen right up to umbilicus. She was labeled as a tropical splenomegaly. As a student, we learnt about tropical splenomegaly. I always wondered what that entity is because the definition keeps changing. Just you live in tropic and you have a spleen, it's called tropical splenomegaly. But I think that diagnosis is obsolete. Recurrent malaria was taught as the commonest cause of tropical splenomegaly. If you are from Bihar, UP, chronic leishmaniasis was said to be the cause. If you are from Bengal, they talked about certain arsenic contamination leading to portal hypertension, etc., causing tropical splenomegaly. That diagnosis has now disappeared. In 2025, you don't make a diagnosis of tropical splenomegaly. I don't think that entity exists. Drop of Fever, 4 hours, probably patient gets antimalarial. If not on that day, second day, third day, fourth day. If you are from that belt of leishmaniasis, everybody gets treatment for that. How can the spleen become large in this country anymore? Hematologist saw this lady and she had a classical face and a classical peripheral smear and a classical X-ray to make a diagnosis. That's her face, that's her peripheral smear on the right side, empty cells, target cells, anisocytosis, poikilocyte, a dirty looking smear, which is not close to normal at all. And you look at this face, she is beautiful, no doubt, but she has a different face. Those were her X-rays. All the ribs were expanded. You can see on the left side, you can see on the right side. They are bulbous ends in the front. This is classical thalassemia. As you know, in the morning we discussed thalassemia minor, major, intermediate and all that. This entity is nowadays called anti-DT, non-transfusion dependent thalassemia. Minor never needs transfusion, major always needs transfusion. This one needs occasional transfusion as our proband. In past it was called thalassemia intermedia, and this lady has now developed big spleen because of chronic hemolysis, has developed hypersplenism, so she's needing so much blood transfusion, and the only answer now is to remove this spleen, though reluctantly, but there's no choice left. If she was diagnosed earlier, a lot of other things could have been done, like regular transfusions or even a transplant to come to this. After having seen spherocytosis, sickle cell disease with sequestration crisis, anti-DT, let's come to the fourth case. Let's turn to the boys and the males now. So Tanish is 36-year-old man. 6 months he has been unwell with fatigue and feverishness. He was treated by his physician during these 6 months with the usual stuff, virus, malaria, enteric fever, even probably he got a short course of AKT. There was no significant relief. Then he became suddenly breathless. He was grossly pale, and there was a mild splenomegaly, just 2 centimeters spleen, but distinct. He had to be hospitalized as the hemoglobin was negligible, and the retic count, every alternate red cell was a retic, 42%. Now, this kind of reticulocytosis is extreme and strongly with this kind of background suggests hemolysis. Retic only tells you a reactive marrow, a productive marrow, a marrow that is working. It doesn't really tell you hemolysis, but this is the background with which it looked hemolysis. Once again, the peripheral smear was diagnostic. I want to emphasize this repeatedly, that like a chest physician looks at the X-ray or the CT scan, a cardiologist looks at the ECG and the echo, a hematologist has to keep looking at the peripheral smear. Hematopathologist, if he gets 500 samples a day, his machine has to tell him which smear has to be examined by him and not by the technologist. So this is here one case which was diagnosed by peripheral smear. What you see over here is a dirty looking smear. What is happening is not a bad smear, but the red cells are loving each other. They just formed clump, and in medical term you call it agglutinated RBCs. And agglutination to a hematologist means antibodies. And this patient had a strongly positive Coombs test. So Coombs test was positive. This is autoimmune hemolytic anemia. Up to the age of 33, nothing. And now, sick. With each hemolytic episode, he got fever. He became unwell, treated as infection. In tropical country, infections are common, so okay. But this patient had hemolysis, acquired, Coombs test positive, etc. Got cured with medical treatment, did not require really splenectomy. Next case. Come back to the girl, Ahana. She's 22 years old. We are now moving from the red cells to the white cells. She had nothing, but for some kind of admission, her blood counts were done. And the blood count showed that she's got leukocytosis. If I remember, it was about, it is there, 22,800. Examination showed that the spleen tip is palpable. She has nothing. She said, I'm fine, no fever, no symptoms, spleen tip 22,000. Differential diagnosis was obvious on the peripheral blood film, we will soon see. And a molecular test was done to confirm the diagnosis, which was ready by next day. She was treated with oral pills for a period of 4 years. She was cured. We followed her up for the next 5 years. There has been no relapse. She got married. She got a baby, and she is free of the disease. She has forgotten that she had anything related to her white cell. That's our girl. That's her spleen. That's her peripheral smear showing leukocytosis and the differential count, which is highly suggestive of the diagnosis. And the diagnosis was confirmed by the molecular test, which was BCR-able, shown you over here. Previously, you had that 922 translocation called Philadelphia chromosome. So your chromosome becomes small, and exactly what happens is the fusion of these two genes, BCR-able. And the treatment has varied from splenectomy to splenic radiation to hydroxyurea in between melphalan to interferon therapy to transplant, and now tyrosine kinase inhibitor. First generation, second generation, third generation, and now you have in chronic myeloid leukemia the master drug called asciminib. It's a drug which can give cure to large number of patients. They can be free from the treatment in couple of years and never relapse like our patient. She got married, had child, and no more she remembers that she ever had CML. Those were the days when the blood used to look like this, as you've shown in the test tube. The counts used to be in lakhs and lakhs, not like 22,000. And then you used to get some complicated treatment with chemotherapy, become bald like this. Nothing of that sort today. So chronic myeloid leukemia is a curable CML. Chronic myeloid leukemia, if we go into the history, is a epoch-making disease. First disease where there was a cytogenetic abnormality. First disease where there was a molecular translocation to be documented. First disease where targeted agents were used. First leukemia, which is cured in half of the patients. So this is first of chronic myeloid leukemia. There are medical oncologists in the audience, but medical oncologists have learned everything from Hemato-Oncologist. All their treatment is based on this disease. We move on to the next one, and this is story of Kabir. Kabir is 47. In 1 year, without any attempt of dieting, fasting, nothing, lost 32 kg of weight. Looking absolutely cachectic, and there was a massive spleen. Mild anemia, hemoglobin was 10. Moderate leukocytosis, just about 30,000. The peripheral film was once again strongly suggestive of what the diagnosis is. A marrow was attempted to be aspirated, but it failed. Nothing came out, even by the master guy who has done thousands of marrows. And the biopsy was done, which was diagnostic. And then a molecular test was done, which was further diagnostic. He is put on a pill. The spleen has disappeared. Not 32, 42 kgs have come back. And he looks a healthy, normal person. So this is what the appearance of this gentleman was, the front view and the lateral view. This is what the imaging showed, the big massive spleen and even the liver. And that is what the biopsy showed. And the reticulin still showed this fibrosis. This was myelofibrosis. And the test that is positive is what is called JAK2. This JAK2, the name comes from, as you see the picture over here, it's a Roman god. The Roman god was considered to be sitting on the fence, and it would look whether the enemy is coming and inform the king that yes, the enemy is coming. So it's a two-headed watchman or security person you can call. The treatment is ruxolitinib, available in this country at Jakavi, and it makes the spleen disappear. It makes your all constitutional symptoms disappear, and you gain your weight back. And this is what Kabir is after 2 months of Jakavi. We move on from two white cell disease, CML and myelofibrosis. Now we go to the next one. This is Khalifa, 57-year-old. He came from Darussalam. He had fever for a year. No diagnosis could be made in this country or in Mumbai, and therefore he dropped in. His hemoglobin was 9. His ESR was 72, all non-specific, but he had a moderate splenomegaly, and that's how he landed up with us. His workup at our hospital did not give exactly any clue to the diagnosis. Right up to PET scan, all sorts of blood tests were done. So you got a man who is unwell for a year, who's got a spleen, little anemia, high ESR, and all investigations, imaging and blood tests have failed. So what do we do now? He's come from a different country. We said that you have to sacrifice your spleen because the disease is somewhere in the spleen. He agreed to undergo splenectomy, spleen, specimen, histology, IHC, gave the diagnosis. It is now 6.5 years after the procedure. He's fine. He's got no recurrence of the disease. That was his spleen, the gross specimen. That was the cut surface, smooth, just looks like fish flesh. And this was a case of lymphoma of the spleen, what is called primary lymphoma of the spleen, called splenic marginal zone lymphoma. These patients just come with systemic symptoms and a big spleen. You don't find anything. Sometimes we are tempted to do splenic biopsy to confirm the diagnosis, a procedure which has to be taken with a pinch because occasional patients have succumbed due to a tear of the spleen, hemoperitoneum, emergency splenectomy, and so on. But in the master hand, that can also be done, and you can salvage the spleen and then treat medically. But SMZL is one condition which can be put into remission for decade by just removing the spleen. So I think the diagnostic splenectomy became a therapeutic splenectomy. These are certain pictures of other patients who have undergone splenectomy. This old lady had this spleen, which looks to a pathologist probably like a lymphoma. This was a lymphoma, but this was Hodgkin disease. And this another one which was genuinely a lymphoma, this time an aggressive lymphoma, DLBCL what we call. And this was a very, very interesting lady. She was 78, 80-year-old. This spleen was removed as query lymphoma, and what it came out to be tuberculosis. And these were all tubercles. And we couldn't pick it up anywhere, including on the usual imaging from all over. This is peripheral smear of a person which we used to in past call surgeon's leukemia. If you look at this cell, there are hairy projections. It's called hairy cell leukemia, a very rare condition. In past, we used to do splenectomy, and the patient would be not exactly cured, but would go into remission for decades. Now we have drug treatment for this, so we don't sacrifice the spleen. This is our friend from north, the leishmaniasis, which can present like this. This is sometime pediatric, sometime adult, the Gaucher disease and the Gaucher cell. This is a rare thing, spleen having a big cyst, and this is still rare, a spleen having polycystic disease. Polycystic disease affects kidney, it affects liver. Here there is a polycystic disease of the spleen and the cut surface on the right side, which looks like coconut, each one of them. Of course, this is not my cup of tea, but portal hypertension is a commonest cause of chronic splenomegaly, whether it is portal vein thrombosis, whether it is cirrhosis of liver. So every patient deserves a portal vein study by Doppler, a liver study by fibroscan, and so on before you touch the spleen. I come to the last part of my talk. Yeah, I have time. So that is splenectomy. There are types of splenectomy, and there are 4 types. When I was a student, there was only one, open splenectomy. Open, take it out. About 20 years ago, I remember our own surgeon, he went abroad, learnt, and came back and became the first laparoscopic splenectomy guy. And that was Dr. Tempton Udwadia in Mumbai. And then he taught, of course, everybody. So those days, there were 1 or 2 surgeons doing laparoscopic splenectomy, laparoscopic cholecystectomy. There was a phase, and I think it's important, it's medically very important, to do partial splenectomy or subtotal splenectomy. And the reason is very obvious, because spleen is not like appendix. When you remove the spleen, you pay a heavy price for it, and sometimes with your life. So if you can save a little part of the spleen, why not? And that's possible, and I'll explain you why it is possible. And last 10 years, we are seeing what is called robotic splenectomy or robotic laparoscopic partial splenectomy. So you got the best of all the words. So machine does it for you using the AI and removes only a part of the spleen and only laparoscopically. This is laparoscopic scar. There are 4 small scars, and which if you use your plastic surgeon with you, then probably even that is not visible. So young girls, etc., they would love it to do it this way. And that's robotic splenectomy, which is there in now 3 institutions in Mumbai itself, and maybe many more in the country. And that is like partial splenectomy. Why is partial splenectomy possible? You look at the blood supply of the spleen. The main splenic artery divides, and it goes into various parts of the spleen, and the reason for this is the embryogenesis. The spleen is formed by fusion of the splenencula that I talked to you about. And therefore, you can sacrifice part of the spleen because the blood vessels can be cut and ligated, and that will destroy only that much part of the spleen. So this is what is shown about the blood supply of the spleen and how you can probably cut and ligate few vessels and leave some intact so part of the spleen can be salvaged, which is important for preventing morbidity and mortality. What is this? This is traumatic splenectomy. It can be unfortunate. Even a normal size spleen can rupture when you're driving a scooter and you have a bad accident, injury on the left side, and this can lead to exsanguinating hemoperitoneum, and you can succumb even before the diagnosis is made. In these cases, the fortunate part of it is when the spleen ruptures, cells of the spleen deposit in the peritoneum. So when you remove the main spleen, if you have to, those deposited splenic cell can develop and regrow into splenenculi. And the chance of these people then getting post-splenectomy complications are less than the medical splenectomy where you remove the whole stuff. One of the forgotten indication, which I didn't talk to you about, is the platelets. When we were students in ITP, the treatment was splenectomy. Now, there is a treatment, splenectomy. Where is it? It's at the bottom. And the reason for that is two discoveries. One is rituximab and one is Altrambopag. Those who are into hematology or medicine or pediatricians, they know very well. They are TPO-RA, thromboplastin receptor analogs, given by mouth or injected once a week like romiplastin. These can improve your platelet count in 80 to 90% of patients, and they are not immunosuppressive. All the treatment of ITPs are immunosuppressive, but this is not. And this is a long-term treatment. For chronic, recurrent ITP, this treatment can go on and you can give it for years. It's like managing diabetes with metformin, I talked in the morning. Cyclosporin, rituximab, 4 doses, and more than half the patients can go into complete remission for a year. And you can probably give 1 dose of rituximab every year or every 2 years to keep these patients going on. What I'm trying to say is the splenectomy has become very, very obsolete in patients of ITP. You do it reluctantly. Can splenectomy be done during pregnancy? Yes. During second trimester is the best time. In the first trimester, anesthesia cannot be given. In third trimester, the uterus comes in your way. When you can't do splenectomy, you can embolize the splenic artery. It is painful. You have to give strong painkillers. You have to also take care that this infarct does not get infected and develop a splenic abscess. That's the price you pay. So you reluctantly can embolize the spleen when you can't do splenectomy. Patient is not fit for it. What are the problems of splenectomy? Why are we discussing so much? The problems are a couple of them. Perioperative morbidity and mortality. Patients can die on the table or immediately after the surgery. 10% of patients of myelofibrosis can die during splenectomy, which was a fashion in past. And then this OPSI, which has never disappeared, the overwhelming post-splenectomy infection. You give pneumococcal vaccine, you give meningococcal vaccine, you give an influenza vaccine, you keep them on penicillin prophylaxis, but you lose some patients suddenly of infections. And then this thromboembolism I talked to you about, the senescent red cells surviving, these are abnormal cells. There are normoblasts in the peripheral smear. There are precursors of white cells now lying in the circulation. There are large platelet and increased platelet count. All of these are thrombogenic. All of these. The red cell membrane is the most thrombogenic. They can develop pulmonary hypertension. Once pulmonary hypertension, it is always irreversible. It leads to cardiac failure sometime. I talked to you about portal vein, splenic vein, mesenteric vein thrombosis that happens. And even the DVT and PE then can happen. Arterial side, there is an increased incidence of thrombosis. So the moment you remove the spleen, you are inviting and you are making the patient a prothrombotic, as if he is factor V laden, as if he is an antiphospholipid antibody syndrome patients. Pneumococcal sepsis can take place 10 years and 20 years after losing the spleen. A patient can die in 4 hours. And from that angle, it's extremely important that you avoid splenectomy when avoidable, and we already talked about pulmonary hypertension. All patients who have lost their spleen should have a band that he does not have a spleen or his spleen has been removed, so that any time he's found somewhere on the roadside, etc., the person knows what has happened to this person. There is an idiom, vent your spleen. What does it mean? It means vent out all your anger. The spleen was considered the site of anger, traditionally. So if somebody is shouting, howling, you can patiently listen to that person, allow him to speak or shout or crib as much as possible, and this idiom is used to vent out your spleen. And that's my last slide. Paris spleen. You tell me what it means, and on behalf of Mumbai Hematology Group, we'll give you a check of 5,000 rupees for the correct answer. Time is up. Nobody wants to say anything. Very interesting story. You have the name of the writer on the top there. Charles Baudelaire. Born in Paris, a Frenchman, a poet. He has written small poets, multiple of them. They all are sad poems. They are all poems which are melancholic. They give you very negative messages. And this is a volume which contains all those. This is in 19th century, early 19th century. Paris is a city of love. If you are in love, it's Paris. You have all the dramas with love in Paris. You have all the novels written on love, it's in Paris. You have all the films which are made about love, it's in Paris. And the Eiffel Tower stands for love. So Paris is the love country. This gentleman in late 19th century wrote this book. It is believed, no one knows, it's believed that probably there was a failure in love, and therefore he wrote all these poems. And this volume is called Paris Spleen, based on this. Spleen is melancholia, and Paris is this gentleman's birthplace. So that is Paris Spleen. My 5,000 remain with me. Thank you so much.
Thank you so much, sir, for interesting lecture. So now the house is open for discussion. Any questions from audience?
Yes, please. I will repeat your question. You can just speak out. In leukemia, is there an indication for splenectomy? So a short answer is no indication whatsoever. Acute leukemia, there is no question. Chronic myeloid leukemia is curable by medical means. Myelofibrosis, today you have powerful drug to melt away the spleen, which is touching the right hypochondrium, you've gone into the right iliac fossa, etc. Hairy cell leukemia, occasionally we have still done splenectomy because it gives you remission for 1 decade and more, but only after failure of all the medical treatment and the relapses occur. We still have 3 or 4 lines of treatment like cladribine, interferon, alkylating agents, and we are now targeted molecules. So even that condition, the splenectomy is usually not done. So in short, yes, we don't touch leukemic spleen for splenectomy.
Last week, I'm associated with one of the hospitals. So there was a case of leukemia. I look after the lab there. And there was a sudden drop of hemoglobin till about 2 grams and a splenomegaly, and the consultant asked me, we plan to do a splenectomy, what is your advice? I said, I'm not the right person. Maybe patient will go into a lot of. They did a splenectomy, and now they say that in the last 3 days, the hemoglobin has stabilized and improving.
So a case like this I showed you, I'm not saying that that patient has sequestration crisis of sickle cell disease, but sickle cell disease with sequestration crisis can present with hemoglobin of 2 and can benefit from, life can be saved by doing splenectomy. Autoimmune hemolytic anemia can present with 2 grams of hemoglobin, and splenectomy can sort of settle the patient or even cure the patient. But again, we have medical means, so we don't do that anymore. What else can I think of? 2 grams of thing and the things.
This patient was a case of leukemia. I don't know exactly what leukemia, but was on treatment.
Okay.
And within half an hour of talking to me, they did a splenectomy. And
what
then they
happens
asked me,
is that
how
sometimes
do you follow up this case from the lab point of view?
Yeah. So what happens is nowadays the indication of a procedure, a test or treatment is that the patient has entered your chamber. That's enough. I've seen transplanters saying, come on, get your donor, your brother, sister, HLA typing, you need a bone marrow transplantation. And next day you come to know that it was not myelodysplastic syndrome, it was iron deficiency anemia. So there are examples galore where whatever you are doing, the patient, nothing against transplanters, but whatever you are doing, you are tempted to stimulate the person into that direction. Say thalassemia. Things have changed. Now thalassemia is cured by transplants, but I remember 10, 15 years ago, there was a war, including in the journals. The hematologist will say medical treatment. The transplanter will say transplant the patient, cure the person. Sickle cell disease, same story continues even today. So yes, the indications are very often that the person must have been with a surgeon.
Yes.
That's enough.
Thank you.
Any more questions? Sir, here, sir. Sir, in regarding pancytopenias in splenomegaly, and especially in cirrhosis patients, like when do you suspect a second pathology apart from splenic sequestration or induced cytopenia?
So portal hypertension of any type, including cirrhosis of liver or portal vein problem, you get a large spleen and you get hypersplenism, counts go down. In most of these conditions, the RBC morphology is normal. The hemoglobin is down to 6-7 grams. The WBC count is down to 2,000-3,000, sometimes maybe a little less than 2. The differential count is maintained. The polymorphs are more than lymphocytes. There are absolutely no abnormal cells whatsoever. The platelet count is moderately down, 30,000 to 60,000, and again with a normal morphology. So if you have this kind of picture, probably I don't expect anything else. But if I have, say, polymorphs are 20%, lymphocytes are 80%, now I'll be seriously concerned whether this is a lymphoma and this is secondary portal hypertension. So some suspicion comes from somewhere that, okay, there is something else. I should investigate this patient with a bone marrow, PET scan, etc., etc. But otherwise, straightforward case, you can pick up and you will be mostly right.
Sir, if myelofibrosis, if medical treatment, Jakavi is not working, with massive splenomegaly, is there any indication for splenectomy?
I'm very reluctant about doing splenectomy in myelofibrosis for two reasons. One, 10% mortality on the table or in the perioperative shape. Two, within 3 months, the liver becomes massive. And now what do you do? So you didn't really give something great to the patient except a very painful spleen. The spleen is large, is different, but the spleen is painful, then it's a problem. But how to live, make the person live with the pain? So infarcts have taken place, spleen is very painful. Sometimes those infarcts have become abscesses. You may have to sacrifice the spleen with the risk of dying on the table, dying in the perioperative period, and the cost of hepatomegaly, no addition to the lifespan whatsoever. So nowadays, if there is a bad case of myelofibrosis, you rather rush with a bone marrow transplant and cure the person with its morbidity and mortality than to allow all this to happen. But yeah, sometimes you see patients in this country who have come very late and you have a problem. They can't afford Jakavi. There's so many things. So in practice, things happen. Done.
I think we will end the session. We'll take the questions on the later half, if any. Okay.
Next lecture by Dr. Pravas Mishra, Amrita Hospital, Faridabad. The Art of Reading CBC, a Clinician's Guide. We welcome Dr. Pravas Mishra onto the dais.
Thank you so much. So I'll explain why Hyderabad has a very dear place in my heart, so far CBC is concerned. So when we are doing MD in medicine, we all want to be cardiologists, at least during my time. ECG was the biggest charm that would be there. Everybody would be experts on reading an electrocardiogram. And when I was doing my MD in a rural hospital, hemogram would come on a small slip of paper, just one stamp. Hemoglobin, TLC, possibly some DLC, that counter is there, and a platelet count. That is all, no big problem. Suddenly one day, the hospital got a counter. And then we started getting this whole page of so many numbers and, MCV, MCHC, RDW, whatnot. And ECG lost all its charm so far I was concerned. I wanted to be an expert on this particular piece of paper. But what to do, not understanding anything. That's where Hyderabad came in. During my MD in medicine, I had 2 months posting with Dr. J.M.K. Murthy in neurology in Nizam's Punjakuta. I don't know how many of you know him. He taught me how to take a history. He said, MRI to baad mein aayega, that is later on. First you take a history and make your diagnosis. Then you look at the MRI and confirm your diagnosis. I used the same thing. He tried to encourage me to join neurology, but I was already in love with hematology. So I went back and applied the same rules and regulations to reading a CBC. Dr. Agarwal said that you have to, all hematologists, again, all apologies to medical oncologists here, but hematologists will take a history, examine the patient, and then look at the hemogram. So after that, there was no looking back. I came to AIMS, did my DM, and here I am. So without any further ado, we'll go to the hemogram or the CBC. So this is whether it is a male or a female. All the numbers will be the same, except for the hemoglobin. For a female, you start saying that it is anemic. if the hemoglobin is less than 10, so for females it is around 12 to 15, for males it is around 14 to 17. Everything else remains the same. In a hemogram, you would have MCH, that is the mean corpuscular hemogram, MCV, that is the mean corpuscular volume, MCHC, the mean corpuscular hemoglobin concentration, RDW would be the red distribution width. I'll be explaining all this. TLC, the differential count, the platelet, the reticulocyte count is not, it does not come with the hemogram, by the way. You have to ask for it. The RBC count. So all of these figures are there, and you look at these figures and try to see what is going on. Now this is of course a lecture for not hematologists and oncologists, but primarily for pediatricians, physicians, and maybe gynecologists. Various of all of these red cell indices are calculated. So you've got an MCV, you've got a hematocrit, you can calculate the RBC number in millions, you can calculate the MCH, you can calculate the MCHC. What is red cell distribution width? You have heard of anisopoikilocytosis in the peripheral smear. So this red cell distribution width is nothing but that anisopoikilocytosis that you are looking on the peripheral smear. So if your red cell distribution width is increased, that means there are several RBCs of various shapes and sizes within that peripheral smear. It could be microcytic, it can be macrocytic. But if the RDW is within the normal range, that means all your RBCs are of the same size. They can be again small, they can be large, they can be normal size, but they're all of the same size. This is what red cell distribution width will tell you. So when a peripheral smear says anisopoikilocytosis, you can look at the counter and say this is what there is. The other important thing that will help you is the reticulocyte count. The reticulocyte count, whatever number you get, that is not the final reticulocyte count. You have to correct it for your anemia, right? So your hemoglobin is low, the reticulocyte count is there, so how do you calculate it? So whatever the reticulocyte count is, you have to use the patient's hematocrit or the hemoglobin. Remember the rule of 3. If you don't have the hematocrit, no worries. If you got the hemoglobin is 15, your hematocrit will be 45. So percentage reticulocyte count multiply by the patient's hematocrit, divide by the 45. This is what will give you the corrected reticulocyte count. So I've got 3 examples here. So the hemoglobin is 3, hematocrit will be 9, reticulocyte count is 5%. Up till 0.5 to 2% is a normal retic count. So here you would say that the retic count is increased, but you correct it. For the hemoglobin, the corrected reticulocyte count is only 1%. Then the second example, hemoglobin is 5, hematocrit is 15, retic is 1. Here again, you see the corrected reticulocyte count, it is actually reduced, 0.3. And in the last example, where the hemoglobin is 3 and the reticulocyte count is 15%, the corrected reticulocyte count will be 3%. So this is again actually increased, right? So this is how you look at. So previously in the previous talk they told you reticulocyte count just tells you the general health of the bone marrow, whether it is functioning well or not. Broadly speaking, using the MCV, the mean corpuscular volume, you can differentiate all your anemias into 3 broad groups. Simplest is the one in the middle, hypochromic microcytic, just 2, iron deficiency anemia or thalassemia. Could be some sideroblastic anemias, but commonly these are the 2. Macrocytic would be, the vitamin B12 deficiency, folate deficiencies, some myelodysplastic syndromes, marrow failures, leukemias. But the most anxiety-provoking hemogram for physicians or pediatricians would be the normocytic normochromic anemia. That is where all your diagnosis is going to be there. So in the normocytic normochromic anemia, you would have anemias of chronic disease, you would have malignancies, endocrine problems, hemolytic anemias, anemias of acute hemorrhage, myelomas, MDS, everything. All of that is in that normocytic normochromic anemia, and this is where your history taking skills, your examination, and then you look at the CBC and the peripheral smear to come to a diagnosis. We'll just complete this topic with various examples. So this is a 34-year-old who had repeated blood transfusions, and you look at the hemogram here, hemoglobin is 5. I straight away look at the TLC and the platelet counts, that is normal. Differential count is normal. The MCV is 86. So MCV is 86, it's a normocytic normochromic anemia. I look at the health of the bone marrow by looking at the reticulocyte count. For a hemoglobin of 5, the reticulocyte count is just 1, and if I correct it, it is even lesser, it is about 0.3 or 0.2. I look at the RBC count also, it is 1.89. So this is a 34-year-old, repeated blood transfusions, no splenomegaly, no hepatomegaly, no lymphadenopathy, comes to us with a normocytic normochromic anemia and a very reduced RBC count and a reduced reticulocyte count. This was a case of a pure red cell aplasia when we did the bone marrow. 47-year-old alcoholic. I've removed certain things because those are not important. We only will look at certain pictures. So here we see that the MCV is 135. So this is a macrocytic or a megaloblastic kind of a picture. We look at the total leukocyte count. We look at the platelet count. Those are also reduced. You look at the reticulocyte count, that is 1. So this is again a bone marrow which is functioning, it is hypofunctional, right? And then you look at the LDH. LDH is 2,500. It is very high. Does that mean hemolysis? No, not necessarily, because the reticulocyte count is actually reduced. LDH is just a tissue injury. So this is a patient who has got a megaloblastic anemia. 47-year-old alcoholic, you could have a vitamin B12 deficiency. This is again a 55-year-old who has repeated blood transfusions for the last 6 months. There is no lymphadenopathy, there is no splenomegaly, no hepatomegaly, just repeated transfusions every month. He comes to us, and we have got a hemoglobin of 10.2. The WBC count is normal, is also reduced, 2,910. The platelet counts are also reduced. And here you look at the MCV. This is again a somewhat macrocytic kind of a picture, 105. Reticulocyte count is also reduced. So this is again a hypofunctioning bone marrow. And since we looked at the peripheral smear, again normocytic, normochromic, we started to look at some dysplastic looking, abnormal looking WBCs on the peripheral smear. We did a bone marrow. This was again a person with a myelodysplastic syndrome. 17-year-old. There was one report of a low vitamin B12. Look at the hemoglobin, that is 3.4. RBC count is also reduced. The TLC is 3,900. The platelet counts are also reduced. Vitamin B12 was around 59 or so, but the child had already received several vitamin injections, shots had been given, but there was no improvement in the hemoglobin. And you look at the MCV again, MCV is 123. So this is again a megaloblastic or a macrocytic kind of a blood picture in a 17-year-old whose vitamin B12 has not, despite correction, has not improved the hemoglobin or the TLC or the platelet, and the reticulocyte count is also reduced. So a hypofunctioning bone marrow in a child with a pancytopenia kind of picture. This was a person with a hypoplastic marrow or an aplastic marrow. So we did a bone marrow, and that is what there was. This is a 56-year-old who had severe fatigue. Look at the hemoglobin, that is 5.7. The total leukocyte count is 7,600. The platelet count is raised, it is 9,000, it's about 9 lakhs. Reticulocyte count is 1%. You look at the MCV, it is 72. So this is a microcytic kind of a blood picture. Reticulocyte count is reduced. This is what would be a patient with an iron deficiency anemia. So microcytic anemia and iron deficiency anemia. Similar picture in another 57-year-old who had come to us for a routine check pre-surgery. Here the hemoglobin is 9.5. Look at the MCV, it is 57. The TLC count is normal, platelet count is normal, the reticulocyte count is 2.3%. You start thinking, what is happening here? So this is a microcytic kind of a blood picture. Look at the RDW here. The RDW is 13. So this is within the normal range. Look at the previous one, where the RDW in this microcytic, picture, the RDW was raised, 15.9 in iron deficiency. So there was anisopoikilocytosis. Here in this case, this is a thalassemia trait or a thalassemia minor. So that is why all the RBCs are of the same small size. So the RDW is within the normal range. This is a person, this was in the previous talk you had somebody with an autoimmune hemolytic anemia. This would be the CBC of someone with an autoimmune hemolytic anemia. So this is a 34-year-old male who came to us with repeated with anemia, repeated blood transfusions. Despite giving blood, the blood is, the hemoglobin is not going up, might be slight icterus that you could see. Examine the patient, a little splenomegaly, and you look at this hemogram. Hemoglobin is 4.5, RBC count is fairly normal, MCV is 104, somewhat macrocytic, the TLC, the platelet count is normal. The clue to the diagnosis comes from the reticulocyte count, which is 20%. You correct it for the hemoglobin, it is still raised. You do a Coombs test in this patient, the Coombs test will be positive. This is an autoimmune hemolytic anemia. Now, hemogram alone, now I start to introduce another concept. Your history is important, but reading a hemogram, you also need to have certain other ancillary investigations. Could be a liver function test, could be renal function test to come to a diagnosis. This is a postpartum with renal failure and was sent to me primarily because of the very low platelet count that you can see, 9,000. Now this low platelet count, the patient had hardly any bleeding. There were few spots, red spots here and there, but the hemoglobin was low, 7.9. The total leukocyte count was otherwise fine. The platelets were very reduced. We looked at the peripheral smear. There were several cystocytes. So this was essentially someone with a HUS. So you got an atypical HUS in pregnancy. So you start doing plasmapheresis, you exchange with plasma exchange, and then this person improves. Elderly frail man with lymphocytosis, so you start looking at the TLC count, which is very high. Most of them are lymphocytes. You look at the platelet count, 89,000. Hemoglobin is 7.9. Again, here you look at the MCV. The MCV is 105. This is a macrocytic kind of a blood picture. Reticulocyte count is 2, so there is no autoimmune hemolytic anemia. This is CLL. But there is no autoimmune hemolytic anemia because the reticulocyte count is not increased. Essentially here, the hemoglobin and the platelets are low because of the infiltration of the bone marrow by the lymphocytes. This is someone who was referred to us from nephrology, chronic kidney disease, repeated dialysis. Hemogram shows the hemoglobin is low. Hemoglobin is 7.7. MCV you look, that is normocytic anemia. So TLC is normal, the platelet counts are normal, reticulocyte count is 2, so the ferritin is raised. So this is a normocytic normochromic anemia in a person who is having repeated dialysis. This is anemia of chronic disease. So you can get similar picture in various other conditions like connective tissue disorders, endocrine problems, heart failures. You'd have this kind of a picture where ferritin is raised but the iron is low because of the inflammation. The bone marrow is not able to utilize the iron, but the ferritin is increased. So this is anemia of chronic disease. So for any normocytic normochromic anemia, in addition to looking at the history and the examination, this is the kind of a investigation pattern that I have, which also includes particularly for those with a normocytic normochromic or somewhat macrocytic anemia with no pancytopenia. I would also include protein electrophoresis and look for a myeloma in these patients. Using this, we had a 68-year-old male, 6-month history of pallor and fatigue, never transfused till presentation, liver and spleen were enlarged, so approximately 4 centimeters below the costal margin. The ultrasound showed a hepatosplenomegaly and no liver changes. This was the hemogram that we have. So if you look at the hemogram, again, here the hemoglobin is 5.9, the RBC count is 1.96. This is again a normocytic normochromic anemia, but now I start looking at the differential count at the bottom, and I start seeing that there is a lot of left shift. I start looking at myelocytes, I start looking at metamyelocytes. So I immediately start thinking of a myeloproliferative disorder. The reticulocyte count here is also normal. And when we did the bone marrow, there was myelofibrosis in this. So this was a myelofibrosis with a left shift, normocytic normochromic anemia with left shift. Similar picture, 56-year-old, massive splenomegaly at presentation, repeated blood transfusions. This lady came to us with a big spleen. However, when we looked at the hemogram, again this is a chronic myeloproliferative disorder. What else could it be? I looked at the reticulocyte count, that was also fairly normal, just a little bit raised. The peripheral smear did not tell us any clue. The Coombs test was also negative. The LDH count was also normal. The kidney functions tests were also normal. I do a liver function test, that also did not give us any great indication. The proteins were somewhat normal, but the albumin was a little reduced. The LDH was also a little raised, it was 331. I do a protein electrophoresis in this patient and I find a IgM type of a M band. So IgM kappa is there. So this was essentially a patient with a lymphoplasmacytic lymphoma, or what we commonly call a Waldenstrom's macroglobulinemia. So this is again a patient who can come to you with a big spleen. This is again a 52-year-old. I think I'm coming to the end. I can skip this. So this is a 61-year-old, again fatigue for 6 months, diabetic foot, abdominal complaints. So their ultrasound was normal, underwent an endoscopy, received iron and vitamins, despite which the hemoglobin kept on dropping. The liver and kidney function were normal. Here this was a blood picture, which was otherwise pancytopenic, and the peripheral smear did not show us anything. The reticulocyte count was also reduced. LDH count was almost normal. So this was somebody who had a bone marrow where it was hypoplastic. So this was again an aplastic kind of a blood picture in an older person. We also did certain cytogenetics and molecular tests. So ultimately, whenever we are trying to interpret a CBC, so the interpretation of a CBC is never in isolation. You have to have the history and examination of the patient. You look at the CBC, you look at the other organs, you look at the liver function test, you look at the kidney function test, you do the LDH, reticulocyte count. And only in this complete paraphernalia, once you have all of these reports, you would be able to actually diagnose what your person is having by looking at the CBC report. Again, if you have access to a peripheral smear, you look at your peripheral smear itself, that itself will be giving you a lot of information. Thank you so much.
Yeah, thank you, Dr. Parvez. That was an excellent actually overview of how to read an art of a CBC, and that gives a clue inside the clinical areas. So any questions from the hall? So I think in view of time, I think we'll take on to the next talk.
RDW is reliable, sir.
Oh, thank you. Yeah.
RDW reliable, sir. Can it definitely differentiate hemolytic and other anemias?
Yes, as I said, the RDW just tells me that there is a lot of anisopoikilocytosis. It just tells me whether there are different shape and sizes of the RBCs that are there. But based upon the RDW, I will not be differentiating whether this person has a hemolytic anemia or something like that. RDW can be raised in iron deficiency anyway. That is typically that you would see. It could be raised in megaloblastic anemia.
Even in MDS and B12 deficiency also, there will be some confusion, sir.
Yes, yes, of course. So when you get a megaloblastic, a macrocytic kind of a blood picture, commonly they would come to me only after they have received a lot of vitamins. So, you would have done like I showed you one example of that 17-year-old who had a vitamin deficiency, B12 deficiency. They corrected it, but still the pancytopenia did not correct. And then you look at the peripheral smear, you would see Cabot rings, you would see dysplastic myelocytes, and that would be true for both MDS as well as for megaloblastic anemia. I have seen several patients who have been diagnosed as acute leukemia, where they are actually megaloblastic anemia by just looking at the bone marrow. So one has to be very careful there.
And thank you, Dr. Parvez, and that was an excellent talk. So we'll move on to the next talk for the lack of time. At this point of time, we'll invite Dr. Mallikarjun Kalasetti, who has been a part of the Manipal group of hospitals in Bangalore. Over to you, Dr. Mallikarjun, for the next talk, that is leukocytosis and leukopenia. When to worry and why to worry. After RBC, we will move on to a white cell count. Over to you, sir.
Good afternoon. Thank you, Chairperson. At the outset, I would like to thank Dr. Ganesh and the organizing team. Some of the scenes I've seen here are unprecedented. I think at this rate, next time it will be Chiranjeevi, Allu Arjun talking on CLL and CML very soon. So congratulations on putting up such a show. So Ganesh has asked us to worry about something, but modern day mantra is stop worrying. And Trump says, do whatever you want to and live like king. Don't care about the rest of the world. Yeah. So I think we should be a little careful. So leukocytosis will go, sometimes more is not merrier. So we'll talk about leukocytosis a little bit and then you go to leukopenia. So we all know leukocytosis is elevated white cell count, more than normal range. And depending on what is the predominant white cell count which has gone up, you divide leukocytosis into neutrophilic leukocytosis, which perhaps is the most common one because of varied etiology. You have lymphocytic leukocytosis, you have monocytosis related leukocytosis, and eosinophilia related leukocytosis too. So these are the common subclassifications of leukocytosis. Bispecific is extremely rare. So when to worry? If the patient has an extremely high count, more than 100,000, more than 200,000 persisting without rhyme or reason, you obviously think this is a serious medical condition. Patient has persistently white cell count despite recovery from infection, or for no reason at all. There is no evident infection, fever, no other symptoms. Patient has presence of abnormal cells in smear, so this regardless of the number. So sometimes count could simply be 30,000 or even 18,000. However, there are 20% blasts on the circulation, so you would worry. So if there is any abnormal cell which is detected, or the pathologist calls you and tells you that there are blast-like or blastoid cells, you would worry. Patient has bad persisting constitutional symptoms, loss of weight, loss of appetite, drenching night sweats, repeated infections, then you start worrying about leukocytosis, presence of lymphadenopathy, organomegaly, bone tenderness. All of those are telltale evidence of something sinister brewing inside. So extreme high count and other associated symptoms, you start worrying about leukocytosis. So like I mentioned, neutrophilic leukocytosis is the most common cause for the leukocytosis, and ANC more than 7,000 is something that we look for. So most common cause in all hospitals and for all practitioners is infection, and indeed neutrophilic leukocytosis with lift shift is seen in most infections. However, again, pathologists will tell you that the smear does tell you the evidence of toxic granules, Dole bodies, cytoplasmic maculation. So it is very important whenever you have a hemogram or CBC, ask the pathologist to look at the smear. That can give you clue to many things. So inflammation, autoimmune conditions, all of those can cause neutrophilic leukocytosis. And I think many of us do look for CRP, procalcitone, and ESR, which can give the corroborative evidence of neutrophilic leukocytosis being driven by an infection. Many medications, commonly, I think steroids all of us use, causes neutrophilic leukocytosis. Growth factors, for given any reason, when you continue beyond the improvement of the count, can increase the count. That is something that one needs to look at. So Dr. Abkarwal has told us splenectomy can cause thrombocytosis and leukocytosis for a very period of time. And of course, the primary myeloproliferative disorders are something that one has to look for, apart from the rare primary immunodeficiency disorders causing persisting neutrophilia. And when you talk about myeloproliferative disorders, I think chronic myeloleukemia, polycythemia, essential thrombocythemia, myelofibrosis, I think a lot of the speakers have already spoken to you about those. So this is something for us to remember, depending on the patient profile and the counts that the patient presents with, apart from the clinical examination, which tells you whether the patient has splenomegaly or not. So there are also atypical myeloproliferative neoplasms that one needs to keep in mind, including the overlap syndromes in some of these patients. Switching gear, lymphocytosis. Again, the infectious diseases are common. Viral infections can cause lymphocytosis. However, the clonal process is what one is worried about. So if patient has absolute lymphocyte count less than 5,000, however, immunophenotyping tells you those are monoclonal. You worry about monoclonal B lymphocytosis. Nothing much needs to be done. However, patients can also have large granular lymphocytic leukemia. Chronic lymphocytic leukemia is one of the commonest things that a physician would see elderly individuals for no rhyme or reason when they have done a health checkup. They have high count with 70-80% lymphocytes, have no symptoms at all, could be having early stage chronic lymphocytic leukemia, which does not need to be treated at all. There can also be indolent non-Hodgkin's lymphomas with leukemia phase, like mantle, follicular, marginal zone lymphoma, where patients can have lymphocytic leukocytosis. Hypereosinophilia is something that all of us worry, and patient, when it comes to us with hypereosinophilia, sometimes it can be unnerving just to get to the diagnosis. Again, what you do not want to do is miss a clonal process causing hypereosinophilia, like chronic myeloid leukemia, chronic eosinophilic leukemia, AML with eosinophilia, MDS with eosinophilia. So make sure that you're not missing a sinister problem causing hypereosinophilia. Having said that, oftentimes drugs, infections can cause transient eosinophilia, where one doesn't need to bring down the roof at all. Parasitic infections, other infectious disease, and allergic and atopic disorders can also cause hypereosinophilia. Monocytosis is not very common, however, when it occurs. Again, you have to look at transient infection-related causes, autoimmune causes, and then look at the clonal disorders. Chronic myelomonocytic leukemia is something that has to be looked at when patients have persisting monocytosis in elderly, along with other conditions which can cause this as a part of clonal disorder. So we'll go through a few cases quickly. I think some of these would be repeats. So this was a 50-year-old man with no significant medical history at all, was brought to adult emergency with progressive headache, confusion, and stupor really. And the symptoms could have worsened in the last 24 hours. He also had some dyspnea on exertion and occasional easy bruisability. So vital signs are fairly okay. However, he had some drowsiness, arousable though. He has tachycardia, tachypnea, but multiple ecchymotic patches. So if you see, there was hypoleukocytosis, total count was 175,000, anemia and thrombocytopenia. And then when you look at the peripheral smear, there were circulating blasts with R rods. There were no cystocytes suggesting microangiopathy. And patient had some coagulopathy, azotemia, LDH was very high, and there was metabolic acidosis too. And the imaging in view of altered sensorium showed evident cerebral leukostasis and pulmonary leukostasis, and bone marrow confirmed diagnosis of acute myeloid leukemia. Immunophenotyping, cytogenetics, and molecular testing confirmed a high-risk AML with FLT3 mutation. So in view of hypoleukocytosis with leukostasis, the patient he underwent leukophoresis about a couple of sessions, followed by induction chemotherapy, which led to a rapid improvement in his general condition. This is something for us to remember. Very high count, altered sensorium, sometimes dyspnea, could indeed be signs of leukostasis, which needs to be treated immediately. So such patients can improve on right treatment. So this is another young person with no significant past medical history, came following a health checkup in view of leukocytosis. Clinical examination revealed splenomegaly. I think we have seen this. He was well appearing, splenomegaly on examination, left shift, high count, and bone marrow confirming chronic myeloid leukemia and chronic phase perhaps. So Philadelphia chromosome, I think we have spoken about the shortened 22 chromosome because of translocation between 9 and 22 confirms the diagnosis of chronic myeloid leukemia. And you also do genetic tests both for diagnosis and following these patients once you start treating them with targeted therapy. So imatinib is one of the few drugs which appeared on the Time magazine, which Dr. MBA was alluding to, when you started treating the heart of the cancer rather than giving them carpet bombing with conventional chemotherapy. This was an elderly gentleman who had hypertension and some kidney disease, had 6 months history of progressive fatigue, unintentional weight loss. He also had mild exertional dyspnea, vitals were fairly okay, but then he had cervical lymphadenopathy and mild splenomegaly, high count, lymphocytosis, mild anemia. As you could guess by now, he had lymphocytosis on the peripheral smear and smudge cells. Immunophenotype confirmed patient having chronic lymphocytic leukemia, and Marrow confirmed the same. And we always want to see whether the CLL has 17p or TP53 mutation. Those patients have high-risk CLL should be treated very differently. So this patient had CLL, which is symptomatic, requiring therapy. We already discussed asymptomatic CLL patients need not be treated. And this patient was elderly, had comorbid illnesses, was treated with BTK inhibitors, which have indeed changed the paradigm of treatment of chronic lymphocytic leukemia. Leukopenia, again, so the other end of the spectrum where the counts are low, and again, not all low counts are sinister, not all low counts mean bad diseases, but we need to look at the patient in toto rather than the numbers alone. So neutropenia again could be, leukopenia could be neutropenia, lymphopenia, and other cell lines being low. I think neutropenia is indeed the most important one because the risk of infection improves quite dramatically as the neutrophil count becomes lesser and lesser. And if the patient has severe or very severe neutropenia with ANC less than 500, 200, such patients can have what we call neutropenic infections, which can be life-threatening in no time at all. So primary leukopenia is something that pediatricians will deal with. The secondary neutropenia or serious bone marrow problems causing neutropenia like aplastic anemia, myelodysplastic syndrome, infiltrative disorders of the bone marrow like leukemia, metastatic disorders are something that one wouldn't want to miss. Almost every drug can cause neutropenia, so it is indeed important to see if there was a temporal association between the initiation of a new drug and onset of leukopenia, neutropenia. Viral infections, autoimmune conditions, nutritional deficiencies are rare causes. Sequestration because of a big spleen in cirrhosis of liver is another common cause. So I think a couple of more cases we have. 5 minutes is there. So 28-year-old male had no significant past medical illness, came with progressive fatigue, some bleeding symptoms, anemic symptoms, no other issues. His general examination showed multiple ecchymotic patches, no nodes, no organomegaly. And look at the count, there was pancytopenia with significant neutropenia and thrombocytopenia. I think again we have discussed, so bone marrow confirmed diagnosis of severe aplastic anemia, and such patients who are young, who have an appropriate HLA matched donor should be treated with allogenic bone marrow transplantation, which can be curative in these individuals. This was a young lady who postpartum was hospitalized actually in our ICU with history of bleeding symptoms, shortness of breath and dizziness, had fatigue, had pallor, had of course evident bleeding from skin and mucocutaneous areas. And if you look at the numbers, she had anemia, cytopenia, coagulopathy, and D-dimer was markedly raised. And given the clinical profile, we always wonder whether the patient had postpartum sepsis with DIC. However, when you look at the peripheral smear, the pathologist would call you and tell you that there were abnormal promyelocytes on the smear. So what you are actually dealing with is acute promyelocytic leukemia presenting as DIC and bleeding symptoms. So such patients should indeed be treated with clone-directed therapy as soon as possible, and diagnosis is confirmed by genetic confirmation of these disorders with PML-RARA demonstration. So we must aggressively treat with blood products to reduce the risk of bleeding. The most feared bleeding, of course, is intracellular hemorrhage, which can be life-threatening. And of course, low-risk acute promyelocytic leukemia, you treat them with chemo-free protocols of ATRA and ATO. So summarizing, so leukocytosis and leukopenia can be because of varied disorders which can have presentations which are very different. So one must always look at the patient profile and the temporal profile of illness rather than looking just at number. And sometimes there is more than what meets the eye. It is indeed important to look between the lines and make sure one doesn't miss diagnosis. So systematic clinical evaluation, laboratory evaluation is indeed very important for diagnosing these patients and treating them early and promptly with appropriate treatment. I thank you all for being here, and thank Dr. Ganesh and organizing team for this wonderful CME. Thank you.
With accompanying case, it is important. Any questions?
So,
Yes,
I'm
sir.
a pathologist.
Yes, sir.
Every day in my lab, I see adult male and female patients with lymphocytosis. I don't understand what adult patients, male or female, only lymphocytes increase. Is it due to any environment problem or something else? I don't know. Just for your knowledge.
Yes, sir. Yes, sir. So I think it is important to look at those hemogram with the background history. Young children up to the age of 5 years, they would have lymphocyte predominance, and that is a normal thing. Beyond 5 years, the neutrophil predominance starts. Number 2, most viral infections can have transient lymphocytosis. Number 3, when you are looking at asymptomatic elderly individuals older than 60, 70, 80 who have persisting lymphocytosis, then perhaps that is a group of patients who could be having chronic lymphocytic leukemia. So you would have to look at the age of the patient, clinical presentation. And these days, diagnosis has become extremely easy. You could just run a peripheral blood flow cytometry or immunophenotyping, which would help you in making the diagnosis.
Thank you.
Okay, we will proceed to the next talk.
Thank you.
I would like to invite Dr. Sushil Chelvarajan from CMC Vellore to give talk on ICU patients with fever with cytopenia, simplifying the complex.
Good afternoon. It's my pleasure to be with you. I thank Dr. Ganesh for the invite, and I thank all of you for being a wonderful audience so far. My talk is essentially for all the people who are managing critically ill patients. Now that's across specialties, across diagnostics. I think all of us in the auditorium basically. So I'll quickly go into the scope of the issue, which is basically that this is a significant diagnostic challenge, but we have to approach it from a holistic perspective, that we don't look at only fevers and cytopenias, but the rest of the patient also. I think it's important to state these definitions of fever, because sometimes in our clinical practice, fevers of, we diagnose fevers when there's not really fevers. We diagnose cytopenias when there's not really cytopenias. So, I think the previous topics have defined cytopenias pretty well, so I think I'll go on quickly. This is a sort of a good overview of the etiology of pyrexia in the ICU. Now, we've had this session in the morning, so I'm not going to go through the hyperthermia causes and the infectious causes, but I think it's important that we keep in mind that there are various infectious causes and there are various non-infectious causes also. But what I need to focus on really is the fevers with cytopenia syndromes. Now, this is a slide that, it's available on the website, but it talks about how, rather than the algorithm-based approach, it talks about how to go, like in our clinical thinking, how we go through a first pass, a second pass, and a third pass when we consider diagnosis. And again, we go from common to uncommon as we go across to the third pass. And just to give you an idea, I'm sure all of you can put it together. I'm just going to circle each of these causes of fever and which of these can present with cytopenias, right? So common infections can, prolonged incubated fevers like endocarditis can, opportunistic infections can, untreated infections can. I've not circled clot bleed, but remember that if there's a DIC and severe enough DIC, then that can also have cytopenias. Drug fevers can, localized inflammation, especially pancreatitis can, systemic inflammation, of course, is our, when it comes to hematology, that's where we are often called as the consulting team. And in these, there are a whole host of causes here, all of which can in some way lead to cytopenias. And this is where the conundrum really comes. So in our mind, if we categorize it, it would be broadly into infections, hematological causes, and into drug-induced causes. Now, a systematic approach is very important, because often you will not, as I told you in the first slide, you're not going to find someone with only hematological causes. You're not going to find someone with only drug-induced causes. It's most likely going to be a mixture of many. And that's where our basic understanding of fever, again, this was taken care of in the morning, so I won't put too much time into this. But just to say that the pyrogens come in and cause fever by dysregulating the hypothalamic set point, and it's up to us to decide whether we treat or not to treat and put them into which kind of bucket. And remember that not all hypothermias are fevers and not all fevers are hypothermias in that sense. So there are some fevers we don't need to treat. There are some fevers that we have to treat. And there are some fevers where it's very confusing, especially neurogenic fevers, when we don't know whether it's some underlying low-grade sepsis that we're missing. So there are a whole host of infections that mimic hematological disorders. Now, that is anything from viral infections, especially with the current last 2 years of viral infections that we've had during viral season. We've seen viruses that previously don't cause cytopenias start to cause cytopenias. I'm sure all of you have come across it, even severe infections like RSV, human HPIV3, even to that extent in CMC, we've seen even simpler viruses for example, just last week we had even an old human coronavirus, not the current, the COVID-19, the HCOV043 there was a patient who had come with cytopenia. This is, of course, apart from the usual virals that we involve like dengue and other things. But then we go to sepsis itself, which itself is very, because of the milieu of cytokines, they're all extremely cytotoxic cytokines when they occur in the setting of a severe sepsis cycle. And then go on to a proper immune dysregulation like HLH. I'll briefly go through hematological malignancies. I think it's all, just for completion's sake, I should say leukemias, lymphomas, and MDSs and aplastic anemias are all disorders that have to be considered in the ICU setting. Each of these disorders are primary disorders by themselves, but when you look at the last two, these are disorders that can be secondary, either to autoimmune diseases or to some sort of drug-induced insults. Again, this is drug-induced cytopenia, something that we have to keep in mind. The classic ones that we have to always think about, cardiovascular drugs, antiarrhythmics, and diuretics. Chemotherapeutic drugs, any exposure to these in the past. Antibiotics like beta-lactam, sulfonamides. I've actually I think, again, we've gone through a much more exhaustive list in the last presentations. I think this is just to say that when it comes to thrombocytopenia, there are very good lists that give you the kind of evidence that is there for each kind of each drug and its evidence for thrombocytopenia. Because what you'll do sometimes when you need to go and do a search, no one knows these lists by heart, right? So you will see, okay, let me look at the drugs and see which of these drugs cause cytopenia. You'll go and type it out online, and you'll find that, yes, there are case reports of this drug causing cytopenia. And that's important then, therefore, that we have to separate these case reports from actual evidence. And there are good lists online. I've just given you one, which talks about the kind of evidence that we have for particular drugs and whether it moves from case reports, epidemiological studies, and specific studies, all sort of giving you evidence to think whether that drug really could be one of the etiological drugs for your particular cytopenia in that patient. As Dr. M.B. Agarwal had said very well, a good approach to this patient would be a good history and examination. Unfortunately, the patient may not be the one who would be able to give us the history in the ICU often, especially if they're intubated or extremely septic. We would have to take care of the history from the relatives, but then the examination should help us fill in the gaps. And that makes the examination all the more important in the ICU patient. Again, simply because the patient may be in many positions for the ventilator, may be prone, maybe in various positions. So it's important that just the examination is an event in this patient's ICU stay. And we may have to, change positions just to get a good examination sometimes, because often invasive and cross-sectional testing is not possible in these patients. And a good lab testing flow and advanced test. Now, when it comes to advanced tests, I think it's important that we have some sort of pyramid of understanding. Yes, the biomarkers are good, ferritin, IL-6, cytokines. Then we go on to more advanced tests like flow cytometry. I'll talk a bit about it in the coming slides, how it could help us. And then we come on to probably the most advanced and probably the most cutting edge of how we could take care of fevers and cytopenias in the ICU, which is actually genetic testing. And as a hematologist, I think it's important that we convey the importance of genetic testing properly without putting undue significance on it. So in the real world, as I said, people are always falling through the cracks. They're not either infections, they're not either malignancies, they're usually somewhere in between. There's drugs also somewhere involved. It's all these both and kind of situations that we get. Just to list a few: sepsis, drugs, HLH, marrow insults, autoimmune, nutritional, of which HLH is probably the prototypic disease where, the problem is that either it gets missed from eye doesn't know what the eye doesn't see what the mind doesn't know kind of perspective, or it is missed from the perspective that there is a good secondary cause or an underlying cause for the HLH that might justify your entire syndrome and therefore not let you suspect it. So walking this tightrope in this scenario is often a very difficult thing to do, and good to keep these kind of sort of spectrum understanding of patients, because pinpointing the diagnosis of a patient is often impossible. So it's good to have these spectrums that we have in our mind and trying to put this patient somewhere into this spectrum. So just to give you an idea, most of our patients are going to fall somewhere to the right of the spectrum, right? So that is normal responses, normal immunological response, maybe SIRS. The worst go into severe sepsis, and that's it. But then there are these group of patients, and more and more as we do genetic studies, especially community genetic studies, we see that there are inflammosomopathies that are often silent, often polymorphisms in the inflammasome pathways that may lead patients to come closer to the left side of the spectrum, all the way up to primary HLH, that is the familial genetic mutations for HLH. I think it's important that maybe it wasn't discussed. The HLH Society, the Histocyte Society has put out its 2024 guidelines and 2024 criteria. No major drama in this, except that just the NK cell activity has been removed from the inflammatory criteria. Otherwise, that right now there is the lower absent NK cell activity, which is there in HLH 2004 criteria, is no more there in the HLH 2024 criteria. This was published in Blood last year, just 3 months ago. Yes, now this is another important thing. While sometimes HLH can be many times missed out, often, especially in this current day and age where inflammation flow is free, we have the problem of overdiagnosis. And it becomes a dustbin diagnosis. If we don't know where the patient is going to be, there's fever, there's mild cytopenias, there's a bit of, elevated ferritins, the dustbin diagnosis of HLH get thrown out. And because it's such an easy go-to diagnosis, we have to always be careful. And important to remember that HLH as a diagnosis is not really a good thing to do. It's more that you have to recognize, especially in our ICU patients, we have to remember that it's a pattern. And all diagnostics for that matter are patterns. And to identify whether it's a pattern or disease is important. The NACHO group in the US, which is basically the North American Consortium for Histiocytosis, looked into this, and they actually have given us a good kind of understanding where, the previous criteria that I talked about, the 2024 criteria, would just allow the patient to fit into an HLH syndrome, but not an HLH disease. And an HLH disease is where there is this immunoactivation, but there was also a requirement for immediate immunosuppression in that particular patient. And it's important to therefore separate syndrome from disease. And of course, syndrome from the disease mimics. Now, the problem is that if you just stopped your diagnosis at HLH syndrome, you will end up with the situation where you may have patients who benefit, that are the disease, and may have patients who do not benefit from immunosuppression, like the disease mimics. And if you treat a disease mimic with immunosuppression, what is always going to happen is a rapid deterioration and death because of the septic cycle that you're propagating, especially if you give a short course of steroids, a touch of steroids like we often say. And this is a good schematic cartoon just to show that this is all a spectrum disorder again. The penumbra of this is where the HLH disease mimics lie, and it's important to move your diagnosis between these two areas. This entire drop is the HLH syndrome, but HLH disease is only in this. That is all the classical HLH syndromes. And then important to remember that if you have immune compromise, if you have septic, if you have malignancy associated HLH, they could straddle the HLH disease and disease mimic spectrum. So yes, in the adult critical care setting, often when this is a problem, one of our newest go-to drugs in the first line, which besides methylprednisolone, IVIG, etc., is anakinra, the IL-1 antagonist. And often it is preferred over steroids if the trigger for the secondary HLH is not clear. Fortunately, unfortunately, it is under the purview of most of our rheumatology colleagues, and it's fairly easy to acquire now, except the stocks in India are often fluctuating. And often these patients need large doses, like prolonged doses of the therapy. But this is something that, especially in, say a dengue HLH in the ICU, is something that may be considered, because often sepsis is one of the worries that the patient has got into a secondary GNB sepsis after having a severe dengue. The rest of this I will not go through because in the interest of time. Just two cases just to highlight what we were saying. Case one is a fever pancytopenia starting on a new medication. Something that we have to keep in mind are all the classical drugs that we went through in the last presentation. I didn't know that we were going to go through that. So just to say that, I'll quickly go on to case 2, which is a lymphadenopathy, hepatosplenomegaly, fever, cytopenia, and an ICU shift for an early multi-organ dysfunction. And here is where this conundrum really lies. And I think it's important to keep infection in mind. Infection, again, because we cannot forget it, rheumatological diseases, malignancies, like especially in the pediatric setting, like a pediatric ALL, and right down there under this entire bunch of diagnosis, an underlying HLH is something that we have to keep in mind, because it could be associated with any of these disorders that I've stated above. This is something just to show how latest flow cytometry techniques can help us. It can actually, T-cell activation profiling is very useful to separate sepsis from HLH responses. And the reason for this is, okay, I just finished these last 2 slides. So if we find the CD8 positive, CD38 positive, HLA-DR positive subset of more than 7%, often it portends more towards HLH rather than sepsis, and that's something to keep in mind. It's a fairly easy test to do in the lab, and of course it has to be set up in the right ways. We can go through that. Just to show this pattern, where you can see in the sepsis pattern, the CD38 and HLA-DR positive are low. That is, there is very few bright CD38 and bright HLA-DR. Whereas in HLH, what you see is that there's this distinct subset of activated T cells, which are CD38 and HLA-DR positive. So yeah, I'll quickly go. Genomics, just this one paper that came out very recently, just last month in Jan, in a Frontiers, it was as the lead article for that Frontiers publication, trying to separate using gene signatures various endotypes of sepsis. And I think it's interesting that, they could actually separate between neutrophilic suppressive and an inflammatory pathway, which had poor prognosis, versus the usual other kind of interferon dependent, normal innate host defense dependent, and then adaptive sepsis. So you've never heard these types of sepsis till I think these people had published. But just something important to help us identify endotypes of sepsis, which would then make us probably more confident in immunosuppressing patients earlier in a septic setting using these gene signatures. Just something that is later saying. I always find mind mapping useful for myself. So just giving you my mind map. So where you have initial workups, you see whether there's a single line cytopenia versus a multilineage cytopenia, and then you can approach all these in the ways that I mentioned in the previous slides of my presentation. So early systematic approaches lead, and a multidisciplinary is going to improve our outcome in these groups of patients. So greetings from CMC, and all the best to Dr. Ganesh for the rest of this.
Thank you, Dr. Sushil, for making the complex things simpler. The gene signature, how it can be practically used for the treating patients?
I think we were all very interested also once we saw the paper. It's actually not feasible, it's not feasible on a real-time basis because of our current turnaround times of gene expression profiling or next-gen sequencing. And also the kind of sampling that we needed in that study, what they used was not feasible for us. So often patients are too sick to do, say, bone marrows and other invasive testings like lymph node biopsies and other things. But I think we're reaching a point where our turnaround times for next-gen sequencing are making it at least, if it's back between 5 to 7 days. So people are waiting for biomarkers for 5 to 7 days. So there should not be any reason other than finances, of course, for trying to apply these kind of protocols to identify endotypes of patients. Now these have to be put into context of clinical endotypes also. You can't have a patient who is rapidly improving on the current treatment, but then the gene endotype tells you that it's NPS. You can't go and treat that patient with immunosuppression. So that's always there. But I think it's really a good tool and something that would give us a more in-depth understanding of sepsis and ICU patients, clinical, immunological, and genetic profiling. Right now we have clinical and immunological profiling, but genetic profiling in these patients was so far not yet up to date. And I don't think it's still it reached the limelight, but maybe soon. So.
Okay, thank you.
Wonderful talk, Sushil, as always. So to all the eminent physicians here, so HLH is no more a waste basket diagnosis. It is seen more and more. The more you look for it, the more you get it, number one. And number two, as Dr. Sushil pointed out, soluble CD25 is beyond the access of most of the clinicians across, whether you are practicing at a secondary or tertiary care levels. And turnaround time is also high. But in this context, there is one particular immunophenotype of these cytotoxic T lymphocytes, which has about more than 80% sensitivity specificity. If it is there, then it is again consistent with the diagnosis of HLH, and which is very much doable because even in tier 2, tier 3 cities, this immunophenotype is very much available. So there it is. Thank you.
Thank you. Yeah. We will move on to next. We are running out short of time. Next will the panel discussion. Yeah. I would like to invite moderator Dr. Sharad Damodar and the panelist Dr. Manoj Toshniwal.
Yeah, good afternoon everybody, and we'll have a quick 20-minute panel discussion because I think we're running late, and post lunch sessions are very difficult. So I'd like to start by calling the panel. I think there are little changes on some of the names here. So Dr. Avinash Singh is around? Yeah, okay. Dr. Arjun Mandade, Dr. Anushri Prabhakaran, Dr. Radhika, Dr. Sumant, I don't know if he's here, Dr. Sunil and Dr. Krishnaveni is the panel. So what we'll do, yeah, I think that's good enough, no? Yeah, maybe the chairperson chairs and the chairs in front. Yeah. So I'm keeping this very open-ended. What we'll do is we'll just run through a few cases on the low platelet syndromes. We've heard enough of talks from the morning. I think from post-lunch I was around. So by now I'm assuming the audience are experts. So what we'll do is we'll put up some cases for the audience to diagnose first, and then we'll ask the panel for their opinion. Okay? So the topic here is, I think it's okay, yeah? They can be on there itself. We'll take opinion from there, just give mics there, because this will again waste more time. Okay? So apparently Ganesh gave the topic as, is are platelets so scary? Thrombocytopenia, it's definitely scary for the relatives for sure. The moment platelets drop below 1 lakh, you'll definitely have patients coming running to you asking what should we do when the platelet is low, right? So this is something which is scary to us as hematologists. If you see something like this, then you're clearly concerned that you're possibly having a platelet below 20,000, and this is something for us to worry. So first case, 3-year-old child coming with petechiae ecchymosis, lymphadenopathy, hepatosplenomegaly, and these numbers. Any diagnosis from the audience? Anybody, please? Okay, it's too much without even a smear to give for diagnosis. Seems unfair. Okay, now. Okay, fair enough. I'll ask any of the panel to take this up. So, do you see this in your practice? Anybody can just start talking. And on the brief management of ALL and the fact that you don't want to give steroid the moment you see a low platelet. Anybody can take, please. Yeah. So I think Dr. Agarwal already highlighted the importance of seeing the smear, and I think that's something which all of us would see. And if you see a sheet of blast like this, clearly diagnosis is very obvious there. I mean, there are other things which we would do. I'll allow the panel to discuss that.
So this is a 3-year child who presented with bleeding manifestations, hepatosplenomegaly, lymph nodes. There is no active sepsis going on in the child, so obviously sepsis is ruled out here. Because there's a lymph node and hepatosplenomegaly, it can't be an ITP. So my other differential diagnosis, my other likely possible diagnosis in the common scenario is a leukemia, sir. The blasts are very much the morphology of the in the peripheral smear. The peripheral smear is studded with all abnormal blast kind of thing.
Yeah, they are blasts.
Yeah, they are blasts.
They are blasts,
yeah, they are
yes.
blasts. Yeah,
no doubt in that.
Yeah, very likely morphologically they're mimicking the lymphoblast. The next thing what I would like to do is go ahead with a marrow aspiration biopsy, immunophenotyping, and some molecular typing and all to categorize I'm dealing with an ALL or an AML.
Fair enough. So now with immunophenotyping, we'll get a diagnosis of ALL. Commonly the BALL is commoner, and anybody else to add in on the kind of cure rates, because this is a general audience, so that's why I want to bring in a little bit of hematology there. What kind of cure rates are we looking at in children and in adults?
So this child is between 1 to 10, so we are looking at a cure rate of around 90% or more than that. When we take up adolescent and young adult, 10 to 39 or so, the cure rate comes down. And in adult and adolescent and young adult together, I would say the cure rate will be around 50 to 60%.
Okay, fine. Now I have to ask this question because that's the buzz in the country. Will you kind of recommend CAR T-cell therapy for ALL? Anybody?
Not upfront, sir.
Okay, fine, good. Okay, so only in the relapse setting, that sometimes is the bridge to transplant. So currently not something you would offer upfront. Okay. So we'll go on to the next case. So this was ALL. So remember, thrombocytopenia presenting like this. Similar case now, 10-year-old child, this time again coming with petechiae and ecchymosis. Okay. This time no nodes, no hepatosplenomegaly, and these are the numbers. Diagnosis. Audience first, and then I'll come to the panel. Okay, ITP. Okay, fair enough. What would you want to do? How many of you all will want to do a marrow in this patient? Okay, only one hand is coming up. Okay, panel, I'll take the expert opinions on how many of you all are doing marrows, children, adults. I'll leave it a little open.
So, Sharad sir, thank you for these two cases. Excellent and what you call...
I mean, these are real cases, not made up,
yes,
and
yes.
that's what I'm telling you.
That is like thinking is boosted for everyone what to do for these cases. For a young patient who is coming with severe thrombocytopenia, bleeding manifestation, clinical examination is very important. No nodes, no hepatosplenomegaly.
Right.
Second most important thing is peripheral smear. Talk with your pathologist. Ask him to spend some time on the smear. If no blast, everything is right under the microscope, absolutely no need to do the marrow for this patient. If slightest of suspicion is also there, better to get the marrow rather than missing a malignancy, and starting a steroid can be devastating for the patient. Because hemoglobin is 8, it can be because of leukemia, or it can be because of ITP leading to the bleeding, or even nutritional anemia, which is very common in our country. So seeing smear, seeing patient clinically should guide you for the further action to be taken.
So which is the malignancy you would miss here?
Usually for young child who is coming with low platelet count, just WBC count okay, we see the strip coming from local lab where lymphocytes, though 80%, but they mention 20%, we can miss acute lymphoblastic leukemia, which is very common in this young age.
Fair enough. That just the point we wanted to kind of highlight. So please make sure that this is reviewed, the smear is looked at, because if you go and then start steroid thinking it's ITP, you may actually wipe out the marrow. The blast just disappear, and then it becomes a big problem for us to then diagnose it later when they don't recover. It's happened, so this actually happened, and thereby the point of highlighting this. Any other comments from anybody else, if you want to add, please? So here the marrow is actually done, and this is the marrow, It's essentially normal with a lot of megs there. All those fellows are the megakaryocytes which are there. So either, a lot of times normal or increased megakaryocyte production, which is a response to thrombocytopenia. So this is classic ITP, where you get increased megakaryocytes in the marrow, and that's how it's peripheral platelet destruction. And like Dr. MB had mentioned, in addition to immunosuppression, which was the standard of care along with steroid, nowadays you got the TPO agonists which are available, which work with a different mechanism there, non-immunosuppressive, and still help in the treatment of ITP. Any comments from any of the panel on either diagnosis or treatment? Feel free to please pitch in. I've kept this open. I'm not specifically targeting to anybody because of want of time.
Just one thing to add. Steroids are the first line therapy for these patients. Many times patient get admitted to some local hospital. They start the steroid, response is there, and immediately after 5 days, 10 days, steroids get tapered. That has to be done rightly, maybe for at least 3 to 4 weeks of right dose of steroid, and slow tapering over next 1 to 2 months, and that gives the long-term sustainable response to the ITP patients.
Okay.
With regards to this patient, I would not like to start him on any kind of treatment. 10 years child, just skin bruises and all. Otherwise, there is no significant major bleeds like oral bleeds or a major bleeding and all.
So petechiae ecchymosis, parents will be jumping more than the child. So
they just need to be assured.
Okay. Any other thoughts? Any other panelists who would not treat this patient with steroid?
I would just keep him under observation, follow up
Okay.
observation.
Little difficult in today's world, but I'm deliberately asking. Yeah, please tell me.
Sorry to interrupt, sir, but I want to put a point because you have mentioned it's a 10-year-old. I'm a pediatrician.
Yeah.
I'm a professor of pediatrics. My point of view here is you have just mentioned that there is only petechiae and ecchymosis.
Correct.
And there is no organ infiltration.
Right.
So the history will definitely tell. All the while we were talking about the history all the time.
Right.
So unless we have a proper history, we cannot reach to this. ITP would always be the first thing when we see the smear and when we go for the bone marrow. And regarding the steroid, exactly. Steroid can be given, yes, that is good. What is prevented? And you said the recent advances have come. What we can go with the treatment part. Yeah, seeing this picture, there are no nodes, there are no infiltrative. So leukemia is not the primary thing that we have to look in this case.
Okay.
Not to progress further for the marrow or biopsies.
Fair enough. That I'll accept, that if there's nothing atypical at all, you don't have to do a marrow, which is fine. I'm not fighting on that. The question is, after you made a diagnosis of ITP, on a 12,000 platelet count with petechiae and ecchymosis, will you start steroids or will you not start steroids?
We'll start with IVIG. That's what we are following.
We'll do IVIG. Okay, fair enough. So some treatment will happen. Okay, right. Next case. 33-year-old male, petechiae, ecchymosis, no nodes, no hepatosplenomegaly, and these numbers. 12,000 platelet, 1,200 total count, and hemoglobin of 8. Diagnosis. Anybody? Okay, maybe unfair, because I'm not giving you too much of history deliberately, okay? It's to keep you all awake and think. So here, will all of you all do a marrow, or will you just wait?
No, we would like to go for a marrow here.
You would want a marrow?
The first and foremost is peripheral smear.
Okay, nothing atypical. I'm telling you, nothing atypical, no blast.
Still, we would like to go for a marrow examination here because it's pancytopenia.
Fair enough. Mild lymphocytosis was there. This was the marrow. Diagnosis.
Hypoplastic.
Aplastic anemia. Okay, so straightforward. Okay, aplastic anemia. Treatment options, I'll ask the other people to speak, please. Some thoughts on treatment of aplastic anemia in our country, quickly. Fair enough.
Transplantation is one of the gold standard and standard of care treatment in aplastic anemia.
Fair enough. Point to highlight for the audience there. Somebody less than 40 years of age, if you have a matched sibling donor, you would push for a transplant as a curative intent treatment. Okay. In the absence of that, other treatment options. If you don't have a donor.
If you don't have the donor, then we can treat with the other medicines like the thrombomodulators or other
ATG,
ATG,
cyclosporin is the standard of care.
Yeah.
Okay, ATG in adults and children about 50-60% kind of response rates. Sometimes can go away after 2-3 years. You might have to do a second course. Non-curative intent treatment, but still you will get some remission rates there. So if you can't even afford ATG, then plain cyclosporin is an option in this subset of patients. Okay, we're a little bit tight on time, so I will go a little faster here. So 18-year-old male with rheumatic heart disease, no petechiae, no ecchymosis, no lymph nodes, no hepatosplenomegaly, platelet count of 72,000, TC of 7,200, hemoglobin 15. Somebody did a bleeding time which is normal. Diagnosis. Anybody from the audience? I can't take too much time because they're already telling me we're running tight on time. Okay, the experts. Anybody?
We have to see the smear once.
Fantastic. Okay, very good. So this is what they saw on the smear. Okay, so there were large platelets on the smear, the typical macro thrombocytopenia described from our country. They call it the West Bengal syndrome. This is actually described by one of the registrars who was there when I was doing my DM at CMC Vellore. His name is Harris. This is actually named after him as the Harris syndrome. It's actually there. Currently he's practicing in Boston. And this is what was discovered there. A lot of the patients from the Northeast, when they come in, they have giant platelets which are not counted on the machine because it counts by size. So you will get a platelet of about 70-80,000. You do a smear, it will be 1,50,000. You do a bleeding time, it will be normal because the large platelets are all functionally normal. Okay? So in spite of thrombocytopenia, you get a normal bleeding time. Then it tells you that there are other larger platelets which are actually helping you to keep the bleeding time normal. Okay, so that was just to kind of put up as a case there. Okay, back to a child, 3-year-old, petechiae ecchymosis, no nodes, no hepatosplenomegaly, platelet of 1,20,000, but the bleeding time is prolonged. Audience diagnosis, and then we go to panel. Everything normal, but the bleeding time is prolonged. So I know thrombocytopenia is a topic, but I'm just deliberately going away. Somebody said Bernard Sulia, eh? Okay, panel.
So at least at the track, the platelet count a little bit lower than the normal, but bleeding time is prolonged. That does mean that whatever platelet someone is having, they are not working the way they should work. And it is usually the platelet function disorder.
Very
For
good.
that, it needs to be evaluated.
Fair enough.
Bernard-Solier, usually platelet count remains normal, but in Glanzmann's thrombocythemia, that is lower than the normal, and they are not functional rightly.
Okay. So based on the receptor defect there, 2B3A in Glanzmann's and 1B9 in Bernard-Solier, you can do platelet function tests and figure this out. In a lot of places now in the country, platelet function tests are available, can be done. You can even assess your antiplatelet response when patients are on aspirin clopidogrel to even look for resistance. So be aware that all that is currently available in our country and we can diagnose that. Okay. Case number 6, adult, 60-year-old with coronary artery disease on aspirin came with petechiae and ecchymosis. No nodes, no hepatosplenomegaly, these kind of numbers again came from the Northeast. So this was the picture. This is due to what? Okay, so patients on antiplatelets can also bleed even with normal platelet count. So we see this in a lot of older patients. First of all, they have very thin skin. They have higher capillary fragility. They tend to bleed a little more. So sometimes when they're on dual antiplatelets, they tend to come up with these symptoms in spite of a normal platelet count. Okay, case 7, I need to quickly run through now. 23-year-old female, fever for 1 week, occasional petechiae ecchymosis, no nodes, no hepatosplenomegaly. These are the numbers. There's an elevated liver enzymes, and the ferritin is 12,000. Audience diagnosis, and then we go to panel. Anybody? Oh, very good. Then you'll listen to Sushil. Okay, so Sushil spent 15 minutes talking about HLH. Okay, so I'm glad you all did that. So this is something, remember that any fever can, or any infection for that matter, can trigger HLH, and this is something you need to consider on those numbers. If you have a high ferritin, it should at least make you aware of it. And this is the bone marrow picture where you can see all that hemophagocytosis, everything getting chewed up by the reticular endothelial system there and the histiocytes there. All of them are within that cell there. So nice little pictures from the marrow there, HLH. Okay. Case number 2, I think we've got 2 more cases after this. 30-year-old male, fever 1 week with jaundice, no petechiae ecchymosis, no nodes, mild hepatosplenomegaly, and these numbers, platelet of 82,000. Possible differential, okay. I mean, you can't give one diagnosis here. Hemolytic anemia, fever 1 week, okay. You can trigger, you'll listen to MBA's talk. So he did mention about something getting triggered with fever. Any other infective causes?
Fever with hepatosplenomegaly, first and most common diagnosis is malaria, the infectious diseases.
Okay, very good. Bang on, spot on. Okay, this was a smear there. So remember, malaria presenting with thrombocytopenia. Dengue also can come up with something similar. So these are the 2-3 things you keep in mind, which all of us would typically do. This is a nice little picture of showing you the malarial parasite there. Okay, case number 9. 43-year-old male, fever into 1 week again, this time with petechiae ecchymosis, no nodes, no hepatosplenomegaly. Okay, platelet of 52,000, WBC count elevated. You had a full lecture on high elevated WBC count. Coag slightly abnormal. Possible diagnosis. You can tell me anything. There was a big list of causes put up for high WBC count. Now I added the low platelet to that to make it a little more confusing for you all. Okay, now at least diagnosis. Yeah, so remember, so somebody presenting with thrombocytopenia, high count, a lot of people get passed off as infection till somebody should see the smear. And if you really search, you can see nice multiple ore rods there. And that one, that's a classical picture. This is not from the textbook. This is from one of our patients in the hospital. Okay, so this is the way they can present it. Just that somebody has to pick it up quickly and call you because APML is an emergency. You want to start supporting platelet and your, blood products there so that they don't bleed. Okay, because the first 2 weeks is very, very crucial. If they pull through that, you've got 80-90% cure rates. Okay, so it's very, very crucial to not miss a diagnosis of APML, and thereby their initial presentation could be just thrombocytopenia with some abnormality in the coags. This should be my last or penultimate. Okay, so this is a 63-year-old male, pure vegetarian, fever on and off, weight loss of 4 kilos. Okay, no petechiae ecchymosis, no nodes, no hepatosplenomegaly, and these are the numbers with which he came. His main worry was weight loss and this little fever going on. So some possibilities here. Come again? Megaloblastic, okay, the vegetarian kind of took you in that direction, okay. I didn't put up an MCV deliberately here, okay. So, come again? Okay, possibility. In our country, certainly possibly. Weight loss, a little bit unusual there, but sometimes you can have if his appetite has dramatically come down, okay. But he was getting chased around for fever. On digging back, the fever was going on even longer. And there was significant weight loss. The hepatosplenomegaly is something which is sticking out here. Just a pure megaloblastic, you will not get hepatosplenomegaly. Okay? So that's the one which is sticking out in this patient here. And this was the marrow. Audience first, panel after that. So there are multiple granulomas here. Okay? So rare to get granulomas in the marrow, but this is what happened, because people thought it was actually megaloblastic and got the marrow done. Then you turn out and see this. And then when they chased him, they actually figured out the TB quantiferon was positive. And then he was started on ATT and actually got better. So starting ATT on a little low count again is a little nightmare with INH and rifampicin. You must remember that. That's also a cause for dropping counts. So you need to be careful in addition to monitoring the LFT. Okay, my last case, I might as well finish it. We are just on time. Last one, 43-year-old female, fever into 1 week, headache, vomiting, no petechiae, no nodes, no hepatosplenomegaly. These are the numbers. And then they did a CT. Okay, it's unfair to ask you without the CT. Okay, so presentation here, there's a thrombosis and you've got thrombocytopenia. So this I think I'll ask the panel to manage. So came with the thrombosis with a 70,000 platelet count, young female, headache, vomiting.
Young female presenting with thrombosis and borderline thrombocytopenia can be because of some autoimmune disorders, particularly antiphospholipid antibody.
Right.
The obstetric history should be taken into consideration. Also SLE and other autoimmune disorders can also have some type of picture. Yes.
Okay, the treatment part of this, because you've got thrombocytopenia and you need to anticoagulate. Last word from the panel and then I close.
So the patient, she's APLA-positive, the most important thing is the acute episode has to be managed like any other CSVT here.
So she's APLA-positive, she's got a thrombosis, and the platelet is 70,000.
Platelet is 70,000. I don't think she requires any platelet transfusion, but
No,
for the
okay.
CSVT, she needs to be managed like any other CSVT.
So you will just give heparin or low molecular weight or whatever?
I would like to give heparin, get away with the acute episode. 72,000, I'm happy with it. I'll take a remat consultation, add on a HCQ, some additional supplements and all. In future, during high risk conditions and all, probably I would like to put her on some anticoagulant prophylaxis.
So what anticoagulant would you want to do here?
Most commonly, like most of the time, she's a young female. If she conceives and all, probably I would consider Clexane prophylaxis in the peripartum and the postpartum period.
Oral anticoagulant? Anybody else?
Applies one condition where warfarin is better than NOAC.
Yeah. So you would want to switch to that. You would not use any of the NOACs. Okay. You would keep a watch on the platelet count. If it drops below 50,000, then you might want to interfere even for that, because you want to maintain at least a 50,000 count when you're giving somebody anticoagulation. Okay. Okay. I think we'll end there. Thank you, panelists, for your inputs here, and for the audience for not actively participating. Okay. Thank you.
Thanks. I would like to invite Dr. Arijit Nath for the next talk. Clinicians obsessed to acute leukemia.
Can we have the slides, please? Yeah, thank you. So today's talk is on clinicians' approach to acute leukemia and recognizing the time bomb. So I'll be as generic as possible for most of the audience who would be from from the medicine or the pediatric background. So the objectives would be to understand the types of acute leukemia, the recognizing the signs and symptoms of progression, and evaluating the treatment strategies and patient care broadly. So basically, why does acute leukemia take place? Because there is a proliferation of these abnormal cancer cells, which we call blasts. They fill up the marrow, they infiltrate into the organs, and as soon as they do that, they cause dysfunction. So the counts fall, there is organ dysfunction, and essentially acute leukemia is when the blood cells become abnormal. So it can be across the lineages, but most commonly originating in the WBC lineage. It can be of two major types. One is the acute myeloid leukemia. Traditionally, this would be the one that you would probably see more in adults, and the acute lymphoblastic leukemia, which we would see more in children, and interferes with the function of the healthy WBCs, platelets, and the hemoglobin. So broadly speaking of, it can be acute myeloid and lymphoid, as we talked about. Lymphoid can be acute T acute lymphoblastic leukemia and B acute lymphoblastic leukemia, originating from the precursor T and B cells respectively, and from the mature B cells, we would have the Burkitt's leukemia. There is also a subset, which is the leukemia of ambiguous lineage, and that's a different talk altogether, and so I won't go into that. So traditionally, we've been brought up in our pathology lectures recognizing the morphology of acute myeloid leukemia, but I think this is how the acute myeloid leukemia looks at right now in 2022 onwards, and it's very confusing. So because it's more based upon the genomic and the evolutionary pathways, and so we need to be making a comprehensive diagnosis to start with, because each of these have its own prognosis, and we need to know how to consolidate the response. Again, this is a busy slide, just to iterate that there is a lot of genomics that goes into the diagnosis, and it's also based upon a very, very good morphology, a strategic and systematic way of approaching the diagnosis, and which I'll come to in the subsequent slides. And so it's not easy. So you have to be alert, and at the same time, you have to do the comprehensive panel up front so that you can actually make up for the correct classification. And as you move on to the ALL as well, you would recognize that this again is an area wherein it has moved more into genomics, and so a comprehensive diagnosis up front is very important. So what happens in acute leukemia is the cells will either lose an ability to differentiate, or they will have a very proliferative advantage, leading to division uncontrollably. So basically, if they lose the ability to differentiate, they will be stuck in the blast phase and they don't function effectively. If they divide uncontrollably, what they will do is that they will effectively crowd out the normal cells, causing cytopenias. And when they go and infiltrate into the marrow, they will cause a cytopenia. But if they go and infiltrate into the organs, it will cause an enlargement of the organs to the first place, because it keeps on expanding uncontrollably. So the liver and the spleen goes increases in size. Sometimes in children, it can, and especially in T leukemias, it can go and infiltrate into the lymph nodes and thymus. And so you would have a big mediastinal mass, enlarged lymph nodes. There's one very interesting subset, and this is moved, and we've moved into an era where a very, very deadly disease has been made curable. So this is very, very important that the pathologists recognize this. And what it does, additional to the other leukemias, is that it activates the clotting process. The patient's often present with a picture of DIC. So there are some risk factors for leukemia, which I'll not go to for lack of time, but this is, some of the genetic syndromes do predispose patients to leukemia. And some of the viruses as well to acute leukemias. I'll go straight away into the symptoms and the sign, and this is very important to recognize that patients can present either sometimes asymptomatically, but most often with symptoms which may be very, very heterogeneous. So you can have a patient presenting with a persistent fever, you can have a patient with fatigue, lethargy, a bleeding phenotype, or a combination of these. Patients may come up with only hepatosplenomegaly with altered counts, with lymphadenopathy with altered counts, with vague pains and aches in the body with a leukocytosis. And in acute promyelocytic leukemia, addition to all of these, you can also have a patient who comes into you purely with bleeding and thrombocytopenia. So when you suspect a patient of acute leukemia, when you're seeing a patient, if there's a patient who has presented to you with a sudden onset pancytopenia, so pancytopenia again does not necessarily have to be all the 3 lineages, it has to be 2 or more lineages among the WBC, hemoglobin and the platelet lineage. So sudden onset pancytopenia with bleeding. It can be a young patient who has persistent symptoms like persistent fever, persistent aches, or a plain patient who has just done a routine blood test, was feeling a bit fatigued, and has discovered that he's pancytopenic and is very worried. You can have a patient with leukocytosis, leukopenia with blast, and is otherwise normal. So essentially, you have to be on the lookout for these patients, and this should always be a differential in a patient in whom you're not finding an obvious cause. So it's important that you identify the signs, you perform like pancytopenia or leukocytosis. You conduct adequate blood tests to look at the blast in the peripheral smear. You do a few direct tests, which I'll come to in the subsequent slides. It focuses on the diagnosis and characterization of acute leukemia. You also need not to stop there, but to be very, very aware to detect the complications, because before the hematologist or the oncologist takes over, you are the managing physician, and you will have to preempt the complications and manage the ones that are already present. You have to collect bone marrow samples, so it's very, very important that you consider a differential of acute leukemia, because unless you do that, you will not be collecting extra samples, you will not be doing a comprehensive gene profiling, and you may have to land up in repeating a marrow, which is not pleasant to the physician, costly to the patient, and very, very unpleasant to the patient for sure. It's important that whenever you suspect an acute leukemia, please talk to your pathologist. Please give a heads up that this is a patient. I think please look out for the smear, look at the differential, and get back to me, because unless you suspect, and unless you give a proper history to the pathologist, it's very, very difficult, especially when there is pancytopenia, to suspect that there may be a leukemia. So it's, if you go to the conundrum of the test that you need to do, the first and foremost is a good CBC and a thorough smear examination. There is nothing better than that to suspect that it's an acute leukemia, and often it's the work of the pathologist to flag it to the clinician that, hey, I'm suspecting this is an acute leukemia. Please be alert, and please do the appropriate tests. You should, whenever you hear the word acute leukemia, for the clinicians, it's very, very important that you immediately think of tumor lysis syndrome, because unless you suspect it, you will not test for it. Unless you test for it, you will not recognize it. Unless you recognize it, the patient may unnecessarily land up with an acute kidney injury and with very, very severe problems in various organs. It's also important for you that before the hematologist or the oncologist takes over, you perform a thorough organ assessment. So you have to recognize that the patient, whether the lung is okay, whether the heart is okay, whether there is organomegaly, and whether the patient in general is fit enough for the subsequent tests and the treatment for sure. Again, as I mentioned, it's very important to suspect an acute leukemia, because unless you do that and you do a blind procedure thinking that maybe I'll go in and do a leukemia panel later, you will come with a diagnosis of acute leukemia, you haven't collected the appropriate samples, and then you will need to do the test again, and that's often not the most pleasant things to do. It's also important to recognize, as I was testing, that leukemia needs something beyond morphology, and a lot of things beyond morphology to be able to characterize it and to be able to treat it comprehensively. So cytogenetic and genetic testing testing. It forms one of the important components in cytogenetics. You can either do it by conventional karyotyping and often by FISH targeted at the specific mutations that you want to look at. So it's always good to have the opinion of the hematologist before you go in and do the marrow. In genomics, gradually, as and when it becomes more accessible, affordable, and a lower turnaround time, we are seeing a replacement of the PCR through the NGS panels. And central to the diagnosis of any acute leukemia is immunophenotyping. So please collect samples for immunophenotyping in adequate vials and give a heads up to the pathologist before you send it for the testing. There are three key factors which I would like to highlight: that it's important to do the test at reliable testing centers, nothing like an in-house test, but even if you're outsourcing, it's very important for you to be convinced that you're sending it to a reliable center. It's always good to collect extra samples so that you don't need to go in again. It's an invasive test, so it's always good to collect extra samples. And if you're doing in-house and if you have the facility to store the sample, please store the DNA and the RNA within your facility so that you can do the test if you've forgotten to do one initially. So the three pillars of accurate leukemia diagnosis is comprehensive testing. More and more emphasis should be placed on comprehensive, and so it's always important to involve the hematologist or the oncologist initially in the diagnosis, so that it is a team effort, and it's always important to form an accurate and a comprehensive diagnosis, because in today's day and age, a lot of it depends upon accurate diagnosis. For a clinician especially, it's very, very important to recognize that whenever the word acute leukemia comes across a patient's differential, you have to be on the lookout for 3 or 4 major medical emergencies, which it's only you who have to manage before the physician, the hematologist or the oncologist steps in. One is tumor lysis syndrome. The second is risk of infections and actually managing the infections. The third is bleeding and disseminated intravascular coagulation, especially in promyelocytic leukemia. So whenever you think about acute leukemia, think about PLUC, P for high phosphate, L for high LDH, U for high uric acid, C for low calcium, and K for high potassium. So that's the 5, that's mnemonic for tumor lysis syndrome. Please be on the lookout for tumor lysis syndrome. Very easy to prevent. Just start with good hydration. Start on a hypouricemic drug like allopurinol, which is the best, or else you can also start on febuxostat if the patient has a high creatinine. Another very, very important thing is that these patients either have low absolute neutrophil numbers or these neutrophils are dysfunctional. So all patients of acute leukemia, if they come in with fever, that's a red flag. So fever with low neutrophil or fever in acute leukemia is something that we are always very, very worried about. So take this seriously. Alert your physicians, alert the nursing team that this is a sick patient. Send blood cultures, start IV antibiotics immediately, and use an antibiotic as per your hospital policy, or a reasonable choice could be a piperacillin tazobactam with or without amikacin. Monitor the vitals. This is very important because the cornerstone for management of acute leukemia is based upon hemodynamic stability. If the patient is hemodynamically unstable, you need to have a rapid escalation of counts, and also to recognize the source, identify the source, and treat it, especially if the patient has an indwelling catheter. The bedside pearls for the management of acute leukemia is you need to be prompt, you need to be clinically astute, and you need to be on the lookout for complications, because unless you preemptively think about that, you will not be able to prevent it. So hemodynamic monitoring with pulse, blood pressure, and respiratory rate, these are essential. And if the moment you see a patient who has fever and has tachycardia, you should have a palpitation along with the patient, because you know that this patient has a high propensity to worsen. Immediate actions, and blood cultures and IV antibiotics, and try to address the source of the infection. As I mentioned, acute promyelocytic leukemia is one leukemia which in today's day and age should be curable. So there is no excuse for a patient to die of acute leukemia, promyelocytic leukemia, unless the patient has already come in bleeding and is mortally sick. So acute leukemia is something that the pathologist can start the trail, because whenever a patient comes in with with a low blood counts and you see abnormal promyelocytes, it's the duty of the pathologist to alert the clinician. And as soon as the clinician gets to know, it's the duty of the clinician to alert the hematologist or the oncologist, and immediate action is required. There is no excuse for delay in acute promyelocytic leukemia, whatever the day, time of the day, whatever day of the week. So it's important to perform a coag screen and alert the blood bank that you need to keep the enough amount of platelets and FFPs ready. consult the hematologist, start on whatever drug he wants you to start with, either among atra or arsenic. And your pharmacy should have a stock of at least for one initiating dose for a patient. And you need to be on the alert and look out for differentiation syndrome. This is a busy slide, and my purpose is not to highlight the slide, but the purpose is to highlight that there are very, very effective treatments, very, very safe treatments. You just need to pull the patient through the first couple of weeks. If you're able to sustain the patient, stop the bleeding, and manage the patient in the first couple of weeks, you're sure shot treating the patient and curing them. So and this is one leukemia wherein we should be happy treating the patient because they have a very, very high potential to get cured. So again, whenever you have any acute leukemia patient with bleeding, you have to identify the cause. So either if it's a low platelet, most often it is. So recognize low platelets, alert the blood bank, start platelet transfusions immediately. Do not give very meager amount of platelets. It should be either one full single donor platelet unit or 4 to 6 units of random donor platelets. Please also monitor the coag screen, if possible, daily in a patient who is bleeding, to check for the prothrombin time and the APTT. Pay extra attention to APML cases because they will mostly die of bleeding in the initial 7 days. So it's important to do a PT, APTT, and a fibrinogen. Address infection and sepsis because these patients tend to worsen very fast. So if there is a patient who has acute leukemia, is bleeding and has got sepsis, be on the lookout for DIC and try to address them. I'll not go into the management of acute leukemia in detail because that's not the purpose of today's, but just to let you know that there are very, very effective treatments and a large proportion of these patients will get cured. So it's important to diagnose and start early. And I'll just end quickly by going through this case of a 22-year-old gentleman who presents to you as who's the treating physician with low-grade fever. You do a blood count, you see pancytopenia, and the patient is bleeding from the skin, from the mouth, there is a subconjunctival bleeding, and there is epistaxis. The liver spleen is not palpable, lymph node not palpable, chest you find a mild crepitation. The blood count shows a pancytopenia with a low WBC, and the pathologist sees some abnormal bilobe cells with dense granularity, suspects abnormal promyelocytes, and you are alerted. So you alert the hematologist, prepare the blood products and start transfusion immediately. Initiate antibiotics because the patient has fever, so you don't want to overlook that. Monitor the vitals very, very closely. Monitor the vital signs, monitor the coag screen, and start the treatment as per the hematologist. And if you do that, doing it for the first couple of days, 3 days, 4 days, and then transfer care, this patient will be cured. If you don't do that, the patient will die. So that's the difference that you can make to the life of the physician. And in summary, is to mention that leukemia is, of course, a time bomb, but if you recognize it, we can reverse the clock. Early suspicion is the key. Prompt management can save life. And you should not be should be fearful or afraid of doing of an allogenic stem cell transplant, because often a patient will come back to you asking you, the hematologist is asking me that I will need a transplant. Do I actually need a transplant? It's important for you to assure the patient that yes, the hematologist knows his job. Sometimes this can actually cure you. So and it's very, very important and imperative to involve the hematologist and oncologist very early in the case and transfer care. Thank you.
Thank you, sir, for comprehensive coverage of the pneumonia. Any doubts can be asked?
That was very well presented, sir. And one of your slides which was showing about febrile neutropenia, where you said that golden hour, definitely it has to be the peptase. Pipzo is always the chance of treatment, and then shift on to the oral. This is what we follow for the pediatric age group, but I hope the same holds good with the adults also.
Yeah,
so the golden hour management, because on the management perspective, I was looking at the febrile neutropenia.
Yeah, it's important that as soon as you recognize that there's a neutropenic patient or a patient with leukemia who has fever, it's very important to start the IV antibiotic, especially when it's the first time. Yeah.
Which line of that? That's what I said. You said Pipzo. Is it?
Yeah, so it depends upon an institutional protocol. We follow piperacillin tazobactam. It's a good alternative. It's a good regimen to follow piperacillin tazobactam with or without amikacin. But if your institutional antibiogram suggests otherwise, depending upon the prevalent infections in your hospital, then you might follow that as well. Yeah.
Thank you. Thank you, sir. Thank you for the wonderful presentation, and we'll move on to the next topic. So it's a virtual. It's coming virtually.
Next,
I would like to call Ashish Chauhan sir, Senior Physician, Apollo Hospital, to join as a chairperson for this session.
Sir.
This is the title of Maman's talk.
Just chair this session also. The before two were good actually.
Did Biju's talk is over? Dr. Biju George?
No, I didn't hear his talk. Probably it was not in this.
Recording in progress.
You are
Testing one.
online, sir. Yeah, we can see you, sir.
The same smiling face is what if I can introduce Dr. Maman Chandi as. Do we have the slide with us? Do we have the slide or anything ready?
Live.
Yes, okay.
I'm live. I need to have share screen. That share screen hasn't come up. They need to put on the share screen. If not, I can't share my slide. Hi, Ganesh. Log in again.
Professor Maman Chandi, father of hematology in India, who has established the first DM course. आप चालू करो, तब तक बात करते हैं.
Thanks. So finally, I get the go from one only Dr. Ganesh. And it's an absolutely needed that I should stand up when I introduce our teacher. You know, the gentleman who you see smiling right now out there in front of you, the father of bone marrow transplant in India, Padma Shri, Dr. Professor Maman Chandi sir from Vellore. Can we have a big round of applause as we see him? You know, I am being very, very honored, a student of his in 1993, and his son was my junior in Vellore. And if I have to start talking about sir, I'm very much sure the books can be written. One of the most humble soul I have ever met in my whole life is Professor Maman Chandi sir, and his smile speaks it a lot. And there is, you need to meet a I really believe that you must have the privilege to ever see him in person when he's there, if possible in Vellore or wherever. But a gentleman who's brought the bone marrow transplant in India while he was at CMC Vellore is Professor Maman Chandi sir. Finally, he moved off to Tata Memorial as a director. And then subsequently we have his blessed presence out here. And as he is going to speak also, I just love the topic which chosen by him and Ganesh is, yes, knowledge is precious. Its lack can cause harm. So right knowledge, the right direction is what I have learned as student of Maman sir, and I'm really, really honored to be welcoming you, introducing you. Maman sir, it's so nice to see you, that lovely smile of yours. The audience is already set to hear to your precious words. Over to Maman sir. Thank you. Sir, we can't hear you. Just a second, sir. Can you unmute him, please?
Sir, please unmute yourself.
unmute. Now is it all right?
This is perfect, sir. Now we can hear you. Please restart
Okay.
if I can request you. Thank you.
Okay, thank you. I'm really sorry for all this delay and trouble. But basically, Ganesh is holding this meeting to tell you about all the recent advances and all the new things that are happening. But in my talk today, I want to take you back to basics, okay? And I want to try and illustrate how knowledge is precious and its lack can cause harm. So So this is Dr. Paul Brand. He was the famous leprosy surgeon, and he is the one who introduced a tendon transfer for claw hand. And he has written a wonderful book called Fearfully and Wonderfully Made. And Paul Brand used to talk about knowledge and how it was precious. And I am not able to move the slides, so I think somebody has to move the slides. So he used to tell us about Shushurata and how Shushurata had devised 2,600 years ago a technique to reconstruct the nose. Those documents were all forgotten and nobody knew about it. And it's many, many years later that plastic surgeons realized that the technique of nose reconstruction, which Susurata had so beautifully illustrated, in fact, is one of the best ways to do it. So knowledge truly is precious. Can I have the next slide? The basis of clinical medicine, even today, is a well-taken history, a good physical examination, clinical diagnosis, investigations based on clinical diagnosis, logical interpretation and integration of all of the above, make a final diagnosis, and then proceed to treatment, which is based on evidence. Next slide. All of these only after history and physical examination. Unfortunately, today, we go to all of these without bothering to take a good history and do a physical exam. Next slide. Next slide. So the first talk that I'm giving is about a case which illustrates the need for crosstalk. Now, in computer language, crosstalk is something that's unwanted, something that takes you off track. But to me, in medicine, crosstalk is essential. And it's the basis of knowledge when we ask questions and try to get answers to those questions. Next slide. So case number one is pursuing the diagnosis, and it's the story of Arjo Das. Next slide. So Arjo came to me on the 13th of June 2023. He was at 6 months, they found his hemoglobin was low. And from that time, he had been receiving transfusions, initially once in 22 days. And by the time he came to me, once in 10 days. On examination, he was pale. There was no icterus. Spleen was 15 centimeters, liver 5 centimeters. Other systems were normal. Next slide. Investigations done in CMC, HB 6.6, MCV 74, WBC 15,300, platelets 167, retics 7.8%. Total bilirubin 2, direct 0.79, LDH 540, ferritin 744. With this blood picture, I don't know why they went straight to a bone marrow. Next slide. And the bone marrow was a cellular marrow with marked erythroid hyperplasia and dyserythropoiesis. And it was called congenital dyserythropoietic anemia type 1. A repeat bone marrow was done 2 months later, and again that was reported as CDA type 2. Next slide. The parents, hemoglobin 14.4, father, retic 2.6, MCV 90, mother, HB 11.8, MCV 90, retic 4.1. Next slide. So they asked for a next-gen sequencing. And the history given for next-gen sequencing was transfusion-dependent anemia, query CDA. So this was the report that was issued, which said negative. No mutations with clinical significance detected. Next slide. Patient also went to Chennai, met Dr. Revati Raj, and she also asked for next-gen sequencing from MedGenome, which means both together is 40,000 rupees. And MedGenome reported a change in ankyrin. But the end of it, they said, of uncertain significance. So I think the team who saw the child said this is probably not significant. Next slide. So a diagnosis of CDA was put on, and this meant that the child would be on lifelong transfusion and chelation, or an alternative would be an allogeneic stem cell transplant. Next slide. Here's where crosstalk comes. When the child came to me, that retic of 7.8 hit me in the eye, and I said, this cannot be a CDA with a 7% retic. So I picked up the phone and talked to the molecular biologist, and he said, Maman, let me redo and recheck parents and the child. And the same change that was described in MedGenome was found in ankyrin, and this time they put likely pathogenic. Why? Because they found papers which in fact showed, and that's the reference given below by Park, that this particular genetic change was not a polymorphism, but was most probably pathogenic, and they had seen patients with hereditary spherocytosis with this mutation. Next slide. Now this is the algorithm, which I won't go into, but it tells us that we must beware of the child with anemia who has been transfused. That's my addition to the algorithm. Transfusion alters the picture and you go off the mark. Next slide. Next slide. Ordinarily, we would use an osmotic fragility test. I'm afraid this is given up now. And in a multiply transfused child, the osmotic fragility will not be helpful. Next slide. So these are some of the other tests which we use, an ALGT or an eosin maleimide. Most centers today would use an eosin maleimide by flow cytometry. Next slide. This is the red cell membrane. You can see that there is a phospholipid bilayer, and within the phospholipid bilayer is band 3, and you can see that band 3, my pointer isn't working. I do have it. It's band 3, and you can see that ankyrin is what links band 3 to spectrin, alpha and beta spectrin, which is the cytoskeleton of the red cell. There's a small protein here called 4.2, which links band 3 to the Rh complex and to ankyrin. Next slide. So mutations of ankyrin, of band 3, of alpha or beta spectrum, or protein 4.2, any of these mutations can cause hereditary spherocytosis. And in this case, it was an ankyrin mutation which was responsible for the phenotype of HS. Next slide. So the diagnosis now changes from CDA to congenital hemolytic anemia with an ankyrin mutation. And he's a case for splenectomy. Next slide. Which was done. And please go back to the previous slide. And this child was again tested in April of 2024. Hemoglobin 14.3, no transfusion requirement, normal. Next slide. So what does this story tell us? One, beware of making a diagnosis in a child with anemia who has been transfused. Two, when requesting for molecular tests, provide an accurate history and your thoughts on the possible clinical diagnosis. Pick up the phone and talk to the molecular biologist. That crosstalk is essential. And what has it done for this kid? It has made a difference between either lifelong transfusion or an allotransplant to a simple splenectomy and a normal life. Next slide. I'm going to give you another child who presented with pancytopenia at 8 months of age. This case illustrates the importance of careful history taking. Next slide. This kid went to a doctor in Kolkata with history of being weak in November 24. On examination, he had a hemoglobin of 4.3, a platelet count of 10,000, a WBC of 5,000. We don't have the differential. He was transfused with packed cells and started on some tablets, which are not mentioned, and he was referred to some other center for further evaluation. Next slide. The kid comes to CMC in December. A month later, his WBC is now 9,000. His platelets have improved to 76,000 and his HP is 8.5. And there were no abnormal cells in the peripheral blood. Next slide. Because the retic was slightly elevated and they were not sure, they did a bone marrow. The bone marrow showed erythroid hyperplasia in a very cellular marrow. Trophine was not contributory, so they asked for an NGS. And what was the NGS? Hemolytic anemia. Why? Because the retics were 7% here. And the child was sent home on folate. Next slide. He came back in January with a white cell count of 20,000, a platelet count of 8,000, and a hemoglobin of 9.6. And the peripheral smear showed 59% plus. Next slide. So, on looking, mom brings out all the medicines she has received. And when you sort through those medicines, you find that the child has been on prednisolone, 2.5 milligram, thrice daily for 10 days in November. Please remember that even a short course of steroids can make the blast go away in a child with ALL. The child then presents to the next physician with cytopenia and a recovering marrow with increased retics and no blasts. So they say there's nothing. So this child illustrates the importance of taking the history, of carefully checking the medication that has been given. And at that time, even though when the child came to you for evaluation, there were no blasts, you would have put a rider. This could be a partially treated acute lymphatic leukemia. Next slide. Next slide. This lady came to me with pruritus. She was 53 years old and she had been on Livogen for an anemia and she was on Ecosprin, but her pruritus was not getting better. Now, my dermatologist sits across the corridor and she sent the patient to me. Next slide. Hemoglobin 10.7, MCV 53.9. White cell count, next slide. 12.2, platelets 540, slightly raised. Next slide. LDH 214, ferritin 54. So it's not iron deficient, but the MCV is so low and the hemoglobin is only 10.7. And this lady is presenting with aquagenic pruritus. Next slide. Did a next-gen sequencing to look for JAK mutation, and lo and behold, JAK mutation was present. So here it illustrates the problem that, next slide, this shows the reason for her low MCV and the hemoglobin of 10.7. She is homozygous hemoglobin E. Next slide. So in clinical medicine, the golden rule is make a unitary diagnosis. Coexistence of two clinical conditions must be considered, and this can modify the phenotype. So she had PRV, but the PRV didn't present with a high hemoglobin because she was homozygous hemoglobin E. And aquagenic pruritus was only the trigger, was the only trigger to consider polycythemia rubra vera and initiate JAK mutation testing, which was positive. Next slide. Case 4 is the importance of keeping your mind open to new entities. And this is of a young lady, Sutapa Jana. Next slide. So this is her, and this is her father, and this I thought was her brother. Next slide. So she presented with a 4-year history of recurrent skin lesions and a 10-year history of recurrent swelling in the neck with fever and sore throat. She had come multiple times to CMC, had been admitted in ENT, had been admitted in dermatology, and the small piece of land that they had was sold so that by the time they came to me, they had no money left. Next slide. This was a lymph node biopsy in the neck. It was positive for EBV. Next slide. It was strongly positive for CD20. Next slide. And CD30. So one would have said this is Hodgkin's disease. But I called my pathologist. She said, no, I don't think this is Hodgkin's disease. So then what is it? Recurrent sore throat, nodes in the neck, EBV positive, CD20 positive, CD30 positive. So go to the books. Fortunately, we don't have to go to Index Medicus now. The computer gives us everything. Next slide. So I was not sure what was the diagnosis. Next slide. These were the investigations, and you can see that her EBV titer was 7,55,433 copies. Next slide. Immune screening for an immune deficiency disorder was negative. Next slide. So this patient had a condition which I had never seen, and it's called CAEBV, chronic active Epstein-Barr virus infection. And these are the WHO criteria for making this diagnosis. Next slide. She fulfilled all the criteria. So even at this stage in my life, I'm learning new things because constantly you're asking, what is the diagnosis? What is going on in this patient, right? Now, how to treat this patient? Why is the Epstein-Barr virus not getting killed by her own immune system, and I am unable to pick up an immune deficiency disorder? So how do we treat post-transplant lymphoproliferative disorder, which is EBV driven? We give rituximab, and the rituximab gets the virus out of the cells, and then this was something we thought of doing, was to add checkpoint blockade to make her T cells go and kill the virus-infected B cells. Next slide. And just to remind you, nivolumab is a great treatment for EBV-induced HLH. We learned this a bit late and we lost a patient. But if you ever have a patient with HLH, which is EBV driven, the treatment today is with checkpoint blockade. Next slide. So the other drug that can be used is sintilimab, which is also a checkpoint blockade inhibitor, but an antibody. Next slide. So this lady, it's fortunate I have friends all over the country, many of whom are my students. And this patient went back to Calcutta, and under Swasthasati, she got rituximab and nivolumab, and her viral titer came down to 7,000. But this is not going to cure her. So she's being planned for an allogeneic stem cell transplant. Next slide. Now, the boy whom I showed you in the picture was not her brother, but it was her boyfriend. And they were childhood lovers. And he was the one who was bringing her for treatment and evaluation because he had a steady job. So the moral of the story is you must have someone to care for you. And it's great to have students all over the country whom you can reach out to. And you're never too late to learn, which I will show you in the next slide. Next case also. Case 5 again illustrates that you're never too old to learn. Next slide. This kid is 17 years old. He has thalassemia. He's on deferriprone. And he came to me with this skin rash over his legs. So I called my colleague who's across the corridor, Dr. Renu George. Please, can you tell me what's going on? She comes in, next slide, with an instrument called a gonioscope. Next slide. And this is at a low power looking at the skin lesion. Next slide. And this is what you see. You see a perifollicular hemorrhage and you see a corkscrew hair sticking out of the follicle. I believe this is pathognomonic of scurvy. So at 75 years of age, I am seeing my first case of scurvy with a perifollicular hemorrhage and a corkscrew hair, which I never knew anything about. Next slide. When we were students, we had a teacher who used to tell us about history taking, where he said, you must ask the patient whether he has been on a long sea voyage without the limes. This was ML Tiku. Obviously, that doesn't apply to today, but to keep in mind, next slide, that a patient with thalassemia who is being chelated can become vitamin C deficient. And these are all the interactions between vitamin C and iron. Vitamin C enhances iron absorption. It shifts intracellular iron to the extracellular compartment. It's very important in the Fenton reaction. So if you give too much vitamin C to an iron overloaded patient, you will generate free radicals, which can cause tissue damage. And this is the important association. So here in this kid, he was chelating not only his iron, but his vitamin C, and he developed scurvy. Next slide. This is Linus Pauling, who's one of the few people who got the Nobel Prize twice. And he's the one who told us, not correctly so, that vitamin C is good for the common cold. He got the Nobel Peace Prize in 1962. Next slide. So in conclusion, with these 5 cases, I want to try and tell you that in this era of MRI and PET and all the rest of it, we don't take a history, we don't examine a patient, and we cause great harm. So knowledge is precious, and we can help many if we have it. Thank you very much.
It's an absolutely delight to hear Professor Maman Chande sir. I really love hearing. Can we say the stalwart at the age of 75 or 80 and speaking to us? Can we all stand up and give a big round of applause to Padma Shri Maman Chande sir? When I speak these words, his energy and his enthusiasm takes us to the new level, sir. I must say, Most of
Thank
us,
you very much.
the ones who are standing here and majority of us who know you, we really believe one gentleman who probably deserves the Bharat Ratna in medicine is none other than our sir. One big round of applause, and I would request Ganesh to say a few words. Being his teacher, one thing which I have learned is yes, care, compassion, and consistency, even at the age of 75, to learn so much things, and inspiring all of us continue learning with all. And absolutely, when he says, even when PET and MRI has come, don't stop looking at the feet and going deeper and connecting with your colleagues from different background and the field. So thanks a lot, sir. We just loved it.
Thank you. Bye-bye. Thanks, Ganesh, for inviting me.
Thank you so much, sir. It was such a privilege and blessing to have you, even though speak virtually. Actually, we were supposed to have sir here physically, but in the last minute because of the family issues. But looking at sir's presentation, one thing is very eminent. At post-retirement, 78, 80s, when sir is presenting a case, the
Thank you,
curiosity,
Ganesh. Thank you very
the
much.
passion, the enthusiasm, and the the what you call it as the zeal to dig out the mystery puzzle underlying each case. And that's a huge source of inspiration, motivation to all the students in this auditorium. And really, sir, it is one of the most, what you call it as memorable and most impactful lessons and lectures of our life. Thank you so much for this honor, and really look forward. We all wish and pray for your long cherished health to bless and guide us, thousands of students across the country continuously through your teachings and through your inspirations. Thank you so much, sir.
Thank you.
Thank you, sir. Thank you so much, Chandy, sir. That was wonderful to listen to you. And it was such a clear message that history and what we have knowledge is so precious. Yeah, history taking is an art. The generation has moved to a next gen sequencing or whole exome sequencing, but we are supposed to look at the history. Because the leukemia case, what you shared, we have been seeing this over the times, and the steroids that are not to be given at the first instance, we are experiencing them here and then. So it was a wonderful message once again, and it is good to learn from you, sir. It is a privilege for us to have you today. Thank you very much.
Thank you so much. Thank you very much.
The next session, can I kindly request Dr. Chandrakala S. from KEM Hospital, Mumbai, Professor and Head Department of Hematology, KEM, Mumbai. The financial capital brings the right kind of energy to all of us out here. So we request ma'am to proceed with her presentation on TTP Unveiled. Thank you, ma'am. Ma'am, can you bring it closer to your mouth, please?
Yeah, I hope you can hear. Yeah. So I thank Ganesh and the organizing team for arranging a wonderful meeting. And in the next 15 to 20 minutes, I'm going to talk on importance of diagnosing TTP, only how important to diagnose and how to refer, when to refer the TTP patients. So as you enter this hall, you are seeing the RBCs are a small blood vessel. When it blocks, the knowledge that the oxygen gets blocked. That's how the small vessels get blocked and causes the ischemia of the heart, brain, and the kidneys. That leads to our TTP. So this is how my talk layout is. What is TTP? How does the clinical presentation? Importance of early diagnosis. What is the clue to the early diagnosis, like plasmic score, principles of management. So this is also one of the 100 years of TTP celebration, because about 100 years ago, Elis Moshowitz is the first person who described the TTP in a 16 years girl. So it's actually apt to discuss the TTP now. Coming to the first case, this is 32 years female, presented at 28 weeks of pregnancy, referred in view of thrombocytopenia. There is no history of bleeding, fever, nothing. No history of similar complaints in the past. No pallor, no icterus, no organomegaly, hepatosplenomegaly. This is one of the commonest reference we see in our outpatient clinic. Pregnant lady referred with thrombocytopenia. And these are all the causes it can happen, from varying from B12 deficiency to ITP to gestational thrombocytopenia, drugs, and as actually we may see sometimes leukemia also in these pregnant females. So, but our patient do not have any other symptoms or any other signs like hepatosplenomegaly. So, the most common what we think, you can see hemoglobin is 12 grams, WBC count is normal, and only platelet count is 80,000. Even the smear is normal in this patient. The most likely cause in this patient is gestational thrombocytopenia, otherwise dilutional thrombocytopenia. And for this, the patient keeps on actually sending to hematology for the consultation because of thrombocytopenia. So this doesn't require any treatment, or it can be other thing is, it can be the thrombocytopenia because of the platelet clumps, or it can be platelet satellism. You can see here the platelet satellism you see in patients of pseudothrombocytopenia, and we have sometimes called as a large platelets. So these are all the cause of pseudothrombocytopenia. So the first case is simple. There is no need for treatment, and patient can continue pregnancy and delivery in this patient. Coming to the second case, is 28 years female, again presented at 30 weeks of gestation. In view of thrombocytopenia, patient is referred, and patient has got fatigue and occasional giddiness, had complaints, and BP was 140/90. And then we have a list of hypertensive disorders of pregnancy having the complication of thrombocytopenia. The most, which is very least complicated, is the HELP syndrome. HELP is hemolysis, elevated liver enzymes, and low platelet count is the one of the differential diagnosis for this patient because she has thrombocytopenia and hypertension. And the next can be preeclampsia, and we have a patient who is more than 20 weeks of gestation, and BP, she is hypertensive, and we need to test for either proteinuria or renal dysfunction. So any of these things fit, we can call it as preeclampsia. And we have something called as eclampsia, which has got organ dysfunction. If associated with a thrombocytopenia, hypertension has an organ dysfunction, then it becomes eclampsia. The most dangerous one is acute fatty liver of pregnancy, and patient can present in DIC also. So in this, we need to treat this patient. How do we treat? You treat the hypertension, and if the patient is uncontrolled, like acute fatty liver of pregnancy or eclampsia, then you better deliver the baby. That is the treatment for these conditions. Coming to the case, which is case 3, she is 28, again a female, presented 6 weeks after IUFD, intrauterine fetal death, with fatigue and weakness for 6 days, yellowish discoloration of eyes. Family also complained that patient is not sleeping well for more than 24 hours, and hallucination intermittently she had. And in the hospital also she had irrelevant behavior. So all these things were attributed to that she has a postpartum depression because the patient, she had IUFD, and she had history of bluish patches on the lower limbs. The BP was normal, CNS examination. So she has clinically, she has got fatigue, anemic symptoms, she has icterus which shows hemolysis, and she has a vague CNS symptoms that can be so mild, like such a mild, the patient is not able to sleep, patient can have hallucination, it can be, TTP can be so mild. So that's how the patients can present with the TTP patients. So it can be differential diagnosis. ITP is unlikely because patient has symptoms of anemia, and patient has got little altered actually in the form of hallucination. So we don't think it is ITP. The next is TTP, maybe a differential diagnosis. We'll see in the next few slides how do we think about TTP in this patient. Is it possible to have a DIC? It's about 6 weeks post delivery or IUFD. So DIC, patient is clinically stable without any organ dysfunction, so less likely to have a DIC. So these are the 3 differential diagnoses we have to consider when the patient comes to you with an ITP with the postpartum IUFD. ITP, why? Because they may have Apla syndrome and then having an ITP. So we'll investigate this case. So clinical history, what we have to point out is fatigue, weakness, hemolysis, and increased creatinine, and family also complained of patient is having hallucination. So our investigation, you can see hemoglobin is 9.2 grams, white blood count is normal, and platelet count is 35,000. And we need to investigate other investigation, like look for hemolysis, is LDH is high, haptoglobin is low, intact hyperemia she has. And then The other thing you can see, the coagulation. We ruled out the ITP because smear we saw normal, and the hemolytic parameter she had, and to rule out the DIC, the most important to the PT, APTT, and the INR D-dimer. So these things are normal in this patient. So we have a patient, anemia, thrombocytopenia with hemolysis, being a coagulation parameters are normal, and the pathologist coming to the great help for this patient. You can see classical cystocytes. You can see cystocytes and the spirocytes. The platelets are also you're not seeing. Sometimes you do see a platelet count because the smallest cystocyte, the helmet cells, can be counted as platelets in the cell counter. So always just look at the smear when you're having a TTP patient. So this is a classical picture. When you have any patient like this picture, you immediately call up your clinician and go ahead for the treatment in this patient. So we have a points to be noted in this case is fatigue, weakness, anemia, hemolytic, creatinine is high, and coagulation workup is normal. So that leads to a diagnosis of thrombotic thrombocytopenic purpura. So TTP is a life-threatening thrombotic microangiopathy characterized by severe thrombocytopenia. MAHA is microangiopathic hemolytic anemia, widespread microvascular thrombosis due to deficiency of enzyme ADAMTS13. So the deficiency leads to what happens to this deficiency causes is ultra large VWF molecules are there, and that doesn't get cleaved into VWF molecules, and that forms it has got a very high affinity to platelets and form the microthrombosis affecting the brain and the other organs. The severe deficiency of ADAMTS is less than 10% is a diagnostic of TTP. It can be due to two causes. Either it can be congenital TTP or it can be antibodies. That is the immune TTP is immune thrombocytopenic, thrombotic thrombocytopenic purpura is the most commonest cause of TTP. So in this picture you can see these are in normally what happens is these are all ultra large VWF molecules. When you have this ADAMTS, it breaks the molecules, cleaves the molecule protein, and then it leads to circulating normal VWF multimers. In a patient of TTP, when there is no ADAMTS, this large, ultra large VWF multimer, they bind to platelets. This yellow one is bind to platelets and form the microthrombi leading to ischemia. So this is the pathophysiology of TTP patient is absence of the cleaving protein or the ADAMTS protein, either because of the absence or because of the antibodies. So this is the first person who described TTP is Elise Mashkovitz, and it's about 100 years, and he described in a 16 years girl who died, and it was diagnosed at autopsy like hyaline thrombosis of the terminal arterioles and the capillaries. You can see in this patient. So what is the importance of diagnosing TTP early is the mortality. If you diagnose TTP, you have to treat immediately. If you don't treat immediately, the chance of mortality is 90%. So the mortality of TTP without treatment is 90%. And with proper treatment, that mortality reduces to 10 to 15%. So you can make a break with a simple diagnosis of peripheral smear and a CBC. You don't need very hi-fi investigations to diagnose TTP. This is the reason we have to diagnose TTP patients early. So what is the epidemiology of TTP is? It's a very, very rare disease, and the incidence about 2.8 per million in adults, and it is also seen in pediatric patients, but it's quite rare for the pediatrics. The average age is about 40 years of age. It's more common in females, especially during pregnancy. So that's what happens in the TTP. And you can see this is a picture which shows, these are all, if you consider about 100 patients of TTP, these are all the adult TTP, and the circle one is the childhood TTP. And among these, it can be either inherited TTP or the acquired TTP. So the inherited one is only this much. You can see inherited in either adults or the pediatrics. It doesn't mean that pediatrics only has the inherited TTP. Sometimes we do have pregnant females who comes to us with the TTP and then diagnosed to have a congenital TTP. So that we need to, that it may adults also can have congenital TTP. So cause of TTP, either congenital TTP, primary TTPs, we don't have any underlying condition. Patient has got deficiency of ADAMTS levels because of the antibodies. Secondary is because of the multiple autoimmune conditions. It can be pregnancy, or it can be SLE, or it can be anti-cancer drugs or medications, or systemic connective tissue disorder. So these are all the causes of TTP in a patient when you have. So we need to work up when the patient comes to us with the TTP. So the most common you can see is primary immune mediated when there is no underlying cause but the patient has got antibodies. The next most common cause you can see autoimmune disease, HIV and kinetoral deficiency caused to about only 5% of the constitution of all the TTPs, kinetoral TTP. So the most common clinical presentation is gastrointestinal symptoms, abdominal discomfort, fatigue, weakness. Purpura is only present in 54% of the patients. It can be as mild as minor neurological symptoms like headache, confusion in 26% of the patients, coma, stroke, seizures in about 40% of the patients. And the classical pentad, what we have read, is only present in less than 10% of the patients of TTP. So the clinical spectrum of TTP is you can have either, we had a patient of pancreatitis and the gastroenterologist called us for thrombocytopenia, and before the patient was diagnosed, patient died within few hours of diagnosis of TTP. So the pancreatitis is one of the things which can be because of the necrosis in the pancreas can be caused by TTP, or it can be kidney injuries. Most common is the CNS involvement, and patient can have a heart failure and they can have a myocardial infarction because of TTP, or the DVT is also one of the manifestation we see in these patients. So the classical pentad comprising of hemolytic anemia, thrombocytopenia, fever, acute injury and severe neurological abnormality is present in only less than 10%. So you don't have to wait for pentad to diagnose TTP, and so this shows that we are not waiting for pentad because it is only present in less than 10%. So what do we need is only the features of hemolytic anemia and thrombocytopenia with the presence of cystocytes. Only 2 features are enough to diagnose a TTP in a patient who is suspected to have TTP. So don't wait the patient until they develops the pentad features. So act on this time and then patients can have a better prognosis. So how to suspect TTP? This is a very well plasmic score which is available. Everybody is used to use phone. You can calculate and the Medcal is available, and you can have a 7 criteria to diagnose TTPs or suspect TTP is platelet count less than 30,000, features of hemolysis, no active cancer, no history of transplant, MCV is less than 50, INR is normal, creatinine is less than 2, and then you have different points. You give each point, each feature is given 1 point. If the patient has got 6 to 7 points, the chance of having Adam TS levels less than 10% is 90%. So if somebody has got 6 to 7 points, don't wait for the protein levels, start the plex. So that's the importance of identifying the plasmic score in a patient when you have a suspicion of TTP. So the diagnosis is mainly CBC, peripheral smear, and the hemolytic markers, renal function test, coagulation test, and you have a Adam TS13 testing, it an antigen testing, and the antibody testing. So this is the test which is not routinely available easily, but on this basis, using a plasmic score, you can start the treatment and send the sample for Adam TS levels. Again, you need to know how to send the samples. It's about you have to collect in a citrate sample, and it should be centrifuged, and then you transport the sample wherever the test is available. And you differentiate between TTP and HUS is very, very important, because when you diagnose TTP, you need to start the plex. But when you have a HUS patient, moral renal dysfunction, they might respond to hemodialysis. So the principles of treatment is plasma exchange is the only which is important, which and the steroids, which will plasma exchange is to remove the ultra large VWF multimers. Steroids is to suppress the production of these antibodies. So this is how you treat the patients of TTP. You start the plex. So the plex is to remove the ultra large VWF multimers. That's how we treat the patient of TTP. And you see, as soon as you start the plex, the platelets beautifully going up. So even a few days, after 24 hours of plex you start, the patient neurologically drastically improves. So that's also one of the diagnosis point you can have in TTP patients. So this is an approach, and I'm not going to details of these things. Again, the lot of recent advances are happening in TTP. When we had a first report which had a 90% mortality when we had in the initial days, now only less than 5% mortality because of early diagnosis and the better treatment for the patients of TTP. We can also use rituximab if the patient has got immune TTP, and it can be used when the patient is not responding to plex or the patient has got a relapse. There's a new molecule which is available, is a caplazimab, which is an antibodies to VWF can be used. So my last slide is what are the do's and don'ts in TTPs? Do's is start plex immediately, and it is only if it is a life-threatening need, give platelet transfusion. Otherwise, don't give platelet transfusion in a patient of TTP. Misdiagnosed as DIC or HUS is one of the most common things which is seen in ICU patients. Check the levels of antigen and use the plasmid score. And use of heparin is not indicated unless the patient has got venous thrombosis and the platelet count is more than 50,000. Aspirin is also not recommended. If the patient has arterial thrombosis and platelet count is stabilized, then you can give. Using a IVIG cyclophosphamide as a first line is not the one. Use rituximab or a plex as the first line treatment. Don't ignore the relapse rate. Monitor the patients because patients can have a congenital TTP. The patient I discussed started is she was diagnosed, she was managed initially with steroids. NGS was sent and she had a mutation which was autosomal recessive. She had a compound heterozygous mutation, and we managed throughout her pregnancy with the plasma infusions, and she had a normal delivery. So right management can save the life of patients of either congenital TTP or an acquired TTP, like an immune TTP. Again, I thank for the patient hearing. I'm happy to answer any questions.
That was a wonderful presentation, madam. And any questions from the audience? Yeah, that was a wonderful one. Only one question for my end. Like when you said it is like rituximab, it is for the refractory cases as a first line.
Yeah. It is actually, there is the evidence is mainly for the refractory cases. The definition of refractory is usually when the patient doesn't respond after 5 plexes, then you can give. Or if you are expecting, you are monitoring the levels of ADAM-TS levels and the patient has got the dropping levels of less than 10%. So at that time, clinically stable patient, that patient also can be given rituximab. Or somebody is expecting pregnancy and you can give rituximab and after about 6 months they can conceive. So these are the few indications we can give rituximab.
Thank you so much. So we'll move on to the next session. We have indications for bone marrow studies by Dr. Rajeev De, NRS Medical.
I thank all the chairpersons and speakers. I humbly request them to collect the mementos at the memento desk next to the photo booth. And now let's break for tea for 10 minutes and we'll resume after that. Please move to your right side and proceed towards the exit door.
Lectures and presentations, and I'm really grateful for the talk, sir. It is very
art and so this has generated such an enthusiasm. 200 plus so you're saying it could be delayed presentation or everybody was standing and were clapping for so it has nothing to do with the brain and kinetic ability. Thank you so much. That is the most valued lessons of our lives, and it is really wonderful, sir. Thank you so much, and please take care, sir. And we missed you this time, and looking forward to. Yes, sir. Yes, sir. Thank you, sir. Thank you so much, sir. Thank you. मोहम्मद सर का टॉक था अभी 250 लोग 4 मिनट खड़े रह के स्टैंडिंग ओवेशन। मैडम चंद्रकला मैडम क्या टॉक था मोहम्मद सर का, वन ऑफ द फाइनेस्ट मेमोरीज ऑफ आवर लाइफ। मैडम जब वो प्रेजेंट कर रहे हैं ना केस, क्या क्यूरियोसिटी एंथुसियाज्म है।
Yes, yeah. He is so curious. He is only the
एंड मैडम देखो 80 साल की उम्र में देखो पैशन वो, और हम लोग तो स्क्रीन लीवर तो छोड़ ही दिए, बट क्या है यार, और छोड़ते नहीं किसी केस को। देखो जिसको सीडीए बोला फट से निकाला सर ने पकड़ के, सारे केसेस ऐसे ही। बट द टॉक रियली मैडम, ये अपना कॉन्फ्रेंस का धन्य हो गया, और सर का टॉक भी मस्त था। नॉलेज इज प्रीशियस, इट्स लैक कैन कॉज हार्म।
If you have it, you can help people. If you don't have it, you can't.
कहाँ जा रहे हो? मैडम को छोड़ के, मैडम मैं बहुत रिक्वेस्ट किया मैडम कल से ले जाते हैं, बट मैडम थैंक यू सो मच, वेरी नाइस फैंटास्टिक। मैडम तो मैडम आई हैव नो वर्ड्स, हमारे गलतियों की वजह से मैडम कल का सेशन हमने आज मैंने एक्चुअली मैडम इन द फर्स्ट प्रोग्राम इट वाज सेकंड डे, बट व्हेन वी फाइनलाइज्ड इट somebody called me yesterday that actually can you practice for me actually for
Patients and
check, check, check.
కల్లా కుప్పలు ముంచేస్తారు సార్ మమ్మల్ని. నేను సరే తీసుకుని ఇక్కడ వాటర్ అయిపోయి 4 సార్లు కాలేదు తాగుతూ ఒక్క రౌండ్ పోయేసాను ఇలాడి ఒక్క రౌండ్ తీసేస్తాను ఒప్పం గుంజుకొని చీర గుంజుకొని పోతున్నాడు. నాకేం కాలేదు, నాకు పెద్ద విషయం లేదు. ఈ విషయం చూడండి డైరెక్ట్ ఎవరికి కొట్టలేదు.
Sit here only, then we will move on to another person. Okay, come here.
We'll move on to the session 4. I would like to call the chairpersons for this session. Dr. M. Venkataramana sir from Nizamabad, Dr. Sanjay Padalwar sir from Lotus Hospitals, Nanded.
So good evening, everyone. Let us start our session post tea. I request today's speaker, Dr. Rajiv Degaru, to come on to this dais and deliver his talk, Indications for Bone Marrow Studies. Sir is from Calcutta. Sir, the stage is yours.
Very good evening to everybody. I express my regards to the organizing committee of this mega Deccan Hematolink, and especially to my friend Dr. Ganesh Jaishetwar, with whom I spent a lot of good and bad old days. I also thankful to Dr. Ganesh because giving me the opportunity to read the indications for bone marrow studies for the first time. Because we get so many requests to do bone marrow examination, bone marrow aspiration, and bone marrow biopsy, whether you are in an academic institute, you are doing private practice, or in your own clinic. So actually we need to know the indications for not doing bone marrow studies. So let's start with the few case series. One is 2.5-year-old girl, then the case is a 10-year-old boy, then 16-year-old boy, and 56-year-old female. So let's start with 2.5-year-old girl, who are presented with a 10 days history of fever above 102 degrees Fahrenheit, treated with oral antibiotics, no weight loss, unusual fatigue were reported. General examination showed pallor, few enlarged lymph nodes, cervical supraclavicular. Systemic examination, mild hepatosplenomegaly and icterus. And these routine diagnostic workup was done, complete blood count, routine biochemistry, LDH, blood culture, Vidal test, and USG. The patient progressed to pancytopenia, and this is the CBC report. That is hemoglobin 10.1, TLC 1770, low NC, low platelet, LDH high, AST-LT high, and ferritin is 5,800. Vidal test was positive. And so as the patient developed pancytopenia and having persistent fever, the bone marrow was done, and bone marrow showed the presence of hemophagocytosis. And supported by the biochemical parameters, low fibrinogen, high triglycerides, so it was a secondary HLH, maybe secondary to the enteric fever. Then it's a case of 10-year-old boy presented with again fever, neck glands, bony pain, gum bleeding, peripheral blood showing again pancytopenia, but with atypical cells, 65%. Bone marrow was done. Hypercellular marrow, 65% blast, IPT done. IPT showed that it is a case of acute leukemia and possibly acute promyelocytic leukemia, and it was confirmed by the molecular study. Bone marrow aspiration was done. So all these investigations was done and the diagnosis was confirmed. Then 16-year-old boy presented with severe pallor, purpura, liver spleen not palpable. Again, pancytopenia, evaluation was done, bone marrow biopsy. Bone marrow biopsy showed hypocellularity. Karyotype was normal, but stress cytogenetic shows the triradials diagnosed as Fanconi's anemia. Then came this old female, again, anemia requiring blood transfusion, pancytopenia. As there was a pancytopenia, bone marrow aspiration biopsy was done, and it showed this erythropoiesis, this hematopoiesis, increased storage iron. CD34 count shows an increase in blast count, and there was a series of abnormal cytogenetic abnormalities and diagnosed as MDS IB2, increased blast 2. So the patients of different age groups presenting with pancytopenia undergone bone marrow examination and having different diagnoses, having different line of treatment. So our godmother Barbara Bain said, a request for bone marrow examination should be regarded as a request for a consultation on the patient in question and not simply as a request to carry out a technical procedure. So we need to keep in mind that bone marrow procedure is not a technical one. It is a clinical decision. So when you are advising for bone marrow, basically you ask for the clinical decision on that particular patient. Then very basics, we know that bone marrow, blood producing factory, produce RBC, WBCs, huge number of RBC granulocytes and platelets are produced. These cells are there in the bone marrow from hematopoietic stem cells to mature cells, but your industry can be in trouble. So when it is in trouble, it can be closed, aplastic anemia. It can produce abnormal precursor cells, leukemia. It can produce an abnormal finished product, myelodysplastic syndrome. So on all these cases, bone marrow examination is indicated. And this is the journey of bone marrow examination, starting from clinical indications, specimen collection, processing, interpretation, and reporting. And these are the basically indications for bone marrow aspiration. It may be anemia or cytopenia, but not all anemia or cytopenia are indicated for bone marrow aspiration. Abnormal peripheral smear, lymphoma staging, unexplained fever, PUO, and stem cell harvesting, increased storage iron may be a cause of doing bone marrow examination. Mass lesions, organomegaly, bone marrow infiltration, and metastasis. So these are the indications, but there are some caveats into it. So when you decide to do bone marrow examination, you need to go through these steps, that is aspirate, biopsy, and then gradually processing, and then the reporting. Site, most commonly the posterior superior iliac spine. You can choose anterior superior iliac spine if you can't access posterior superior iliac spine. Sternum, usually done previously and mostly by the non-hematologist. It is not favored because we can't do biopsy from sternum. These are bone marrow biopsy needles, procedure, and there are indications where how many slides needs to be collected for aspiration and biopsy. And you need to collect not only for the morphological examinations, but also for other tests. That's why you need to have EDTA vials in hand, heparin vial in hand because of the cytogenetic study and fish studies, and then bone marrow preparations. So usually we do bone marrow aspiration, biopsy, imprint smear, and if it is a clot, then clot sections. So in that way, you need to collect samples. You need to collect an adequate samples, at least 1.5 to 2 centimeter long bone marrow biopsy for getting an adequate sample. And this is the adequacy. At least there should be 6 trabecular spaces for a proper representative bone marrow. And you need to assess the cellularity depending on the age. This is the aspirate, touch smear, trephine biopsy, clot section. And so all these should be done while you are doing bone marrow aspiration plus biopsy. And depending on the age, there are the differences. This is the right side, left side, there is a normal bone marrow. It is a hypocellular bone marrow, and right side is a hypercellular bone marrow. And all the bone marrow biopsy samples should have a reticulin stain done and may require a immunohistochemistry. So these are the all standard investigations which should be done from the bone marrow, not only the morphological, but also reticulin, cytochemical stain, immunohistochemistry, and fish and molecular diagnosis samples needs to be collected in specific indications. There are pros and cons of bone marrow aspirate and biopsy, but it is a complementary. In most of the cases, we do it together. But before doing the procedure, you need to take the consent, the written consent. It is very important, so don't forget it. And post-procedure management, management of the wound, management of the pain, that should be done properly. Contraindications for bone marrow, as there is indications, there should be some contraindications also. Main contraindications are some bleeding disorders, mainly the coagulopathies. So we need to keep that thing in mind. Then risk of anesthesia, then the local infections. These are the contraindications. And the low platelet count, thrombocytopenia, is never a contraindication for bone marrow. You can do bone marrow aspiration and biopsy with a 0 platelet count if you give a proper pressure and have a close watch to after procedure. These are in detail the indications. If we enumerate unexplained anemia, not all anemias, unexplained anemia, you have done all the basic evaluations, but then also you can't reach into the diagnosis. Unexplained macrocytic anemia, you have excluded megaloblastic anemia, folate deficiency, vitamin B12 deficiency, unexplained leukopenia and thrombocytopenia. Not all thrombocytopenia are indicated for bone marrow. If it is unexplained, then only. And if it is associated with other cytopenias, pancytopenia definitely, peripheral blood blast or abnormal cells, and peripheral blood, if you have a teardrop cells, have a spleen, you can suspect of having myelofibrosis, presence of hairy cells, multiple myeloma, suspected cases of multiple myeloma, staging for non-Hodgkin's lymphoma in specific cases, not aggressive and DLBCL, if you have an access to PET CT. If you don't have, then you need to do. Unexplained splenomegaly to rule out the indolent lymphoma. Then suspected storage disease, fever of unknown origin, and suspected chromosomal disorders. Confirmation of normal bone marrow in potent allogenic donor, we don't do that. But for the bone marrow harvest, we need to do a bone marrow, but that is a collection. And workup for amyloidosis. And there can be complications, post-procedure complications like bleeding, very rare. Only can happen if there is a coagulopathy. Then local infections and other neuropathy, osteomyelitis, prolonged osteomyelitis, the chances of complications after doing a standard bone marrow examination is less than 0.05%. There are some challenging situations I can explain. Again, the pancytopenia, all the pancytopenia are not indicated for bone marrow evaluation. Because pancytopenia may be because of the vitamin B12 deficiency. It may be because of hypersplenism. There can be a transient bone marrow suppression because of sepsis. So in all these cases, bone marrow evaluation is not required. If it is an unexplained pancytopenia, and if you really suspecting the bone marrow hypocellularity, hypoplasia, then we need to do a biopsy. That I already mentioned, that hypersplenism, infection, autoimmune causes, which can cause pancytopenia, it is not required. In anemia approach, in anemia also, unexplained anemia can, should undergo bone marrow aspiration and biopsy. In ITP, interestingly, in most of the cases, ITP doesn't need bone marrow aspiration and biopsy. Even if it is associated with anemia, it doesn't need a bone marrow evaluation. If ITP is associated with microcytic hypochromic anemia, it can be a simple iron deficiency because of prolonged menorrhagia or prolonged blood loss. ITP, if it is associated with microcytic hypochromic anemia, it can be simply thalassemia trait with ITP. So in those cases, if we can't rule out the other cytopenias in presence of ITP, then only bone marrow is indicated. There are some indications like age more than 60 years, prior to splenectomy, presence of atypical features, poor response to first line of therapy, that is IVIG, and relapsed ITP following CR. So these are the conditions where bone marrow evaluation is indicated, but in most of the cases, the bone marrow is mostly misused in case of diagnosing ITP. Suspected acute leukemia, we have to do it. Myelodysplastic syndrome, unexplained cytopenia, we have to do it. Not only morphology, but also for cytogenetics, FISH, as well as molecular studies. Pyrexia of unknown origin, it can be because of infection, hematolymphoid malignancies, some inflammatory disorder, granulomatous infiltration, as well as metastatic diseases. So in these cases, in PUO, bone marrow is indicated, and then not only morphology is sufficient, we need to collect sample from the bone marrow aspirate to do fungal culture and as well as the mycobacterial culture and AB culture. So that is required in case of PUO. In lymphoma, there is a different lymphomas have different propensities for bone marrow infiltration. Like Hodgkin's lymphoma, around 25% case have a bone marrow infiltration. In CLL, SLL, most of the cases have a bone marrow infiltration. In Burkitt's, there is a significant number, more than 80% patients have a bone marrow infiltration. In low-grade lymphomas, there is 20 to 30% chances of bone marrow infiltration. So in lymphomas, if it is an aggressive lymphoma in today's world of PET-CT, the indications are very, very limited. So in the initial assessment of cytopenias of unclear cause in lymphoma, we need to do a bone marrow. Inaccessible extramedullary site of disease. If it is PET negative DLBCL, then we need to do. But in indolent lymphoma, bone marrow evaluation is required because often it is not picked up by PET. Suspected storage disease, be it the Gaucher's disease, Niemann-Pick disease, it is required. So, to take home message, the bone marrow aspiration and biopsy are complementary to each other. Gone are the days when we do bone marrow aspiration only. And don't please ask for, please do the bone marrow. Please ask for consultation regarding the patient. And don't do bone marrow in the most of the cases as a first visit, during the first visit, and without doing CBC, which is a common practice in general practice as well as in institutions, especially if the prescription is done by your first or second year resident. Then you can see that in the OPD for the evaluation of anemia, there can be 20 investigations which includes CBC as well as bone marrow. And to do bone marrow evaluation only when it is clinically indicated and with no other indications, medical and non-medical. And we need to know when not to do bone marrow examination rather than when to do bone marrow examination. Thank you.
Thank you very much, sir. You have given a detailed things about the bone marrow, how the procedure and the indications and the contraindications and all the things. Any questions from the audience? If there are no questions, sir, because of the time shortage, we'll go for the next session. Thank you very much. Now we'll have a panel discussion on a common topic, pancytopenia, Parenteral differentials. I request the moderator, Dr. Biju George from CMC Vellore, onto the stage.
Thank you, and start by thanking Dr. Ganesh and the rest of the team for inviting me to this meeting. So we're going to be talking about pancytopenia. So we need about 6-8 chairs. Can we get the following panelists on top? Dr. Girish, Dr. Ashish Verma, Dr. Radhika, Dr. Vikram Sahu, Dr. Sandeep Nemani, Dr. Pujita, Dr. Basudev, Dr. Shirisha Rani, if she's here, and Dr. Balasaheb. Okay, we got about 6. I think nahi, आधा वहाँ लगा दो, and 3 here and 3 that side. Sit. So, sit here, there. Where's the rest? Anybody else around? Ashish? Radhika is in the other hall. Vikram? Okay, because of paucity of time, we will start with whoever is available. So essentially, we are looking at a case of pancytopenia, and I thought we will just go through what we do and how we manage such a patient. So this is a 20-year-old male presented with low-grade fever for 3 weeks, over the past 3 months had anemia requiring 2 units of blood transfusion, no bleeding episodes. He was evaluated at an external hospital, found to have a pancytopenia, and was diagnosed to have aplastic anemia. They did a next generation sequencing which showed RTEL mutation heterozygous, and so actually was referred to us for further evaluation and the possibility of undergoing a transplant. Clinically, there was no lymphadenopathy and no organomegaly. His initial blood counts showed a hemoglobin of 6.8, a white cell count of 3,800 with 24% neutrophils, and a platelet count of 52,000. So if I can start with you, Girish, when you see something like this, what are the other tests that you would like to do in terms of confirming the diagnosis? What are the initial lab tests that you would order? I think it's not on.
So when there is pancytopenia in young patients, most of the time what we do is first thing to get a retic count done, then order for a PBS, get a LDH done to rule out if there is any underlying B12 deficiency which can cause such picture. And if there are some symptoms suggestive, there can be some autoimmune pancytopenia, so we get initial ANA workup, or if there is fever like this, patient had fever, so some viral investigations like Parvo B19 and other CMV like investigations we need to do. And definitely a pancytopenia needs bone marrow aspiration and biopsy.
Okay. Now we'll come to bone marrow later. So anybody else in the group? So would you like to add anything more? How commonly do you do CMV for some? I know it's there in the recommendations, but do you do CMV as somebody who presents with pancytopenia?
Sir, not routinely, unless we are suspecting strongly or the basic workup is not conclusive of anything. Then we may think of it, but not as a routine, sir.
Not as a routine. Yeah.
Family history of any consanguineous marriage, that would also help in ruling out or ruling in the bone marrow failure syndromes.
So if you look at, and this I've just put up in terms of a diagnostic workup, this from Ami Dizan, a lot of things, but I think what is common in India would be, of course, autoimmune disease we need to worry, especially if you are a female. In terms of viruses, I think mainly hepatitis. So hepatitis A, hepatitis G can actually cause aplastic anemia, HIV, so that would be, and of course the other tests that go on. So this patient had a reticulocyte count of 2.4, MCV of 98, liver functions were normal, LDH was 212, virology was negative, ANA negative, B12 levels normal. So what would be the next step? I'll start with you, Radhika.
30 years male, right, sir?
20. 20-year-old male.
I missed the first slide, sir. I missed the first slide.
So this was 20-year-old male with low-grade fever for 3 weeks. No abnormal cells in peripheral blood. It just had 24 neutrophils and 76 lymphocytes.
Yes, sir. So it is a moderate cytopenias. Retic is 2.4. That could be attributed to the recent transfusions also. LFT, LDH is within normal limits. All the secondary causes of pancytopenia is ruled out. So the next thing I would like to do is probably he is in a florid sepsis. The cytopenias could be attributed to sepsis also.
So he had temperatures ranging between 100 to 101, but he was not chilling. He was actually looking very well when he was sitting in the OPD.
Probably in a background of 2 or 3 weeks of sepsis, if somebody develops moderate cytopenias, my strong inclination would be towards the sepsis-induced cytopenias. I would investigate this case as a pyrexia of unknown origin and get a marrow done as an evaluation for PUO rather than suspecting.
Okay, so you say marrow. Anybody would like to do any more blood tests before we go forward to a marrow? Anything else in mind? Anybody?
One PNH testing from the.
But you don't know, we don't, without a diagnosis?
The outside patient is already
outside diagnosed have aplastic, so okay, you can ask for PNH, I would accept that. They are all normal. Okay, so we've decided we will also, yeah.
So one ferritin also, because pancytopenia and the long-standing fever HLH we need to.
With the fever and the pancytopenia, the worry about also in terms of HLH. So we did a marrow, and this was what the marrow showed. The bone marrow aspirate showed a hypocellular marrow with mild dyserythropoiesis and suppression of all three lineages. The bone marrow trophine showed a varyingly cellular marrow with reduced trilineage hematopoiesis and mild increase in reticulin. They also said there is 1 to 2 ill-defined granuloma seen on the biopsy, and the pathologist put a note said to correlate clinically. What would you do next? Could this be MDS? We'll start with this, Girish.
So looks unlikely because there are no dysplasia mentioned here.
So they mentioned some dyserythropoiesis.
There is dyserythropoiesis.
On the erythroids, myeloids. Charles,
so only,
Deepak, come. You can also join.
So only erythroid dyspoiesis. There is no other, which can happen even in nutritional anemias as well. But the other lines looks okay, and we have granuloma and some reticulin. So probably some chronic granulomatous infection causing myelofibrosis can be a possibility. So we need to see whether there are any kind of myelophthic changes which we can see. In
there was nothing. Anything else?
So, but still we can have a consideration of hypoplastic MDS, even though things doesn't match everything, because erythroid dysplasia, as he said, can be there in acquired conditions as well, like tuberculosis. But still, a possibility we can keep of hypoplastic MDS as well.
Yeah, but in the background of 2 weeks of fever, for me, considering an aplastic or a hypoplastic MDS is my second diagnosis. So we have a hypocellular marrow with ill-defined granulomas, 2 weeks of fever. Probably I would think in terms of either an underlying COX or sarcoidosis or some autoimmune phenomenon.
Okay.
Like that.
So we also looked at CD34 staining that was negative, and because it was negative, now there, if you look actually in literature, they said mild dyserythropoiesis can occur in aplastics. If you get changes in the myeloid and the megakaryocytic series, more likely to be dealing with MDS. So we actually concluded it as possible aplastic anemia, but there were these 1 to 2 ill-defined granulomas that we saw.
Yes, sir. So in the background of these granulomas, and probably so whether we can get the CT of thorax and
I will
abdomen.
come to that. So we did a PNH. PNH was negative because we did an HLA typing. There was one sibling, there was no match. Then because outside they had reported this RTEL, we also send off an NGS, and the patient continues to have persistent fever. So what do we do now? Should we say that since there's no match, we proceed with ATG? Should we evaluate further for TB? Should we proceed with an alternate donor transplant since he is febrile? Or give the patient some danazol, stanozolol and wait, or any other suggestions? I'll go through each of you.
So we should continue evaluating for the tuberculosis because it is most common infection in India. Also sarcoidosis.
So evaluate for TB and sarcoid.
Yeah, so since there were granulomas, that is why. Otherwise, if the granulomas would not have been there, then I would have chosen.
Yeah, so there are ill-defined granulomas there. That's what put us also off. Any other, if all of you would agree, we would test for TB? Yeah.
Fungal also, granulomas, yes, sir.
Okay.
Fungal sarcoidosis, tuberculosis. I would put the patient on L-thrombopag probably as a bridging gap before I take.
His platelets were 52. He never required, he required 2 units of blood transfusion, never like platelet transfusion.
Looks like a non-severe aplastic as of now.
Yeah.
Okay. So we did HRCT, showed no lesion suggestive of tuberculosis. CT abdomen did not show any nodes. We did some induced sputum for AFBs negative. We actually did a repeat bone marrow to look for AFB stains, nothing. Cultures were sent. Midget was negative. There was nothing to suggest sarcoidosis. In that scenario, what do we do now? Should we proceed with treatment? Should we empirically treat for TB? Should we go ahead with alternate donor transplant? Should we wait with some oral drugs? What would you choose?
Sir, as cytopenia currently is not very severe, I would, in our country at least, I will give trial of anti-tuberculosis drugs. So first we will start AKT, and then slowly we'll see how things evolve over a period of 1 or 2 months. And depending upon that, we will take our chances of further treatment.
Radhika?
Even in our scenario also, an unexplained pyrexia for unknown origin, we always explore an option of
So you would
empirical
treat.
ATTs.
Deepak, any other options other than that? Or?
Sir, this patient also has a possibility of inherited marrow failure. If you are considering that scenario, I'll just closely monitor. If at all we are starting ATT, the liver function should also be monitored because.
So Girish and Pujita, do you have any other choices, or do you stick to the same?
Yeah, that's what, sir. Same.
Yeah. So from us also, we thought that, our logic was that this patient had actually adequate neutrophils. And despite that, if they had fever, it's not like a febrile neutropenia. Counts were stable, so we could give a trial of ATT and then see what happened. So we decided to give 4-drug ATT. We did not give any treatment for aplastic anemia because we were worried whether we gave danazol or the TPO agonist, whether there would be additional hepatotoxicity because of the combination. So once we started that, we just waited. And so there was defervescence of fever in about 4 weeks' time. And after about 2 months of treatment, he felt better. There was a weight gain of 2 kg. Unfortunately, his blood counts did not improve. They actually started worsening. He started requiring blood transfusions every 2 weeks, and then his blood counts dropped further. And this is what happened to him after 2 months of ATT. His hemoglobin was 6.2. His white cell count was 3,900, but with no neutrophils, and his platelets had actually dropped from the 40-50, which was, and it now had come down to around 10 to 12,000. He is afebrile. He's completed 2 months of ATT. So what would you do? Would you plan for ATG since 2 months of ATT has been completed? Or would you just continue ATT and wait? Would you give ATT and add on some oral drugs like L-Thrombopag? Would you consider an alternate donor transplant? Would you repeat a marrow, or any other suggestions?
So since patient symptomatically has improved, but the his CBC is worsening, so we need to check whether his those granulomas have progressed or what has happened exactly to the marrow. So I'll repeat a marrow to see whether there is a clear-cut aplastic picture or there is anything more to that.
Everybody would agree with that, or any other?
Patient has clinically improved, so I would like to continue ATT and add on some oral drugs like L-Thrombopag here. So.
You would add on some oral drugs like L-Thrombopag.
That's a 15,000. I'm more worried that here I'm dealing with a drug-induced cytopenias because clinically he responded. So tuberculosis COX is like responding. So mostly likely it's an ATT-induced cytopenias this time. So probably I would like to add on some oral drugs. If I not responded to L-Thrombopag and whatever drugs I have added, probably then I'll do a marrow to see what's happening in the marrow.
Sandeep?
Sir, I'll do a marrow because cytopenia has progressed. That is one. I'll also do a PET scan also. Because marrow we will do from one side, but at least we will see if there is any skeletal or any nodal activity anywhere else. So just to be doubly sure that we are not dealing with any chronic inflammation or infection. But marrow definitely will do because cytopenia has progressed.
So you have a person now who was sort of having fever for a month and then has become afebrile for a month. You are saying skeletal lesions due to tuberculosis?
Yeah, for tuberculosis.
For tuberculosis, okay. Deepak? Pujita? So most of them feel that we would go ahead with the bone marrow. So we actually did a repeat marrow, but like what the Girish had said, we also wanted to see what's happening to those granulomas, whether they are still persistent, whether they have disappeared. So the aspirate was dilute and paucicellular. The trephine showed a very markedly hypocellular marrow with markedly suppressed hematopoiesis, and we could not appreciate any granulomas on this biopsy. So whatever was there is not there now. We didn't do a PET because clinically, because he's improved, we did not think about finding TB elsewhere because he had been afebrile for almost a month without requiring anything. So this is the scenario after 2 months of ATT. So this is his marrow. Now in the meantime, what we did was, so we knew that the HLA with the sibling was not a match. We had initiated a mud search to see, because a young patient, whether there could be a mud donor. Unfortunately, we could get only a 8/10 match, so nothing else could be identified. So we had sent an NGS, but we could not find that heterozygous RTL mutation which was described outside. But we were worried about whether there still could be an inherited bone marrow failure. So is there any other test that you could do in terms of helping you to be 100% sure?
One more test, I mean, traditional chromosomal breakage studies I would send.
Traditional chromosomal breakage studies was negative.
Telomere length analysis by FISH analysis, if we have access to that.
So FlowFish is not available in the country,
Yes.
nowhere.
Academically, they are doing in certain centers in PGI.
PGI is doing, so PGI is doing by RQ-PCR, nobody does by say.
Yes, sir,
So
RQ-PCR, sorry.
PCR does. So we actually, because if it's an RTL mutation, we would expect very short telomeres, and so we went ahead and did telomere length. We also have qPCR to do that. We found that it is mildly short, which fits into an aplastic anemia. It is not less than the 10th percentile where you would think in terms of a telomere biology disorder. So with this too, we were reasonably sure that this is not an inherited bone marrow failure syndrome that this patient had. So we've got a 20-year-old on treatment for ATT, now has got severe aplastic anemia. So what would you want to do in terms of treatment? So you can plan for ATG since you've completed 2 months of ATT. ATT, continue and wait. Continue ATT, add on oral drugs like either L-Trombopag or Danazol. Consider, because there's not even a mud donor, consider a haploidentical transplant or any other suggestions.
So here, sir, actually the point will be to discuss with the family first, like what to do now, because it's like ATG also can be a problem because we don't know, like TB has cleared, we are saying. So ATG is one option and other is haplotransplant. Because he's young, so we can offer transplant also directly. So, and PNH is also negative, so giving direct ATG may have little lesser response. So either of the two, but given a choice, we can give ATG first because he's non-septic right now and clinically stable. So we can give a trial of ATG. If he don't respond, we can proceed with haplotransplant.
So, I mean, you know, most Indian patients, they will say, Dr. Saab, you decide.
Yeah.
So when you have a conversation with a patient, what would you tell them in terms of cure rates in India as compared to the risk? That is what you have to tell them about the risk-benefit ratio of either ATG or transplant.
Yeah.
So what would each of you, what would you tell in your practice, clinical
In
practice?
such situation, first, like for ATG, we can say around 70% success rates with the addition of L-Trombopag. So that's what we can tell them, around 70 to 80% success rate we can say. For haplotransplant, the data for aplastic anemia is better compared to the leukemias. Haplo we will code them around
in India?
50% success rate.
So you're saying 50% with the haplo. Okay, Girish, what about you?
Yeah, so even with ATG, I think since he has passed few times and he was requiring transfusion, probably it will not be as good as the newly diagnosed aplastic whom we give ATG. Probably the response rate will be little lesser. So I'll consider here 50 to 60% to ATG. And if the family is willing to accept the failure of ATG and then again willing to spend for haploidentical transplant, then need to discuss that thing. If they want absolutely curative treatment, then probably haploidentical transplant is the right choice because he is a young patient. And in that case, around 40% mortality, if acceptable to the family, I think should go ahead with that.
Radhika.
If this were my patient, which I have to manage in my kind of setting, probably I would like to go with, he has just completed the 2 months of induction therapy. He is right now in remission with respect to COX, but still he has an underlying some latent COX sitting in. I would give ATG upfront, sir, because I always have an option of BMT under some government schemes for me. So
okay,
I have a
sure.
second chance
So it
with me.
varies depending upon the circumstances that you're practicing in.
Sir, I would give a combination of ATG, L-Trombopag and cyclosporin upfront, and that itself can attain a remission, say 60 to 70% of patients. So I would wait on the transplant, and especially haplo in aplastic with the risk of GVHD, graft rejections and all, I wouldn't take an upfront risk at this point of time.
Pujita? So, okay. So when you use triple therapy, in your experience, what is the incidence of liver function abnormalities that you find in these patients because of the use of TPO agonists? And what would you anticipate is the risk of liver function abnormalities because you're now doing it on antituberculous therapy?
Definitely, the risk will be added in view of the antituberculous therapy on board. So very close monitoring. In a usual practice, it is around 10 to 15% of patients end up having some sort of liver damage which requires interruptions, drug interruptions.
In my setting, I see liver abnormalities, I mean, especially the direct bilirubin abnormalities in almost 40% or even more than 40% of the patients, but none of the patient requires, I mean, more than 90% of the patients, they don't require any kind of drug interruption because of the hepatic abnormalities.
Same here, sir. Usually we don't interrupt the therapy. So eltrombopag toxicity is there, but mild transaminitis can happen. But subsequently, if we reduce the dose for some time, it disappears. So usually it's not big problem. With ATT, I'm not sure what will happen.
Girish, in your
of the time. Otherwise, bilirubin, we don't see much abnormalities, and very less time we have to adjust the doses in a plastic.
Okay, so one of the challenges that we have in India is the fact that we do not have the routine ADGAM, where all the data is based upon. We only have exposure to the Bharat Serum vaccine, equine ATG, and the other ATGs. So if you decide to proceed with ATG, what would you use? You would use thymogam with cyclosporin. You would use the rabbit ATG because there is good data on that with cyclosporin. Or grapholon is available with cyclosporin, or you use the equine ATG in combination with cyclosporin, eltrombopag, danazol, or romiplostim. What would you use in?
Yeah, so I use ACE only, so equine ATG, cyclosporin, and eltrombopag. We have actually in Maharashtra a scheme where we get ATG nowadays in the Yojana itself.
Do you get the others also in the Yojana, the
yes,
cyclosporin, eltrombopag?
Yes.
Okay. Pujita?
Thymogam with cyclosporin and
Anybody experienced with grapholon or thymoglobulin? No. And any experience with using romiplostim instead of eltrombopag as a part of triple therapy?
Sir, for one patient when there was severe liver dysfunction baseline, we have tried with romiplostim, but we couldn't sustain. When the liver function has recovered, we again restarted the eltrombopag for that patient. So I can't mention the data, but we have used in some.
You've used it. Anybody else?
We have a couple of patients on romiplostim, sir. Actually, what happens is when we diagnose a patient with aplastic anemia, we initially put them on eltrombopag, cyclosporin, plus minus danazol as a bridging gap till we generate the funds. So if the patient has not responded on eltrombopag in the first 1 or 2 months till we took him up for an ATG, then with the ATG we try to incorporate romiplostim rather than eltrombopag. So we have maybe around 5 to 6 patients on romiplostim in place of
and do you see liver function abnormalities the same way you see with the...
Really, sir.
Not really.
More than 90% I don't need to interrupt the dosing, or I don't need to interrupt this TPO agonist, sir. I get away very smooth. I mean, they do occur, but with time they correct off.
Okay. So so this question. So if you decide to use ATG, what if you use triple therapy with the equine ATG that's available here? What would be the response rates that you would tell the patients? You would say 70% will respond, 80%. I mean, the data on ADGAM is now 85 to 90% if you use triple therapy. So, but what would we say? Or what do you say in your clinic?
I'll mention overall response rates to be around 60 to 70%, with the complete response rates ranging between 20 to 30%.
Same, sir.
We have published a data, sir, on 22 patients who have been treated with ACE regimen some 2 years back, and our response rates were 87%.
Okay, good.
With Bharat Serum.
With Bharat Serum, majority with Bharat Serum, maybe 1 or 2 on ADGAM.
So we'll play safe, sir, around 60% success rate.
Play it safe.
87% of the response rates.
So one of the questions always patients ask is, if I take this, will I be cured or will my disease come back? So what do you tell them in terms of relapse, the risk of clonal evolution, other problems that can occur in the long term?
So initially, when we discuss about the ATG option or transplant option, we tell them that the transplant is curative option. If patient becomes transplant becomes successful, the patient will get cured with this disease. For ATG, when we counsel, the response rates are in the range of 60 to 70%. But that response rate means the patient may become transfusion independent, or the patient may go into complete remission. If he goes in complete remission or some kind of remission we achieve, that may sustain maybe up to 3-4 years, and he may have a relapse in around 20 to 30% patients. So that explanation we give them in the beginning, that ATG is not a curative thing. He may need a repeat course of ATG later on if he relapses.
I counsel my patients is with a transplant and ATG, we have kind of equivalent responses between 85 to 90%. But with ATG therapy, there's a 40% chance that the patient may relapse back. So if we have a matched sibling donor, to go ahead for a transplant.
Any difference in terms of relapse rates that you would say? No. Okay. One last question before we go forward. So I'll put you in a spot. If the patient says, I have money only for one treatment, that's all I can do, choose. For this patient, what would you choose? ATG or transplant? We'll start with each of you.
It's a haplo.
Haplo.
Transplant, sir, 20 years.
Transplant.
He's too young.
One shot, transplant.
Haplo, sir.
Okay, all of them changed to haplo. We decided, this patient, we had a problem. They had very little money. We got some money together. We actually went on to giving triple therapy with romiplastim, because we had also a study where they could get romiplastim free. So we gave thymogam with cyclosporin and romiplastim. It's early, but he's had very good responses. So this is baseline, week 1. He required during his entire period 1 unit of blood, 1 unit of platelets. By week 9, he's actually gone into a complete remission. He's gone home to continue the romiplastim, and he'll come back. So he's responded now. He's gone into CR. Like you said, what will happen 5 years down the line? We do not know. So I would still say that a young patient, triple therapy is still something that we can use in a lot of patients. So we've come to the end. We're almost out of time. I'll stop by saying we invite all of you. We got our 3rd IBMFS meeting on the 11th and 12th of April in CMC. This is the contact email addresses. All those interested in aplastic anemia and MDS, please come and join us. We'll stop. Thank you all. Just a good hand to all the panelists. Thank you for all your talk.
Thank you very much, sir, for completing in the scheduled time. Now I request for the next session. That is anticoagulation in special situations. I invite Dr. Maitreyi Bhattacharya from Calcutta Medical College.
I would like to request Dr. Girish Badarke sir, Senior Hematologist, Nasik, to join for the as chairperson, and Dr. Nishad Dakate sir, Senior Hematologist, Nagpur, to join as a chairperson for this session.
Good evening. So first of all, I'm very happy to come here today because Dr. Ganesh was one of my students at the very beginning of my DM course in Calcutta Medical College. So all of my students now, they are grown up, has become very good hematologists. So it's a great pleasure for me to come here and see Ganesh doing all this thing. So I will wish all the best for Ganesh to be in future more success. So my topic is anticoagulation in special situation. So before going to anticoagulation, let's just recapitulate our MBBS days. This is the coagulation cascade, internal intrinsic pathway, and that one is the extrinsic pathway. And what are the anticoagulation we have? The oral anticoagulation, the oldest one is the warfarin, which acts on factor 2, 7, 9, and 2, 7, 9, and 10. And the later oral antibiotics which has come is direct factor 10 inhibitor. These are Epixaban, Rivaroxaban, Edoxaban, all these things, and direct thrombin inhibitor, Dabigatran. So these are the oral anticoagulant available with us. Regarding injectable form, heparin, unfractionated heparin, the oldest one for long time, it acts against factor 10 A and thrombin. Low molecular weight heparin acts against thrombin only. So these are the anticoagulant we have in our hand. This is the pharmacology of direct oral anticoagulant. You can see half-life is very short for direct anticoagulant. It's in hours, 10 hours, 12 hours, like that. And all these direct oral anticoagulants are excreted renally, except very low renal excretion is for Epixaban. There is a hepatic metabolism by CYP3A4 /5. So there are a lot of drug interaction with these oral antibiotic, and none of these are dialysable also except Dabigatran. So there are a lot of special situation. You know, now we have entered the era of precision medicine. So every patient is a personalized patient, and every patient has something special. So, but there are a lot of special situation. Within 20 minutes, I thought I'll be able to cover renal failure, advanced age, obese patients, pregnancy, and patient with cancer, because all these group of patients are more prone to get thrombosis. Regarding chronic kidney disease, this is a 67-year-old female patient with new onset atrial fibrillation. Her creatinine level is around 1.7 to 2.3, and she takes lot of other medicines also. So what will be the ideal anticoagulant for this female with renal failure? So renal failure patients are basically in hypercoagulable state. Here you can see there is increased procoagulant, factor 10A, 7A, EPC, and reduced anticoagulant. Thrombomodulin is reduced, antithrombin is excreted in nephrotic syndrome. There is decreased fibrinolysis also. So renal failure patients are more prone to get thrombosis. On the other hand, there is increased chance of bleeding also in renal failure patient. This is primarily mediated by platelet. You can see there is activation of the platelet by the alpha granules. There is a storage pool defect also. There is decreased binding of the platelet with von Willebrand factor. So because of this platelet defect, there is increased chance of bleeding also. So in renal failure patient, there is increased chance of both thrombosis and bleeding. So there are a lot of studies of this newer oral anticoagulant in renal failure patient, and all they have compared with warfarin, the oldest anticoagulant. What they found that these drugs are as effective as warfarin in preventing thrombosis, and side effects are less. Especially they have mentioned regarding Epixaban that Epixaban was found to have better efficacy and the same safety profile compared to warfarin in renal failure patient. So at what dose we can prescribe these oral drugs to the renal failure patient? You can see till the creatinine clearance is around 50, same dose can be continued. If it's less than 50 to 30, the dose is almost half. If it's 15 to 30, then also you can give at a lower dose. Less than 15, none of the oral anticoagulant can be prescribed except reduced dose of Epixaban. Some of the studies as mentioned, you can prescribe Rivaroxaban also, but only approved drug is Epixaban in a patient whose creatinine clearance is less than 15. So this patient, this is a atrial fibrillation patient. Here also you can see with renal failure, ideally you can consider a VKA, that is warfarin, or you can consider Epixaban. So in renal failure patient with very low creatinine clearance, these two drugs are only indicated. Same is with AF and venous thromboembolism in both these cases. Coming back to the case, this patient was started with DOAC and patient was okay with this drug. she was on Epixaban, but problem is that in future, if the renal failure progress, that the patient will enter into end-stage renal failure, patient will require dialysis also. Then what will we do? In that case, there is no clear-cut guideline that they said that this should be decided depending on the patient-center basis. You will have to decide what drug you can give to your patient with the end-stage renal failure. But the thing is that nowadays it has been found that you can give Epixaban even in end-stage renal failure also, and even in patient on dialysis also. These studies are coming up. Maybe in future this will be included in the guideline also. Coming to anticoagulation in elderly, another population group who are very much prone to thrombosis. This is 1 years old male with atrial fibrillation, slightly high BP, weight is 75 kg. So you can see these are the studies where the oral anticoagulant has been compared to warfarin in patients more than 75 years of age. And all these studies has found these are as effective as warfarin in preventive stroke, and it's a same bleeding risk. So if you can prescribe DOAC in your elderly patients also more than 75 years of age, this will be effective and safe also. But before prescribing this drug in your patient, DOAC in your patient, elderly patient, in atrial fibrillation especially, you will have to assess both the thrombotic risk and the bleeding risk. How you can assess the thrombotic risk? This is the CHA2DS2 VAX score, and the hash bleed score will be there to assess the bleeding risk. If this score is more than 2, then obviously not all patients will require anticoagulant if there is atrial fibrillation. If the score is more than 2, then the patient will require oral anticoagulation. But if the hash bleed score is more than 3, you will have to be very cautious, and you will have to monitor the patient carefully before giving any anticoagulant. So this is any older patient, you can give NOAC. This is preferred over VKA, but you will have to be very careful, and you will have to consider other features also, bleeding risk, renal impairment, and last but not the least of the adherence, whether the patient is willing to take the medicine twice daily. If not, then don't prescribe Epixaban. Though Epixaban is the best one, then it's better to go for Rivaroxaban. You can see previously most of the patients were getting VKA or aspirin-like drug. Only 17% used to get DOAC, and you can see in 2018 most of the patients, around 70%, are getting DOAC. So back to the case, this patient's risk score was 7. So there was a chance of ischemic stroke to 11.2% per year. There are other risk factors also. So in these patients, Epixaban was preferred with reduced dose, 2.5 milligram twice daily. Epixaban was given to this patient, and patient tolerated that well. Anticoagulation in obese patient. Obesity is now a great problem, not only in the Western countries, in India and in Asian countries also. Even the youngsters are very obese nowadays. So this is a 48 years old man who presented with DVT, but the problem is that weight was 140 kg. The renal function was okay, renal clearance was 90. So what will be the anticoagulant of choice for this patient? Obese patients are more prone to great thrombosis. Because of obesity, there is a chronic inflammation which activates the coagulation factor and leads to increased thrombosis. So can we go for VKA for a patient who is very obese, more than 100 kg? Warfarin can be given for thrombosis? Answer is no, because this warfarin is a lipophilic drug. So it's distributed to the fat, and the actual amount in the plasma concentration will be low, and it will take more time to reach the target INR, and more dose will be required. It may not be with 5 milligrams, 8 milligram, the target INR you will be able to achieve. So warfarin should not be the drug of choice in obese patient. Regarding DOAC, there was very confusion whether we can go for DOAC, and all the guideline initially said you should not prescribe DOAC for a patient who is more than 120 kg. Then people started studying the pharmacokinetic of DOAC in obese patient, and they found it was as normal as in a normal person. There is no difference in pharmacokinetic. Then also there was question, this is a pharmacokinetic study, whether it can be translated into clinical medicine or not. Then there are a lot of studies. One of the important studies, Aristotle study, where 5.4% patients were more than 120 kg. And they found that these DOAC are effective and less toxic in patient of obesity also. So these are the studies which have shown that DOAC, you can see the efficacy same as with VKA and safety also same as with VKA. So you can prescribe DOAC in a obese patient also. So he was started a standard dose of rivaroxaban. So the recommended summary is that you can give DOAC to a obese patient, but DOAC cannot be given to a patient who will undergo a bariatric surgery. It's contraindicated to any patient who will undergo bariatric surgery because it's not studied whether the absorption will be okay or not. And standard VTE prevention DOAC can be given and it's okay. And it doesn't require any monitoring of TNA level or DOAC level, even in obese patient also. Though I think all of us read in our younger days that TNA level should be monitored, but it does, guidelines said that it does not require. Anticoagulation in cancer. This is a 62-year-old man who presented to the clinic with palpitation. He was diagnosed as atrial fibrillation. Primarily, he is a case of small cell carcinoma of the lung, received gemcitabine and other drugs. So what we will give to this patient? Low molecular weight heparin, warfarin, DOAC. Problem with LMW is that you will have to give injection, that are other drugs are oral drug. So for cancer patient, when we will decide about anticoagulant, we'll have to think of these two. One is increased bleeding risk. So again, Hashblade score you'll have to do here. Thrombocytopenia, if platelet count is less than 50,000, you cannot go for any anticoagulant in the cancer patient. If there is GI malignancy, if there is CNS metastasis, the chance of bleeding will be high, and you will have to take history of major bleeding also, renal failure also. Last and most important is drug interaction. Patient will get chemotherapy and other lot of supportive drugs also. So drug interaction with the DOAC with warfarin is to be decided before prescribing anticoagulant for cancer patient. It has been found that prevention of venous thromboembolism and even mortality is far better with DOAC. The lowest line is the DOAC one. The yellow and the green are the LMWH and blue is the LMWH and warfarin. You can see the incidence of venous thromboembolism and mortality is less with DOAC in cancer patient. So in a cancer patient, when we will think of giving anticoagulant, you will have to follow this algorithm. So does the patient have high risk of bleeding? Whether it's a GI cancer, CNS involvement, drug interaction. On the left-hand side, you should see that body weight should be less. There should be significant gastrointestinal absorption also. Apixaban should not be given, LMWH should be preferred if there is chance of bleeding and if it's a GI malignancy. In other cases, you can go for a DOAC. It should be continued till the malignancy is in remission throughout the period of treatment. So direct oral anticoagulant versus vitamin K, this is one meta-analysis where it has shown that DOACs are associated with significant reduction in rate of thromboembolic events and major bleeding in cancer patient with atrial fibrillation. So DOAC should be the drug of choice. Anticoagulation in pregnancy. So what anticoagulation can be given in LMWH and unfractionated heparin? In all the previous cases, I have shown DOAC should be the drug of choice, but here DOAC is contraindicated. VKA is also contraindicated in pregnancy. So when this patient was started LMWH, during labor, whether you will stop LMWH or not, it should be stopped only 24 hours before labor, and the labor should be as the obstetric indication. Whatever is the indication, that to be followed. But LMWH should be followed in the postpartum period. What you can do that, you should shift it to VKA or warfarin. DOAC or LMWH, both these cannot be given in a breastfeeding mother. So in a lactating mother, these should not be given. In a lactating mother, warfarin should be given. Warfarin is secreted in breast milk in very small amount. So these are the thing, how will you monitor? These are the antidotes available for oral anticoagulant. So the take home is that during the first few decades, DOAC is coming up over VKA or LMWH. However, it's not included in all the RCTs, all the randomized trials. So especially in special situation like renal failure, it's not included. So we don't know there is no clear-cut guideline. But it has been found that it's safe in renal failure, it's safe in obese person, and it's safe in elderly persons also to prevent thromboembolic manifestations also, and chance of bleeding is less also. However, DOAC is not recommended in pregnancy, and in cancer patient you will have to decide depending on the patient clinical and laboratory parameter whether you will choose for LMWH or DOAC. So there is still a knowledge gap when you are deciding about anticoagulant in a special group of patient. So more studies are required. And I think in future, maybe we'll be having guideline so that it will be easier for us to decide regarding anticoagulation in this special group of patients. Thank you.
So thank you very much, madam. In case there are any questions, we can take one questions or we'll proceed for the next session. Yeah. So I guess there are
there was a trial where low molecular heparin was used along with chemotherapy, and I was part of the trial. There is we use low molecular heparin for surgery, for cancer surgeries. Similar way, the trial was to see whether any chemotherapy, patients on chemotherapy with low molecular heparin would be ideal to give or not.
Patient has other indication, thrombosis or atrial fibrillation, then only you are deciding for LMWH in a cancer
Because
patient.
most of the cancer patients,
yeah, you can go for LMWH. Previously, only LMWH was indicated. Now you can change it because LMWH requires an injection also. But one thing they said for a leukemia patient, you should not give apixaban when you are choosing DOAC. You should choose other drugs. But LMWH is safe in cancer patients who are receiving chemotherapy. I showed you that you will have to assess the bleeding risk and other things also before deciding for LMWH.
I was part of the trial, madam.
Thank you very much, madam. So I'll call Dr. Suparno Chakrabarti. Sir is director of Dharpashila NH Hospital at Delhi. Sir will be talking on future of BMT in 2025.
Good evening, everyone. I thank Dr. Ganesh. I don't think he's here for inviting me for this session, and the chairpersons. I've been asked to speak about future of HCT. I mean, I prefer calling it HCT, and I'll tell you the reason why. I don't call it HSCT. I don't call it BMT. I call it HCT, hematopoietic cell transplantation. So let's address the elephant in the room, as it is called, that why are we even questioning the future of HCT? The reason is this, that it suddenly turned out that with the advent of CAR-T and with the massive increase of the use of CAR-T in the Western world, that transplant of all forms are becoming irrelevant. So you see over here that the major use of CAR-T has been commercial, and it has been used in lymphomas, with myelomas coming up very rapidly, and leukemias, ALLs being somewhat stagnant. So around 3 or 4 years back, there were 2 studies which took place simultaneously, comparing 2 CAR-Ts, TISA-cell and axi-cell to SOC, standard of care in relapsed lymphoma, aggressive B-cell lymphoma as it is called. TISA did not show superiority over SOC, both having survivals in the range of 10 to 20%. When it came to axi-cell, it was shown that the progression-free survival, which you see in the lower panel, was significantly superior to the standard of care, whereas the overall survival was sort of very similar. So, am I audible? Okay. So when first saw this trial, I was surprised, and you know the reason for my surprise was this, that when these 359 patients were randomized and compared, out of 178 patients allocated to the axi-cell group, 170 received the intended treatment, whereas in the SOC group, only 62 received autograft. And believe me, that based on this particular study, the entire world turned its head around and said that autograft does not have a place in relapsed lymphoma. So the treatment of choice is CAR-T for relapsed lymphoma, B-cell lymphoma. So let's see what actually the data showed from outside these trials. So I'll show you 2 studies, one from Porter's group, where they showed that autologous was superior to CAR-T, irrespective of whether it was early relapse, whether it was chemosensitive relapse, whether it had a metabolic CR or not. And between axi and TISA, which was TISA was shown to be inferior to axi, there was no difference. And similarly, in a CIBMTR registry-based study, it was shown that it was in a good number of patients that if the patient is in CR post-relapse, auto is superior to CAR-T. Now coming to the next thing, that patients who have failed 2 lines of therapy, it was shown that CAR-T of any form is superior to the alternate treatments. Now what are the alternate treatments? A whole host of chemo-based treatment. And when you look at it carefully, you will see that allogenic transplantation was offered to only 6% of these patients. So based on our data, now why I'm saying this, there are a lot of young guys over here who just read the top line, that this is better than this, and so the white world has said, so take it with your head down. When you are using something which has been used in only 6% of patients, how can you refute this treatment based on this data? This question is never asked. And what is the result? I mean, this is just one of the many studies I just put it up over here, that what is the result of allograft in lymphoma, relapsed refractory lymphoma? You have a plateau. You have a plateau of anywhere between 30 and 40% for progression-free survival at 5-10 years. This is something that you don't achieve with CAR-T, not as of now, not as of today. So the next one I'll quickly go through is myeloma. Now, I'm not saying CAR-T is not a good therapy. Don't be mistaken. I'm not saying it's not a good therapy. It's a very good therapy to produce a response, but it does not produce a sustained response. So in this myeloma groups also, anti-BCMA CARs, you will see that a lot of early response, but it tails off. There is no plateau. Whereas something that, those people who have grown up in the Mayo Clinic era, where you use 10 lines of therapy in 10 years to keep a myeloma patient alive. I have been in an era where reduced intensity transplantation started in 1995, and we started using it for myeloma. Before that, allografting in myeloma was a no-no because the regimen-related toxicity was in excess of 50%. And this is one of those data that I have been a part of. This was a huge compiled data which shows auto versus auto-allo. That was a study that was done at that time with allo showing maintained progression-free survival at 15 to 20 years of 20% across the board. And if you look at standard risk patients and high risk patients, it's anywhere between 20 and 40%. And you people are growing up with the idea that you have a myeloma, you give for the 3-line or 4-line drug treatment, and you go for an autograft, you relapse after autograft, and then you give X, then you give Y, then you give Z, and keep on giving it. What has happened is you have taken a curative treatment out of the picture. Now, one of the reasons, not the only reason, one of the reasons is obviously the whole pharmaceutical industry taking over the science. But the other problem that is perceived by all is the toxicity of allogenic transplantation. And the main two reasons for treatment failure following allogenic transplantation are either non-relapse mortality or relapse. So I would be focusing on two things in my next few slides is what have we done to reduce graft versus host disease while maintaining its efficacy in terms of anti-leukemia or anti-cancer effect. I'm not talking of non-malignant in this talk at all. So why do I call it hematopoietic cell transplantation? So when we give a graft, how many of you actually look at what we are giving apart from CD34? Mostly no. We are giving an X number of CD34, but in the best case situation, what is the percentage of CD34 you give? It's less than 1% or at max 1%. So 99% of cells you're giving and you are not aware of. So it's a mix of good, bad, and ugly, and you know, it's a bit like Hanumanji carrying the whole mountain to find the Mrita Sanjeevani that we are giving to the patient. Sometimes it is good and sometimes it's not so good, and we have no control over it. So to address this problem, the Perugia group actually started what is called a graft manipulation. And they started with CD34 selection, where just CD34 cells were taken and the CD3 cells accounted for less than 1 × 10⁴ cells per kilogram. But that was associated with a huge amount of non-relapse mortality due to infections. So subsequently came what we use nowadays as TCR alpha beta depletion, with gamma delta and NK cells being in the graft with the CD34 cells. Although it resulted in much better outcome in terms of infection-related mortality, but what was a problem was relapse. That when you have a patient not in CR or high MRD positive, this would result in invariable relapse. So what was the way forward with graft manipulation, which I still think is the most scientific way of going forward. The Perugia group again, Massimo Martelli, Franco Aversa, Andrea Velarde, they formulated something beautiful, something elegant. What we know of graft versus host disease, we know that the alloreactive T cells and the regulatory T cells, these are the two which are going to decide mostly. These are the two which are going to decide amongst the T cells which is going to win over. It's good for leukemia relapse, bad for infection, bad for GVHD, good for relapse, and so on and so forth. What this group did was they isolated TREGs which are marked by CD4 and CD25 positivity and FOXP3 expression. So tregs were isolated and given on day -4, 72 hours before giving the graft. And unlike giving CD34 selected graft only, they gave CD34 selected graft with the conventional T cells of 1 million. So 1 million tregs and 1 million conventional T cells, which is a mixture of CD4 and CD8 along with CD34 cells. And what they showed with that was that there was a marked reduction in relapse. The initial apprehension was that with giving tregs before, you will have more relapse. You might not get GVHD, but why were they giving this? They were giving this to prevent infection-related or non-relapse mortality. So it addressed both the problems, and subsequently in a more recent study, the first one was a decade back, 15 years back, and now in a more recent variation, what they did was in elderly patients, they're using age-guided conditioning with the same protocol with the results as you can see over here, very low GVHD and excellent disease-free survival. So that should be the end of it, because that's how allograft ends. So either if you have a pharmaceutical backer, industry backing you, you go forward, otherwise you don't. So Orca Bio took over this, and they have produced two products, Orca T and Orca Q. And both of them, the first one is a direct replication of the Perugia protocol, where they're shown in matched related and unrelated patients that the results, as you can see over here, are excellent, and the same in elderly with Orca T, and in Orca Q in haplotransplant, which they have not disclosed the exact protocol, but it's very similar, is somewhere in the range of 82% 1-year survival. So this, I would say, is one of the major advances in the field of allogenic transplantation. The problem being technology, technology, and technology. Like car is expensive, this is also expensive, very expensive. But actually the game changer in allogenic transplantation has been PTCY, as you all know. So when a toddler goes on to do a haplotransplant, because giving PTCY, you know that something or the other will happen, which might be good at the end of the day. But what PTCY has actually done is it has changed the scenario of unrelated donor transplantation as well, because in the last 5 years, number of trials have taken place where PTCY has been used with MUDs as well as 7 out of 8 unrelated donors with equivalent results. And as you can see over here, that it's a very classic diagram what you see over here, that patients who had CNI-based treatment, they had more GVHD, less relapse, whereas those who had PTCY-based treatment had more relapse and less GVHD. So ultimately it becomes a balancing act. Now in India as well, haplotransplants picked up, MUD transplants picked up, and as I said, largely because of PTCY. Dr. Biju George took out a very detailed and elegant study for the 10 years data, and what they showed was in haplotransplant with PTCY, because of very early attrition of nearly 45% at 100 days, which is constant over 10 years, the results were very suboptimal. And when we analyzed our data, because we started our haplo program in 2010 in Apollo Hospital, Kolkata, where we found that there were high mortality. In the case of Dr. Biju, it was mostly infection. In our case, we experienced high alloreactivity in children. So this led us to question that whether we can get rid of the T cell effect, alloreactivity, without killing them. Because as you saw, that killing the T cells would increase the infection-related mortality and increase relapse. So I think, I have spoken a lot on that front, so I will quickly summarize what we did was basically introduce co-stimulation blockade as a method of reducing GVHD in haploidentical transplants with CTLA-4 Ig or abatacept, which is known as Orencia. We started this in 2015, but much before that, in 1995, the Gribben-Guinan group had shown that if you block co-stimulation through the B7-CD28 pathway, you can actually induce what is called a transplantation tolerance. And what we did was, along with abatacept, we used PTCY. So a combination of abatacept and PTCY, along with in non-malignant diseases, the use of sirolimus to increase the production of TREGs post-transplant, and cyclosporin in malignant diseases for a short duration. So I hear a few of the young doctors talking about CAST protocol in US, which is a direct replica of what we have been using for 10 years, and they have been taking the name, using it without acknowledging our data and our studies. So that's the nature of Western plagiarism, which we don't realize sitting over here. So we presented our first data of Abascis protocol in 2017, which in the 10 patients with aplastic anemia compared to historical controls did extremely good. And recently we published 40 patients of non-malignant disorders with very low acute and chronic graft versus host disease and excellent survival. At the same time, around the same time when we were doing these studies, our results were being published. Leslie Keane from US used abatacept with CNI methotrexate in unrelated donor transplantation with very good results, and abatacept is FDA approved for unrelated donor transplants in 2023 onwards for in the US. And the final part I will say very quickly is reducing GVHD alone does not solve the problem in leukemia or lymphoma. The problem is how we prevent relapse. Because you might not get any GVHD, but you get 50% relapse, your end game goes blunt. So while using abatacept, what we realized was that there are some data in the literature that maybe natural killer cells are not resistant to abatacept, and there was one study which showed that abatacept might actually enhance NK cell cytotoxicity against tumors. So based on these findings and some of our own lab findings, we introduced what is called a abata DLI, where we primed the DLI with abatacept and introduced as early as day +7, giving a DLI in haplotransplantation as early as day +7, day +21 and day +35. And the initial results were very gratifying in the first 30 patients with 80% overall survival and very low GVHD and NRM. What was more important and more relevant was the fact that we showed that there was proliferation of mature NK cells with increased expression of CD86 when patients did not relapse. Or in other words, this abata DLI protocol was enhancing abata NK cell proliferation and maybe NK cell cytotoxicity, and inducing this reduction in relapse, and at the same time keeping the GVHD at a low rate as well. So we are really talking over here is separation of GVH and GVL through a single maneuver, which is not technologically challenging. So in 2021, 2020, we published this data on 75 patients who received abata DLI versus 50 patients who received just DLI in our protocol. And we showed that if patient, not only was abata DLI superior, you can refer to this publication in Bone Marrow Transplant Journal, what we showed that if the NK cells from the donor had certain characteristics, And if the NK cell recovery had certain characteristics, which is basically they are mature NK cells and the donor was of a B haplotype, the results were as good as 90% disease-free survival. This led us to explore more on the type of NK cells which were recovering, and we found something called adaptive NK cells, which were being talked about for a few years before by Jeffrey Miller's group. And what we found that these NK cells which express NKG2C receptor have very strong anti-tumor effect, and like T cells, they're sustained. NK cells otherwise got a life of 15 days. But in this case, they survive for years together, as we show over here, that they were sustained for 3 years after transplant they were seen. And in patients who relapsed, this ANK population was very low. So in other words, ANK cells sort of dictated the outcome in terms of relapse. And why some patients had low NK cells and some didn't, we looked at the immunogenetics of it and found that the KLRC2 gene, which encodes for the NKG2C receptor, is deleted in a part of the population, and if that is deleted, NKG2C population can be low. And again, this is in 136 patients we did the analysis, where we found that donors had high adaptive NK cells and KLRC2 was not deleted but wild type. The survival was 96.8%. So I'm not getting into details of the rest of the things, and as I said, there is an ongoing work on this, how abatacept enhances an NK cell toxicity, which is a doctoral work of Dr. Sarita Jaiswal, which we would talk about in some other forum some other day. But those who are interested to know about this further, we have written a review article on this a couple of years back, which covers most of these things in Frontiers in Hematology. And finally, if allogenic transplantation has to remain relevant, it has to fight against the odds with less than 10% severe complications and more than 75% disease-free survival is something we have to achieve. And if autologous transplant has to remain relevant, it has to move out of the sphere of being high-dose chemotherapy with stem cell rescue to be an immunologically relevant form of transplantation. And what I summarized over here, I mean, what I said all the while was that we did not, or we need not need to engineer everything around us. Nature has engineered a lot of things for us. So the answers lie within the nature. We have to be in the right quest to find it. Thank you so much.
So, in this series published, was there cases of high risk AML like TP53 mutation, and how was the response with this?
All these patients, what I showed you in all these studies, none of them were in CR. They were high MRD positive or they were not in remission. They had blasts more than 5%. And the distribution amongst myeloid and lymphoid was 60-40. 60% were myeloid. They were in all forms and shapes, TP53, FLT3, everything. The results were better with AML than ALL. So we have done a final analysis, which I could not show over here on our AML versus ALL. In AML, the relapse risk is around 10%. In ALL, the relapse risk is 26 to 28%. So in AML, this protocol works wonders. ALL, yes, but relapse risk is a worry.
Thank you, sir.
And a lot of new ideas. So whether these abatacept and in haplotransplant, it is applicable in leukemic populations or it is applicable in benign disease also?
See, we have showed the data in non-malignant disease first. It started in non-malignant disease. We have shown that there is almost 88% GVHD and event-free survival in patients with aplastic anemia, thalassemia, and immunodeficiencies. So it's a wonderful, ABASIS protocol is wonderful for non-malignant diseases, largely, provided we get the immunogenetics right. So we have looked at the immunogenetics in non-malignants as well. And the same principles which hold good for malignant holds good here also. I could not go into the details. But yes, I mean, it's not a blind protocol that you cannot say that it will be same for everyone. So that's why we looked into why it works for some and not for others. And we have 4 stratifications. Again, I'll show sometime later, or Dr. Sarita will show it, that there are 4 group of patients when we are using this protocol. And there is one group which has 90% survival, the other has 20%. So it's identifying who to do what. That's where it matters.
Thank you, sir.
Thank you very much, sir. Next session is a panel discussion on the rational use of blood products in physician's practice, and I'll invite Dr. Saurabh Bhave to moderate this session and invite his panelists.
Good evening all. So this is the rational use of blood products in clinical practice, and my panelists are Dr. Vivek, transfusion medicine specialist. Dr. Tushti, is she around? Tushti is here. So Tushti is a hematologist. So I think the transfusion hematologists sit on one side because they are the experts, and the physicians and the pediatricians on one side, and I'll just be the link between these two, not do anything more than that. So Vivek, you can sit on that side. Dr. Dayanand, hematologist. Dr. Pujita, hematologist, right Pujita? Dr. Venugopal. Venugopal is around? Not around. Dr. Isha, she's also, I think so you can sit on this side. Isha is also a transfusion medicine specialist, right? Dr. Suresh. Suresh is a pediatric intensivist, right, Suresh? Dr. K.V. Nageshwar Rao is a surgeon, anesthetist, right? Dr. Chinna Babu, he's a surgeon, right? So you sit on this side, both of you, right? So I think we are already late, we'll not go into the details of this blood. So basic is why to transfuse, what to transfuse, how much and how to transfuse. These are the basic 4 questions in transfusion of blood and blood products. So misconceptions. So I think Vivek and Isha and the team can elaborate on whole blood. Is whole blood routinely used nowadays? If yes, what are the indications? You have to be very crisp and sharp. We have to finish within 25 minutes sharp. Yes, no, that's how you answer.
Thank you, sir. Coming to whole blood, right now after the advent of component therapy, we are not recommending whole blood to use. Only in emergency, when there is no component therapy available, in that setting, an emergency war combat situations, only we are using whole blood.
Okay. So Isha, fresh blood. Is blood fresh? And whom will you, patient ask for a fresh blood. Do you accept his demand? You said this is all rubbish. There is nothing fresh in blood.
So regarding fresh blood, there are 2 definitions currently. Fresh blood, fresh PRBC is defined as between 5 to 7 days. There's something called fresh whole blood, which is up to 24 hours at room temperature they can use. But what happens with fresh whole blood is the platelets don't function anymore if you just keep it at 2 to 8 degrees. And also plasma loses its coagulation factors also. So fresh whole blood, it's only recommended in trauma cases, in war situation like Vivek had told. fresh PRBC for neonatal transfusion, especially intrauterine transfusion, preterm neonatal transfusions, and also for exchange transfusion also we are recommending fresh blood.
Right. Tushti, thalassemics ask for fresh blood. Have you encountered?
Yes, they do, but we do not recommend the use of fresh
Don't
blood.
accept the demand. Okay, okay. Empiric transfusions for nutrition anemia, pre-surgical wound healing and enhancement of well-being. Do you recommend? Anybody of you can answer.
No, not really.
Not really. Right. So we move on. So it's a elective cholecystectomy is being planned. Hemoglobin on pre-op evaluation is 8 grams. No comorbidities. The surgeon, OT, you will not get OT, huh? And anesthesia will not give fitness. So what will you do, Chinnababu? You will transfuse, and anesthesia will you give the fitness at 8 grams?
Well, to be very precise. Yeah, to be very precise, I think 8 grams with no comorbidities, elective surgery, I do not transfuse.
You have to tell the truth and only truth.
Yeah.
Not book.
If it is a chronic.
Not book, only truth. What
Now-
do you
now
do actually?
I need to ask
What
Rao.
PRBC? Jao, leke jao. Only
No,
truth.
in,
Yeah, that's
in,
what
in
the
practice, actually
here
below
for.
10, we routinely give, but as per the guidelines and what standards for chronic anemia with 8, and I don't think it is required.
Okay, so anesthesiologist, will you give an fitness or you will say no, meet hematologist and improve the HB? It's elective procedure, no, it's not emergency. We can wait for 2 days, 10 days, 15 days. What will you suggest?
Yeah, because it's an elective procedure, and actually 8 grams hemoglobin is not quite bad actually for the procedure, and it's cholecystectomy. It's a minor
Ageshwar,
surgery.
Will you make him fit or make him
Yeah, we'll
unfit?
give fitness for the surgery, sir. Like
Will make him fit.
Yeah, yeah,
Right?
yeah.
Chinna Babu, are you accepting the fitness and operating him?
Very much.
Okay, game done. Pujita, are they right or wrong?
Yes, sir.
They are right?
They are right.
Okay. Anybody has any other opinion? No. Right. So now this is something depend upon laparoscopic or open? Will your opinion change? Some questions are not here. Everything is not on board. So if it's a laparoscopic, will your opinion change? Both surgeons and anesthesiologists.
Yeah, if it's an open surgery, I consider reserving the blood. I don't give it pre-operative transfusion. I don't ask for it.
You will
Intraoperatively, I
reserve.
may
How
require
many units you will ask to reserve? 1, 2, 3?
2 units of blood, depending upon the type of gallbladder that is.
Okay. Depending upon the confidence of the surgeon. Clean, neat, plain, bloodless surgery is most important. So surgeon skills are very, very important in such situations if you want to use rationale. Otherwise, transfuse and leave the matter to the God. Okay, thanks everybody. So essentially 8 grams may not be useful, but in some situations where getting bloods may be difficult in remote areas, I agree. Reserve, you may transfuse. There is plus minus always, but more or less in big centers they may not, but I am not. Right. So Suresh, irradiated blood products, do you ask for? And please tell in
Not
short
as
what
a
is
routine.
irradiated.
We do not ask as a routine, but we have our fetal medicine department. Sometimes when we have to give intrauterine transfusions, of course, yes, we do. And again, in NICU, we do ask for irradiated, not as a routine.
And do you routinely get it?
We do.
So the irradiated in the blood bank or in the radiation oncology department?
It's irradiated in the blood bank.
Blood bank itself. So it's under your control.
No, it's under transfusion medicine specialist control.
Transfusion medicine.
Transfusion medicine
Right.
specialist is closer to us.
And they radiate at night also, 9 o'clock, 10 o'clock? Or no?
No, not really.
Elective radiation.
Elective.
They ask to give slots and accordingly they radiate, right?
Yes.
Okay. So Pujita, do you feel any challenges in getting irradiated blood in wherever you practice?
Yes, sir. I practice at a center where I have to send the blood to another center for the irradiation. I work in 2 branches. One branch has the irradiation at the center itself, but another branch I have to send. It takes almost 45 minutes. I don't see the point after 45 minutes if I irradiate and again transfuse. What's the point of irradiating that? It loses its effectiveness, but still we are doing that. That's what is
Some
available.
compromise. Tushti?
Sir, We have our center in which the irradiation is done, but again, as you said, it's a slot-based irradiation.
Right.
So basically what we do is we plan the transfusions beforehand, because mostly what we do is during the BMT or maybe a patient with on ATG, so he'll be getting a platelet or something. So we plan that he's going to get this unit irradiated and then transfuse it.
Right.
So it's usually planned.
So Vivek and team, is leukodepletion at source maybe an okay alternative to irradiation, as irradiation is not available? Is it okay, or the question is totally wrong?
Yeah, but leukoreduction has its own reasons to do, and these two things are different. We are doing irradiation to prevent GVHD. So leukoreduction to reduce CMV and HTLV infections, leukotropic infections, and to reduce the reactions, especially FNHDR. So it's not completely reasonable to just do leukoreduction. We should go for irradiation.
Right. Dr. Rao, what is your policies for massive transfusion? Do you deal with polytrauma and all? So how do you manage this?
So whenever some polytrauma comes, actually we look for the initial hemoglobin of the patient. Like if the patient hemoglobin is quite less, around 7 or 6, then we will start for a transfusion immediately straight away before going for the surgery. And during the surgery, we will ask for at least 3 to 4 units of packed cells with along with 4 to 6 FOPs and 1 SDP if possible.
If possible.
Yeah, yeah.
Right, right.
So we'll transfuse it as a 1:1 ratio. Like we'll
Right. So you have to maintain the temperature and the pH,
yeah,
along with the parameters around 150 to 200 fibrinogen, INR around 1.5, platelets around 50. Vivek, what is your expert comment on? Do you get on call?
Yes, especially in trauma and also from the surgical units. When massive transfusion, we have a policy to do 1:1 ratio of releasing the products.
Right. So, Dayanand, comment? Yeah. Is hematologist involved in this massive transfusion, or the surgeons and the blood bank can very well take care of it?
See, massive transfusion basically purpose is to correct the basic parameters, 3 parameters, PRBCs, then plasma and basic proteins or clotting factors. So obviously it should be done judiciously, and of course 1:1, that is the ideal ratio.
Right, sure. So Tushti, do you insist for a leukodepleted blood at source, and if for which patient?
If possible, mostly for the thalassemia patients, because they'll be getting multiple transfusions. And however, it's not available in our center, so it's currently we do not do leukodepletion at source. We get the filters.
Right. Dayanand?
Leukodepleted, basically that is indicated for multiple transfusion, malignant cases, and in immunocompromise also.
Right.
Because the basic purpose is to prevent the infection and allow immunization, and obviously the risk of anaphylactic reactions.
Right. So Isha, what is the best blood you can give to a patient? Money doesn't matter. So best, everything done, whatever guidelines. So what is the best, and then what is the cost?
Okay, so this is leuko-reduced PRBC is the best product, sir.
So it
because
is at source or at bedside?
source. We are doing pre-storage leukodepletion.
So leukodepletion at source,
Yes.
first, second.
And for platelets also SDP. So we're going component wise. For platelets
Right.
it's SDP. And if you also want to make the SDP more safer, you can add something called platelet additive solution. That's what we are doing here. So it will
Right.
deplete the plasma, so patient won't have, you can transfuse across group. You need not search for a group specific donor for SDP. So FFP again is group specific. Cryoprecipitate there is across all groups we can give. So component wise,
And do
these are
you
the best
keep
products.
radiated blood as a routine?
Irradiated blood, we don't keep it in stock, sir. We
But
do
you-
it on demand.
Okay, and so what can be the cost of all these things? So
So
one PRBC, if you leukodeplete at source, if you irradiate and do everything, whatever AABB or whatever guidelines, what should be the cost of 1 unit from your side? Other the lab and the ward will do whatever they want.
Right now we are charging 4,000, sir.
Everything inclusive? is
Everything
1,400.
included. Yeah.
Expensive affairs, not easy. Plus transfusion charge, bed charge, nursing charge. So that's why you have to be really rational in using such a product. 8,000 rupees, 10,000 rupees for 2 units. Are we really justifying that amount to transfuse? That's why this talk is there. So 56-year-old lady, liver cirrhosis, massive hematemesis, needs a transfusion. Blood group is A negative, difficult in getting. Chinna Babu says, nahi, negative ही चाहिए. रात के 9 बज चुके हैं. Huh? So they call a hematologist. So Pujita, what is your plan? Difficult in getting a negative, and she needs 2, 3, 4 units.
So if the patient has not been transfused previously, there is very less chance of getting alloimmunization here. So I would suggest if there is definitely a deficiency of A negative, we can go ahead with the positive.
Positive unit, right. Is the surgeon agreeing for that? You have to agree. Tushti, any other opinion? Or you will insist on negative blood?
No, sir. If the patient is, as she said, Dr. Pujita said, if she has not received another transfusion, or maybe history of pregnancy, I'll take the obstetric history also, whether she has been receiving the product, the Rh positive immunization, whether she has received or not. So if there is no chance of alloimmunization in a life-saving scenario, I can go with the positive blood also.
So as far as possible, negative unit transfused for negative. If not, and the patient is not supposed to get pregnant, 56 will not become pregnant most likely. So go ahead with the positive blood, otherwise she will die looking for a negative blood. Agreed. So if this patient was a child and not a lady, Suresh.
We would still try and get negative, but if it is a life-saving measure and if it's not available, we would compromise and then go ahead with positive.
Hematologist, same opinion? Same opinion. Vivek?
Emergency situation then.
You can. Okay, sure. So Venugopal is here? He is not here, so we'll skip the question then. So patient is planned for surgery, pre-operative 1.5 INR, not bleeding. Anesthetist orders FFP. Will you overrule or accept? Tushti, Dayanand, Pujita, anybody can answer.
No, sir. If
No,
the patient is not bleeding and just the INR, we don't treat the INR basically. Because INR only measures the procoagulants. We don't measure the anticoagulants also. So that isn't a proper parameter actually to assess the
Normally
coagulability.
only PT is done pre-op. APTT is not even asked. Yeah. And before even the PT results come, the patient is driven into the OT and the operation has been done. Right? So don't treat unless you have a good history, then only you transfer transfusion. FAPs are not good at all. I think so. I think we have finished. What is the time? Chairpersons? Not too much. Yeah, this is general, so need not be. So any comment, Vivek, about a rational use of blood, when to ask, what not to ask? As far as possible, use IV iron, oral iron, EPOs.
Yes, we are propagating patient blood management to treat the transfusion is not a first line resort, it's a last line thing. To treat the patients for anemia first, correct iron with iron, and intraoperative salvage should be done, surgeons should be doing, using cell salvage and acute normovolumic hemodilutions. So there are a lot of things that we can conserve. So that is the thing we are also propagating, to save the blood and use it whenever it is needed. And yeah.
Okay. Thanks. Any comment from the experts and the panelists?
So one thing I was trying to say that for platelets, many a times with 25,000, 22,000 even, we get calls, and sometimes the patient has already been given the platelets. So even unnecessary platelets are very dangerous. So that is something that everybody has to understand, that just because a patient has a platelet count of 25,000, and particularly if it is an ITP, you don't need a platelet transfusion unless there is a bleeding.
Sure.
So that's one point.
Sure. I thank the panelist. Any question from the audience to the panelist? Anything? Nothing. She has a question. Can you pass on the mic?
Risk of infections with PAS added platelets, SDP. What is the risk of infections? We have seen bad reactions and risk of infections with PAS added SDP.
Ma'am, when we do platelet additive solution, when we add it to the SDP product, we use a completely closed system. There are two methods of adding platelet additive solution. You can do it in an open system, you can do it in a closed system. So there is a kit itself. You have something called adding pass option. So the machine itself, we have an automated platelet collection machine So machine itself will add it to the bag. So we're not touching or opening the bag anyway. There is another method where you can calculate the volume of platelet additive solution needed. You can remove the plasma, centrifuge the bag, remove the plasma, add the PAS. And if you do it in an open system, yes, there is a chance of infection.
Thank you.
Be sure to do it in a closed system.
Yes, sir, please.
Yeah, platelets are pretty notorious. Huh? So if the lot of bubbles and the color had changed, don't transfuse the platelets. So you have to do like that 3-4 times. You will see swirls. If swirls are there, that's a good quality platelet. There should not be too much of bubbling. If the color had changed to darker yellow or lighter or greenish, then return the bag and put a hemovigilance, whatever systems in the hospital. They are the most notorious to cause problem because they are at 22 degrees centigrade. There was a question, sir. Yes, sir.
Patients on palliative treatment, because palliative treatment also patients are living for prolonged periods. In those setup, earlier the instructions were not to give any transfusions. What are the present guidelines? Because now the palliative treatments are
Prolonged.
not like earlier. They're going on for quality of life and other aspects are going on because of addition of lot of drugs and treatments.
Agreed. Any comments from the experts? Palliative care, blood transfusion indication, not indication.
Until unless definitely in that setting we won't transfuse electively. Our routine cutoff for the hemoglobin is 7 gram until unless the patient has a coronary artery disease background or a CKD patient where we keep the cutoff as 8 grams. For a platelets, routinely 10,000 is the cutoff. Below that only we will transfuse.
I think quality of life is important. Palliation, sometimes they all go on for months even. And then if the hemoglobin is low, platelets are low, then it's a tough. I had a patient who was given transfusion for 6 months. The daughter-in-law came from Australia and said that now I'm frustrated by giving transfusions. Please don't keep her alive by giving transfusions. So we stopped it, and after 2 months she died. So you can have both situations.
So we also have an option of best supportive care for some patients, which is nothing but palliation. So basically those are palliative transfusions. So when it is needed, when it improves the quality of life, it probably should be given.
Yes, Suresh.
Again, we have moved from generous transfusion to restrictive transfusion, sir, because when you are transfusing for a child for palliative care, of course you do not see a lot of children for palliative because parents would want to do everything. We do see a lot of complications associated with unnecessary transfusions. They were generous saying 8, we wait till 5. Lot of children in our practice we see with 5.3, 5.4 nutritional anemia and these kind of things. We do not transfuse. We wait. Less than 5, we think about it, sir. Unless child is symptomatic, effort intolerance or unable to do their routine activities, we do wait till 5. Previously, when I started practice, anything less than 10 on ventilator transfuse. Now, guidelines are very clear, go towards restrictive transfusions.
We can even go maybe lower than 5 also for healthy children. I would go with 4 even. If they are walking in children, if they are walking around, if they are playing around and doing their daily work, I would probably go at even 4.
Agreed. Right now I have a child with 4.6.
Yeah.
We waited for almost 2 weeks, still around 4.5. So we are just trying to give oral and then wait because it's not affecting his life.
Tough to digest, but
my question is, if patient is in failure, severe heart failure, what about the blood transfusion rate? We give packed red RBCs. What should be the rate of transfusion?
so rate of transfusion
Severe
in
heart
the patient
failure,
of
severe
congestive
anemia.
cardiac failure.
Patient is severe anemia with heart failure.
Maximum 4 hours, sir. We are not more than 4 hours.
More than 4 hours.
Maximum 4 hours.
6 hours is
1 PRBC, maximum
So
4 hour
2.5
duration.
ml per kg per hour, something like that.
Approximate.
Should be 2.5 ml per kg per hour.
Depends upon the volume of the bag. If it is 300, 350, depends upon the source bag. How much is collected, how much is the packed, and then you give it. So not more than 4 hours. Generally, it's 2 hours, but not more than 4 hours. So slower is better.
What should be the interval between the each bag?
So 2 units per day. How many units can you transfuse per day? Is there a guideline? Generally, we accept 2 units, but I want the opinion from the experts in the crowd as well. Is there a guideline saying you can transfuse? Massive transfusions, we give 4, 5, 6, 8, 10 also. That's not a problem. Complete blood volume can be replaced within 24 hours. But for routine, generally we give 2. Now, why that 2 is because my professor was giving 2. And I never asked why 2, why not 3?
Sir, but
So
what should be the interval between the 2 bags?
So one in
Because
the
I
morning.
have seen many patients with severe death, pulmonary edema, and patient died immediately.
Sir, at least in pediatrics, I'll answer. Instead of the duration, we don't change the duration. We try to stick it to 4 hours because the longer you keep it, you are exposing the child to other adverse effects. What we do in children is we start with a lower alicot, 5 ml per kg. 5 ml per kg.
Per hour.
5 ml per kg.
Total
I
amount.
deal with tiny babies, like 10 kilos baby. 50 ml we transfuse, wait for another 24 hours. Maybe we increase the alicot to 7.5 ml per kg. Otherwise, in any other child for transfusion, if not severe chronic anemia, we do not want to change the balance. Normal volume is 15 ml per kg we go. But if it is a chronic problem, child is already compensated, we start with 5 ml per kg and maybe we give 24 hours gap and then increase the alicot. Dr. Sirisha might be able to add some more because she also deals with pediatrics.
So I'm pediatric hematologist in Rainbow Hospital. So the interval, the question you asked is like 4 to 6 hours between the transfusion to transfusion. But as you know, like it takes 4 to 6 hours at least for the hemodynamics to settle down. So usually that is the reason why we maintain the interval of 4 to 6 hours. But as you know, like most of the times you don't like to transfuse on the same day the second alicot. So indications are like wide. So if you are, as sir said, if you are giving 2.5 ml per kg per hour, the HB should be very low. Then only you go for that alicot. The transfusion rate should be that low. But if you are transfusing thalassemia child, it can be 5 ml per kg per hour also. It can be as fast as 5 ml per kg per hour because in thalassemia child you will be transfusing at 9. Your baseline is at 9. So going by that you can go for 5 ml per kg per hour. But if you are transfusing at 3, 4, the rate should not be more than 2 to 2.5 ml per kg per hour. And as sir said, like, you know, in nutritional anemia, one can go as low as 3. So even at 3 also, if the child is asymptomatic, we manage the hemoglobin on hematinics alone. Only if you want to raise the hemoglobin faster, one can go for the IV ion therapy also. But on the other hand, in an asymptomatic child with 3 also, as sir mentioned, we can go for the oral hematinics and then get away with the situation. So depends on the indication what you are looking at.
Same sir, HP of 7 is generally we put as the cutoff for adult patients. But if a patient had a CKD or if the patient had a background of coronary artery disease and any heart failure patients, we keep the cutoff of 8 grams HP for transfusion.
Cutoff they say 5 because we have so many.
If it is a nutritional anemia patient, we don't give any transfusion. Sorry sir? Sorry.
Elective nutritional deficiency.
We won't transfuse, sir. Only we will give iron supplements, or if it is a B12 deficiency, we will give only B12 supplement and we will wait for 1 week or 2 weeks for the hemoglobin to rise up. But we won't transfuse if it is a nutritional
Below 5 also will wait or will wait?
Wait,
It depends upon
It depends on the condition of the patient.
and the work the patient does.
If the patient is not having a
No, if patient is in failure because
Failure
of
is
anemia,
not-
transfuse.
So
Don't
if
wait.
the patient is, sometimes what happens, what I practice is that if the patient is not having any symptoms of the anemia, like if he is not having palpitations, not any chest pain, shortness of breath, none of those symptoms are there, then I can still wait at 5 or maybe a little bit less than 5 also.
The comment,
But
guidelines
if
say irrespective of cause, irrespective of etiology, hemoglobin less than 5. Again, we have to understand whatever nutritional deficiency, you give IV iron, the normalization of hemoglobin takes 2 months. Irrespective of oral or IV, because number of RBCs getting hemoglobinized per day, irrespective of your route of administration, is going to be same. So normalization of hemoglobin takes 2 months, and the complete symptomatic relief takes much time. So practically, if you see the guidelines, hemoglobin less than 5, and as Dr. Tutsi mentioned, anybody whose hemoglobin is less than 5 will have all the symptoms of severe symptomatic anemia, plus or minus congestive cardiac failure. So as per the guidelines, as sir mentioned, I think 5 hemogram
we
hemoglobin
can
is the
actually.
Maitri madam, you want to add comment, madam?
No, basically in iron deficiency anemia, since it occurs gradually, progressively over years, over months, so even you will find patient has come to you with 4 gram of hemoglobin, but the patient is not symptomatic. So if you ask me, then I go by that. If the patient is not symptomatic and it's a deficiency anemia, then I put the patient on supplement, iron or vitamin, whatever is that. But if the patient is symptomatic, then whatever is the hemoglobin percentage. Even sometimes the patient say at 7, 6.5 also they say I'm getting dyspnea on exertion, like that. So in those cases I go for transfusion. But if the patient is asymptomatic, then I depend on the supplement. But as Dr. Ganesh said, obviously it takes time. In that case, I request patient, you will have to take bed rest or rest at home for minimum 3 weeks. Before it takes minimum 3 weeks to increase the hemoglobin to 2 gram%. So if the patient agree for that, then only I go for supplement. Otherwise, I give transfusion.
Ma'am, there is another problem that we face sometimes, like if say a 40-year-old male comes with a hemoglobin of 5 and he is having a very mild symptoms, maybe almost 0 to nil symptoms. Now we are considering that whether we'll do a colonoscopy or not in that patient. So sometimes even if the patient is not symptomatic, the gastroenterologist will not do the colonoscopy unless the hemoglobin is at 8 or 9. So for that, maybe, because that is a more of an emergency, because we cannot wait for 2 weeks or 3 weeks for the hemoglobin to rise to 7 when we can do the colonoscopy. So in that case,
the rationale, Tushti, is there has to be a contrast to be seen where the blood is leaking.
Yes.
If the mucosa and the leaking point are of the same color, you will not see anything.
Right.
So mucosa has to be paler than the blood leak. For that, the HB has to go up to 8. Then
Yes.
only you can see the difference.
So
on
in
scopy.
that case, so we have
Why
to,
they
we have
insist
to
on
give
that.
the transfusion,
Yes,
because we cannot
definitely.
wait for 3 weeks for the hemoglobin to rise and then do the colonoscopy.
Definitely. So how many units per day? Next question. How many units per day maximum you can give?
We're going with 2 units.
2
We can-
units.
yeah.
And what is the duration maximum for 1 unit?
4
in
hours.
adult?
There's no
Maximum
other
4
numbers,
hours.
yeah.
Has that
cannot
answered the question? Answered. So I don't think we can take any more questions. Yes, Nageshwar.
Hello. Many scenarios like patients on dual antiplatelets or something coming for major surgery, it's an emergency surgery. Do we need to give any prophylactic platelet transfusions before the surgery, or we can wait, if it bleeds we can transfuse?
So prophylactic platelet transfusion on a patient of antiplatelets planned for an emergency surgery. Emergency surgery, I don't know whether we can reserve platelets. Aspirin takes 5 days for the action to go away, and it's a permanent action.
Yeah.
So if it's a cranial surgery for that matter, probably you give.
Yes.
I'm not sure.
Reserving the platelets is important, and doing like sometimes procedures on flow of platelets.
I give it in neurosurgery cases. I think we should keep a low threshold of giving, at least the neurosurgery cases.
Right. Immediate neurosurgery, whenever it's needed, we used to release 6 platelets to keep that cutoff. The procedure planned in emergency like EVDs.
You reserve the platelets, and if the bleed occurs, then transfuse. But reserve, because we never know what is inside. So I think we end the session. Over to chairpersons.
Thank you so much, Dr. Bhave, and thank you all the esteemed panelists for having such a wonderful discussion. It has been a day full of education and learning. It was a very enthusiastic crowd and very eminent physicians and pediatricians over here. I thank the organizers for giving us an opportunity to be here and attend this conference. Thank you so much, and I hand it over to the organizers.
I thank all the chairpersons and speakers, and I kindly request everyone, chairpersons and speakers, to collect their mementos at momentary desk next to the photo booth. And now it's time to relax and network over gala dinner at Kaveri Ballroom,